Miss Nikita, can we start? Anybody from the technical team is over here?
Yes, ma'am.
Can we start?
Yes, ma'am. Give me 2 minutes.
Okay.
Yes, ma'am. We can start now.
Okay. So the first presentation would be there by Dr. Anju Yadav, Association of Serum Vitamin D Level with Late Onset Sepsis in Neonates. Dr. Anju, please be up to the time. We just have 5 minutes for you.
Yes, ma'am.
Please share screen for her.
Can I start, ma'am?
Yes, please go ahead.
Good afternoon, everyone. I'm here to show the study on association of serum vitamin D level with late onset sepsis in neonates. As we know, neonatal sepsis is an important cause of morbidity and mortality in neonates. It is estimated to cause 25% of total neonatal death worldwide. Late onset sepsis is presentation of sepsis after 72 hours of life in neonates. Recent studies have shown that the vitamin D is a key modulator of immune function. Vitamin D exerts its effect on functioning of innate immune system via its effect on antimicrobial peptide induction in epithelial cells, neutrophils, and macrophages. All cells of immune system have been shown to exert have been shown to exert the vitamin D receptors. So antimicrobial peptides like cathelicidine and beta defensin 4 transcription is dependent on sufficient vitamin D levels. Several studies have been demonstrated a link between vitamin D deficiency and lower respiratory tract infection. So there is an emerging relationship between the vitamin D levels with sepsis and supplementation with vitamin D leading to decrease in sepsis. So this study was done to see its deficiency association with late onset sepsis. Objectives were to study the association of serum vitamin D level with late onset sepsis and to study the association of maternal serum vitamin D levels with neonatal serum vitamin D levels and to study the association of vitamin D level with mortality in late onset sepsis. So this figure is showing the correlation of neonatal serum vitamin D level in study groups. So it was observed that under cases 40% patients were deficient and under controls 20% patients were deficient. And in maternal serum vitamin D level in study groups, it was observed that under cases 53% mothers have insufficient vitamin D level, whereas in controls 32% mothers had insufficient vitamin D levels, and 50% mother in control group had sufficient vitamin D levels, and 28% mothers had sufficient levels in sepsis group. So the study also studied the variation of vitamin D level in both groups with season of birth. So it was observed in that in winter season, mean vitamin D level in cases was 13.57 nanogram per ml. For controls, it was 20.81 nanogram per ml, which was significantly lower as compared to spring and summer seasons. So it was concluded that lower vitamin D levels in mother and their neonates were associated with increased risk of late onset sepsis. So limitations were that key outcome parameters between vitamin D sufficient and vitamin D deficient neonates were not assessed. Ma'am, can you show the abstract also so that can I add additional points?
Can we have the abstract also? I think it is very difficult from our end to have your abstract right now.
1 second. We are displaying 1 second, ma'am.
Yeah, in the study, 38 neonates were died due to sepsis, which was 23.8%. And in died neonates, the serum vitamin D level was 13.93 nanogram per ml, which was significantly lower as compared to discharged septic neonates, which was 23.3 nanogram per ml. So in conclusion, we have that it was found that the lower vitamin D level in mothers and their neonates were associated with increased risk of late onset sepsis, and neonatal vitamin D level were correlated with maternal vitamin D level. So adequate vitamin D supplementation during pregnancy can be helpful in preventing vitamin D deficiency, thereby preventing the neonatal sepsis. So vitamin D deficiency was more frequent in culture proven sepsis in this study, and the prevalence of vitamin D deficiency in mothers and their neonates were very high, predisposing to number of morbidities in neonates. Thank you, everyone.
Ajay sir, please.
Thank you. This is Dr. Ankur. Thank you, Dr. Anju. Well presented. I think first we have to decide that whether it is a biologically plausible or not. Could you please explain that? Is it biologically plausible that vitamin D deficiency can lead to sepsis?
Yes,
Doctor?
sir. It was a biological plausible. It has effects on immune system. It has immunomodulatory effect, and it induces the antimicrobial peptides. So cathelicidin protein and beta defensin are totally dependent on vitamin D level for their function.
What was the mean gestational age and mean birth weight of your population? Please explain it.
Yes, so mean gestational after the 72 hours of life at day 4 for 37 weeks. Most of we included the term and preterms both. Preterm gestation was more included, preterm neonates in this study. 60% were preterms and 40% were term neonates.
Just tell me, what was the mean gestational age and what was the mean birth weight?
Sir, mean birth weight in the study was came out to be 2.46 kg, and the mean gestational was the 37 weeker.
So I think even in 37 weeker, I mean, if the baby is term and the good weight baby, you don't expect any infections. I mean, late onset sepsis is not that common. So in your group, the babies were slightly bigger. And second question, you calculated vitamin D as a mean vitamin D level. So when we calculate mean value, when we calculate median value?
Sir, for comparing the both groups, we calculated the mean, and for in different just we compare the culture proven sepsis in different cultures.
You didn't get my point. So have you heard about interquartile intervals?
So no, I don't
it's
have.
okay. Fine, dear. Thank you. Thank you.
Okay.
Thank you, sir.
Dr. Anju,
Yes, sir.
were the mothers on regular vitamin D supplementation?
No, sir. Mother were not on vitamin D supplementation.
Okay. Or calcium supplementation?
Sir, there was not adequate. Some mothers were taking calcium, but not all mothers were taking calcium.
Okay. Because we need to ensure that gynae department also does its jobs and prescribes them regular vitamin D if you find the mothers to be deficient.
Yes, sir. If they supplement calcium and vitamin D in antenatal period, so sir, it can helpful in
Thank you.
Success.
I'll comment, Dr. Anju, that both of your values of vitamin D were very low. Whether it was 13 or 21, you said that there was a significant difference, but I feel that both the values were very low. So I don't know how much is this difference of values turned into a clinical difference, because I feel even a figure of 23 or 25 is also low. So I think that is also significant. So that finishes with the first, you finished with both the poster as well as the abstract, Dr. Anju, I guess?
Yes, ma'am.
Okay, so we can move to the next presentation, Ajay sir.
Yes, sir.
Okay, so next presentation, we move to Dr. Neeraj Kumar, very low birth weight neonates in a tertiary level NICU with minimum invasive ventilation strategies. So please go ahead.
Good morning, ma'am, and I'm Dr. Neeraj, fellow in Department of Neonatology, Fortis Hospital, Shalimar Bagh. My study is outcome of extremely low birth weight and very low birth weight neonate in a tertiary level NICU with minimal invasive ventilation strategies for management of RDS. In introduction, there is evidence that new method of non-invasive ventilation support has significantly changed RDS management in preterm neonates. This study evaluates the outcome of VLBW and ELBW babies with minimal invasive ventilation strategy for management of RDS. And it was a retrospective observational study to measure outcome in terms of discharge and death. Material and method used was patient data was collected from March 2020 to October 2020 in Fortis Hospital, Shalimar Bagh. Nasal CPAP was started as first-line management for RDS in both ELBW and VLBW neonates soon after birth. Initially by new puff in resuscitation room, either in OT or labor room, and after that bubble CPAP started in NICU. Surfactant was given only if neonate required high FiO2, that is more than 40%, and high P, or developed increased work of breathing. Surfactant administration was done by INSURE technique. Ventilation support, conventional or high frequency, was given only in case of CPAP failure or respiratory failure. Going to the results, total 48 neonates, including ELBW and VLBW neonates, were admitted in NICU from March 2020 to October 2020 in our hospital. Out of 48 neonates, 29 were ELBW and 19 were VLBW neonates. Overall discharge rate was 85.41%. That is, 41 out of 48 was discharged. Discharge rate for ELBW babies was 86.2%. That is, 25 out of 29 was discharged in ELBW group, and discharge rate for VLBW was 84.2%. That is, 16 out of 19 was discharged. Overall expiry rate was 6.25%. That is 3 out of 48. There is expiry rate 3 out of 48. Expiry rate for ELBW was 6.89. That is 2 out of 29. And expiry rate for VLBW babies was 5.26%. That is 1 out of 19. Out of these 48 babies, only 15 neonates, that is 32% neonates, require surfactant. In which 37.9% was ELBW, that is 11 out of 29, and 25% was VLBW, that is 4 out of 19. 24.5% neonate, that is 12 out of 48 neonates require ventilatory support, in which 34.4% was ELBW, that is 10 out of 29, and 12.5% was VLBW, that is 2 out of 19. Culture proven sepsis was found in 8.3% of neonates, that is 4 out of 48, out of which 5.2% of VLBW and 10.3% ELBW. In conclusion, my study concluded that early initiation of CPAP reduces the need of surfactant administration and ventilation requirement. As in my study, a total of 48 cases was included in a study, and only 15 neonates, that is 32%, require surfactant, and out of which only 24.5% require ventilatory support. So, early initiation of CPAP reduces the need of surfactant administration and ventilation requirement in both VLBW and ELBW neonates. This study correlates with the earlier study that was conducted by Morley et al. In 2008 and Finner et al. In 2010, which was a multicentric RCT. Thank you, ma'am. Thank you, sir.
Thank you, Neeraj. Well presented. So it was a retrospective study. So so what was your classification for CPAP failure? When did you define that baby is not tolerating CPAP or CPAP is failed? Because in your methodology, it was...
Yes, sir. We started all newborn with minimal, with few episodes of apnea or Downey score more than 4. We started on initially started on CPAP. But if FiO2 requirement on CPAP is more than 40%, then we will go to surfactant administration by INSURE technique. And
so all of the neonate would be given surfactant through INSURE technique, not by any other non-invasive technique.
No, sir, by INSURE technique. If we are giving surfactant, we will give by the INSURE technique.
So have you heard of the word INREXURE? INREC. INREXURE.
इधर बैठ जाता हूँ
Good afternoon, Pankaj sir.
What, sir?
I think
all right, good.
Dr. Neeraj.
Ji, sir.
Have you heard about Lisa or Miss technique?
Leisure, sir. Yes, sir. Less invasive surfactant administration.
So now in very low birth weight, it is considered to be
Yes, sir.
one of the
It is
standard of
concerned
care
in our hospital. We are giving only by the
in regular. So even in a CPAP, or as you told that you tolerate FiO2 till 40%, still your requirement for surfactant was just 24%. I mean, probably 32% in all the group of infants.
yes,
So
sir.
don't you think that your baby, you were, I think it was a number is showing slightly lesser as compared to standard data.
Sir, in our hospital, this is the real data, and we will start, sir, CPAP very early. And in OT or labor room, we start by the new puff, by resuscitation by the new puff, and after that, we shifted baby to NICU. And very early, we started if there is few episode of apnea, or if there is Donnie's scan more than 4, we will start CPAP. So
Why I'm asking you, because your data is showing that your 32% of the neonate required surfactant. As you
yes, sir.
told me, the surfactant was given by insure technique. That means 32% of the infant required intubation and ventilations. However, you wrote that 24% neonate required ventilatory support
Yes,
only.
sir.
Why?
After giving insure, we will extubate the baby and put on CPAP only.
Okay, that's why you took that.
Ventilator is not required, sir. Yes, sir. Out of 32%, only 24.5% baby require ventilator support.
Okay, thank you.
Okay, sir. Thank you, sir. Thank you, ma'am.
Thank
So
you.
we can move. Yeah, okay. So we can move to the next case.
Yeah.
The next presentation is by Dr. Arom. Is that Dr. Aromita?
Dr. Neeraj, please mute yourself.
Okay, sir. Sir.
Romita was done yesterday.
Okay. I think I have the old list. So we can move to the next presentation by Dr. Bharti, clinical and hematological profile of pediatric patients with cleft palate and lip in a tertiary care hospital of Haryana. Dr. Bharti, please. Dr. Bharti, can we mute everybody else except Dr. Bharti?
Dr. Hema, please explain the timing to the.
Okay. Dr. Bharti, you have 5 minutes. It is 12:45, so you will end by 12:50, and there'll be 5 minutes 1 minute for interaction with the judges.
Okay. Good afternoon, ma'am.
Yeah.
Good afternoon, sir. Topic of my abstract is clinical and hematological profile of pediatric patient with cleft lip and palate in a tertiary care hospital of Haryana, India. The study was done in SGT Medical College Hospital and Research Institute. Uh, Background, cleft lip and palate is the most common visible craniofacial anomalies. The incidence of clefts in India is around 1 is to 800 to 1 is to 1000. The etiology is complex, involving polygenic inheritance and various environment influences. These patients often have feeding difficulties and recurrent infections, leading to an altered immune system, which can be assessed by the variation in hematological parameters. My objective of the study was to assess the clinical profile and the hematological parameters in patients with cleft lip and palate. Uh, the study was conducted over a period of 18 months from May 2019 to October 2020.
Dr. Bharti, please go ahead. Technical team, please mute everybody else.
Total of 115 patient data was collected, recorded, and evaluated. All patients with cleft lip and palate between the age ranges from birth to 14 years of either gender who visited pediatric unit for complete evaluation before surgery were included, and the patient who are associated with any syndromes are excluded. Patients not suffering from any chronic systemic illness were also included. The following information of the patient was recorded like age, gender, and type of cleft, which was either an isolate cleft lip with alveolus, cleft palate, or combination of both. Data of cleft type was documented according to the Carnahan's and Stark's classification. The patients underwent complete blood count analysis, and the hematological parameters assessed in the study included hemoglobin, total leukocyte count, differential leukocyte count with analysis of absolute neutrophil count and absolute eosinophil count. Data was analyzed using statistical methods. SPSS 20 software was used to analyze the data, and p-value less than 0.05 was considered significant. Results. A total of 115 were included in the study and statistically analyzed using the SPSS software to correlate the values of statistical significance by doing chi-square method. Out of 115, 66 were male and 49 cases were female. This study included 36 patients with cleft lip and alveolus, which comprised 31.3% of the total, and 49.6% with cleft lip, alveolus, and palate, and 19.1% with cleft palate only. 52.2% of the total cases showed a raise in TLC count. The parameter is statistically significant because the value was 0.041. 5.2% of the total cases showed an increase in eosinophil count. 25.2% of the total cases showed an increase in lymphocyte count and was statistically significant. 71.3% of total cleft cases showed a decrease in hemoglobin level and was significant. Discussion compared to normal values in cleft individual, there was increase in parameters like total leukocyte count, which was in 52.2% cases, eosinophil count, which was in 5.2% cases, lymphocyte count, which was in 25.2%, and there was decrease in hemoglobin, which was in 71.3% of the cases. So the patients with untreated orofacial cleft showed considerable alteration in hematological values compared to the normal values. Anatomical defect leading to increased risk of infections and difficulty in feeding may act as the contributing factor for such variations. Thank you.
Dr. Ajay, you can ask questions, please.
Yeah, Dr. Bharti, do you think all these problems related to hematological parameters were related to the cleft palate only or to their nutrition profile? Like they were on mainly on the milk, their diet was different, like they were only on milk or
Yes.
on different diets?
No, so most of them, if the age is less than 1 year, the babies were on just on milk. But if the age is more than one, then they were also other feeds were also included. Nutritional findings were also there. But most of the patients were iron deficiency anemia.
Were they on any kind of nutritional supplements?
No, sir.
Okay.
Any more questions, Dr. Ankur?
Thank you.
Okay, I think he's not there. So we
No,
can
no,
move
I'm
to the-
here. No, it's continue. Continue, please. I'm looking for one judge.
Okay, that's good. Thank you so much. Okay, so we can move to the next presentation. So for the next presentation, we have Dr. Sanasam Manimukta Singh. Okay, can you introduce your topic and yourself? Please start your presentation.
Good afternoon. Good afternoon to one and all. Hello, am I audible, sir?
Yes, you are.
Good afternoon. Please carry on.
Good afternoon. Today, my topics on study of magnetic resonance imaging (MRI) of a brain in children with cerebral palsy and its correlation with the type of cerebral palsy. Introduction: cerebral palsy is a diagnostic term used to describe a group of permanent disorder of movement and posture causing activity limitations that are attributed to the non-progressive disturbance in the developing fetal and infant brain. It's the most common. It is the most common childhood physical disability that presents a group of conditions with heterogeneous symptoms which are characterized by deficient motor control, spasticity, paralysis, and other neurological disturbances that emerge before, during, or in short time after birth. The overall prevalence of CP is approximately 2 per 1,000 live birth. The prevalence of CP is far higher in the preterm compared with the term infants and increases with decreasing gestation age and the birth weight. Cerebral palsy affects a huge number of children in India. The prevalence of CP in India is in the range of 1.5 to 2.5 per 1,000. Aim of the my study is that to evaluate the brain MRI finding in the children with cerebral palsy and to correlate it with the type of cerebral palsy according to clinical diagnosis and to correlate with the GM-FCS classifications of cerebral palsy. Study design is a cross-sectional study. It's a period for 18 months. and the samples were taken from the this one 4-day 2 to 18 years, which are attending pediatric orthopedic and physiotherapy OPD. Inclusion criteria were all the clinically diagnosed cerebral palsy patients of age group from 2 to 18 years of age attending the pediatric OPD and physiotherapy OPD. The exclusion criteria were the children with the history of regression of milestone, second, neuroimaging suggestive of metabolic disorder, and children with inflammatory brain disease such as meningitis, encephalitis, and intracranial space occupying lesions like brain abscess, tuberculoma, neurocystic sarcosis, and neoplastic lesion. Result is the bar chart which showing the percentage of children according to the pattern of brain involvement on MRI scan. In this study, we found that the commonest MRI diagnosis was the spastic, leukoventricular leukomalacia, periventricular leukomalacia, and about 40%. The maximum correlation of brain MRI diagnosis with clinical diagnosis was noted with ataxia, it's about 100%, followed by the spastic hemiplegia. And the difference in the proportion of MRI abnormality across the GMFCS level was statistically insignificant, as indicated by the p-value of 0.589 by using the Fisher-Exact test. Conclusion: in this present study, brain magnetic resonance, this MRI finding in children with the cerebral palsy, and to correlate with this study, we conclude that the majority of the children were of spastic diplegia, that is about 36%, followed by the spastic quadriplegia, and third by the spastic hemiplegia. And the commonness of MRI diagnosis noted was periventricular leukomalacia, that's 40%. It's followed by the cystic degeneration. And the third, the difference in the proportion of MRI abnormality across the GMFCS level was statistically insignificant, as indicated by the p-value of 0.58. And overall, the MRI is a better diagnostic modality which helps to detect the abnormalities in the pattern with the cerebral palsy, which helps in understanding the causal pathway in CP. Thank you so much, sir.
Thank you, Dr. Sanasam.
Thank you, sir.
Was the physiotherapy or occupational therapy or the management modality changed with the MRI findings?
Sir, actually, I did not do study on this one, sir, but my study was on to just on this one clinical and MRI, sir.
Okay, so who paid for the MRI?
Sir, MRI was this one, sir, done from the it's an institutional ethical research committee, sir.
The institute paid for the MRI or the parents paid for the MRI?
Sir, most of them, sir, MRI was done by parents also, but actually for the better prognosis and for the further this one management, so we have done the MRI, sir.
No, you are saying better management, but was the management changed after the MRI?
No, sir, not at all, but for the prognostic factor, sir.
Okay, right. Thank you.
Yeah, actually, we all know that the standard MRI changes which we have in terms and preterms. So, did your study reveal anything else? We all know that in term children we have morocystic encephalomalacia, whereas in preterms we have periventricular leukomalacia. So, I think the same is the conclusion of your study, or you have some other conclusions?
No, sir. No, ma'am. Most of them find is the periventricular leukomalacia, sir. 46, that is 61% of the my study comes out to be a periventricular leukomalacia.
Because preterms were more included in your study population also, I think, because of that.
Actually,
so,
ma'am, yeah, yes, ma'am.
Okay. So I think the questions. Any more questions, or we can move to the next?
Yeah, so I have one questions with Dr. Sanasam. Well presented, Dr. Sanasam. So why you call it as a cross-sectional study?
Sir,
why not observational? Why it is a cross-sectional descriptive study?
Sir, actually, it was done for the sir.
But looking at the methodology, it doesn't look like it's a cross-sectional study.
So it was just to correlate with the MRI finding and with the clinically what we diagnosis. So it was in the period of
that is not cross-section. Okay. So the next question. So in your objective, you have written it to correlate brain MRI with GMFCS. But in the outcome, you have presented it like a spastic and ataxic. You have never defined it as a level 1, level 2, level 3 like GMFCS classifications. Why
Yes,
it's
sir.
like that? Because it was not matching with your methodology.
Yes, sir. In the result with the third para, sir, I have written in the difference in the proportion of MRI abnormality with the GMFCS level, sir. In this, we have an insignificant, statistically insignificant, sir, 0.58 in comparisons with.
Okay, thank you.
Thank you.
Thank you, sir.
So now we move to the next presentation. The next presentation is by Dr. Dipali Malviya. Parameters after using 9% normal saline as maintenance IV fluid in non-critically in all hospitalized children.
Good afternoon, everyone. Am I audible, ma'am?
Yes, you are very much.
Good afternoon.
Okay. Good afternoon, everyone. Myself, Dr. Dipali Malra. I'm presenting my research topic with the title having change in the clinical and biochemical parameters after using 0.9% normal saline as a maintenance intravenous fluid in non-critically ill hospitalized children. As we know that the maintenance IV fluid required in the hospitalized children was previously used based on the Holiday-Seger formula, and but it was hypotonic. So, in current clinical guidelines, they have recommended to use isotonic fluid as a maintenance IV fluid after so many meta-analyses and systemic reviews who compared hypotonic versus isotonic fluids as a maintenance IV fluid. So the current guideline that are American Academy of Pediatrics guidelines and NICE guideline, they have recommended isotonic fluid as a maintenance IV fluid in all pediatric patients. But they are concerned associated with this isotonic fluid, which is 0.9% sodium chloride, that it may be associated with hypernatremia, fluid overload, or hyperchloremia. There were some studies which documented increase in mean serum sodium level, but it was not in the hypernatremic range. Regarding fluid overload and hyperchloremic metabolic acidosis, there were some studies which reported also hyperchloremic metabolic acidosis, but those studies were done in adult population or in critically ill patients, which require resuscitation fluid as well. So we don't know clearly that this effect of hyperchloremic metabolic acidosis is due to maintenance IV fluid or due to resuscitation fluid volume. So I have done this study in non-critically ill general pediatric patients to assess the biochemical effects of 0.9% sodium chloride as isotonic maintenance IV fluid in general pediatric patients. So my primary objectives uh, uh, to to see the change in serum sodium and chloride from baseline at 24 to 48 hours of starting fluid, and to see the incidence of hyperchloremia and metabolic acidosis after 24 and 48 hours. My secondary objectives was the to find out incidence of hyponatremia and hypernatremia among those patients. I have done this study in the children age group of 2 months to 12 years admitted in pediatric ward and emergency and requiring maintenance IV fluid for at least 24 hours. So this study was done in these patients and the children which were having hyponatremia, hypernatremia, metabolic acidosis, or dehydration shock, or who required PICU care have been excluded initially from this study, and then serum samples was taken at baseline 24 and 48 hours for for measuring electrolyte as well as for venous blood gas analysis. As a result, we have screened 1920 children requiring admission. Finally, 250 children were analyzed and enrolled in this study. The mean age of this study was 3.7 years, and the major etiology for admission was CNS infection and seizure, and second was pneumonia. The results were showing in this table that the change in there was a significant change in mean serum sodium level from baseline to 48 hours. That is, p-value was 0.017, but it was not associated with clinically significant hypernatremia. but there was significant change in serum chloride level also from baseline to 48 hours and among three values, as well as significant change of serum bicarbonate level from baseline to 24 hours as well as at 48 hours. So the conclusion of that study is 0.9% sodium chloride as a maintenance IV fluid in non-critically ill pediatric patient does not cause any significant change in serum sodium level or blood pressure, but it leads to significant increase in serum chloride levels leading to hyperchloremia and metabolic acidosis, which may adversely affect kidneys and renal outcome. As a large number of children requiring maintenance IV fluid, magnitude of this effect can be considerable. Thank you so much.
Ajay sir, please.
Do you think this will be clinically significant, this hypochloremia?
No, sir, this hyperchloremia was also not clinically significant, but sir, but the children we have taken were non-critically ill. So, sir, our assumption is that, but it can be detrimental in critically ill patient also.
Okay, thank you.
Dr. Ankur, you want to ask
Yeah, Dr.
anything?
Dipali, well presented. So can you explain me what do you mean by confidence interval?
Yes, sir. Sir,
What do you mean by confidence interval?
sir,
Okay, so what was the mean age of your patient? As you told, 3.7 years, no?
yes, sir. Sir, mean age was 3.7 years, sir. I have
What
taken,
was the standard deviation for that?
sir, plus minus 3.2 years, sir.
Okay, so what do you mean by standard deviation?
Sir, standard deviation, sir, plus, sir, it can be, sir, 2 years plus or 2 years minus, sir. So, sir, and
Okay.
sir, yes, sir.
So to check the difference in the two groups of the patients, what type of test you apply for that continuous variables?
Sir, for change in difference, sir.
Yeah,
Sir,
look for the difference whether it's a significant or not. Have you
sir,
heard about student t-test or chi-square test?
yes, sir, chi-square test, sir. Yes, sir.
So chi-square test.
Yes, sir.
Okay. Okay, thank you.
Okay, so we move to the next presentation. Do we have Dr. Ritu Aparna over here? Dr. Ritu Aparna, I think she's not there. We can move to the next presentation. Mohammad Habibul. Do we have Dr. Mohammad Habibul?
Yes, ma'am.
Okay, so you can start with your presentation. It is a case report on Duchenne muscular dystrophy. Please go ahead.
Am I audible?
Yes,
Yeah,
yes.
good
Please go
afternoon.
ahead.
Please continue.
Hello.
Please go ahead. We are all listening.
Good morning, good afternoon, everyone. Myself, Dr. Habibul from Katyar Medical College, presenting case report of Duchenne muscular dystrophy. DMD, it is a severe progressive neuromuscular disorder which belongs to a group of inherited conditions resulting from mutation in the dystrophin gene. It is an X-linked recessive disorder. The affected gene is at the chromosome XP21 locus, and it is one of the largest gene. DMD is the most common dystrophinopathy, more common in boys. Incidence is 1 in 3,600 live born infants, boys. It is typically characterized by progressive muscle weakness, intellectual impairment, hypertrophy of calf muscles, and proliferation of connective tissue, progressive fibrosis of muscle. Early gross motor skills are achieved at the appropriate age, and mild hypotonia will be present. The case report, a 13-year-old male patient, 35 kg, born out of non-consanguineous marriage, presented with complaints of progressive muscle weakness in all 4 limbs since 4 years. Initially started with the proximal lower extremities weakness, causing difficulty in walking, climbing stairs, which rapidly progressed to complete non-ambulation. Hypertrophy of calf muscle was present, and with contracture were present in ankles of both limbs. Early gross motor skills were achieved at an appropriate age. No history of similar complaints in the family, and no complaint of color blindness. Clinical examination, patient was alert and well-oriented. Average build, higher mental function was intact. Cranial nerve examination was intact. Sensory system was intact. On motor system examination, bulk, mid-calf bulk was increased in both lower limbs. Power decreased in all limbs. Tone was decreased in all limbs, and deep tendon reflex was decreased. Coming to the investigations, the serum creatine kinase was 5,708 international unit per liter, and complement C3 was 1.0.9 gram per liter. On EMG, the myopathy disorder was involving both upper limb and lower limbs was present. Nerve conduction study was normal. On muscle biopsy, both atrophic and hypertrophic muscle fibers seen, and some muscle fibers were degenerated. Increased connective tissue between the muscle fibers. And on the coming to this rare X-linked recessive disorder due to the mutation in dystrophin gene. The male more than the females, and incidence is 1 in 3,600 live born infant was. DMD is the most common of all dystrophinopathies with poor prognosis. Muscle weakness is the principal of the symptoms of DMD. It can begin as early as 2 to 3 years of age, first affecting the proximal muscle and later affecting the distal muscles. Affected child initially experience difficulty in walking, running, climbing stairs. Later it progressed to the complete ambulation. Other symptoms include atrophy of calf muscles, lumbar lordosis, and waddling gait. Later on, heart and respiratory muscle are affected. Progressive weakness and scoliosis result in impaired pulmonary function, eventually causing acute respiratory failure. The mainstay of treatment is multidisciplinary approach and rehabilitation. Thank you.
Thank you, Dr. Habibul. Good presentations. So why muscle biopsy were done in this case? I mean, muscle
biopsy was done because hello.
Yeah, why muscle biopsy and ultrasound were done in this case?
Ultrasound was done for the fatty generation of in calf muscle, and muscle biopsy to prove the diagnosis.
So what is the diagnostic criteria for Duchenne muscular dystrophy?
So there should be in muscle biopsy endomassial connective tissue proliferation and scattered degenerating and regenerating myofibers.
Okay.
And CPK level should be raised more than 10,000.
So that's why I'm asking you that in your case, CPK level was not very high. It's in the range of just 5,000. So have you screened other family members of these patients?
Yes, sir, I was screened, but
Because
they said there is no history in family. So I thought it could be the mutation, race mutation, or maybe only the carrier in the family.
So that's why genetic analysis should have been done rather than doing muscle biopsy, because the CPK level is not very high and there is no family history. It's just an index case. So at least in this type of case presentations, you should have a family pedigree chart. So you didn't add it any pedigree chart in this case report. Okay, anyway, good presentation. Thank you.
Thank you so much.
Ajay sir, any questions from your side?
Thank you.
Okay. Was there anything atypical in your case? Because we all know Duchenne muscular dystrophy presents with muscular weakness and all. Everything was typical. So I would just like to ask, was there anything atypical in your case? I think he has left. Okay. Mr. Habibul, are you there? I think he has left. Okay.
Yes, ma'am.
So is there anything atypical feature in your case? Okay, I think we can
let's move to other.
Okay, so the next presentation is by Dr. Kumar Sanjeev. babies of hypothyroid mother delivering at a tertiary care hospital. Dr. Kumar Sanjeev. So you have next 5 minutes.
Good afternoon to everyone. Myself, Dr. Kumar Sanjeev. Today my topic is to study the prevalence of hypothyroidism in babies of hypothyroid mother delivering at a tertiary care hospital. Congenital hypothyroidism is a common congenital endocrine disorder in infants and one of the common preventable causes of mental retardation. Incidence vary from 1 in 3,000 to 1 in 4,000 neonates. In India, prevalence reported was 1 in 2,640 in 14,000 neonates. Neonatal screening is considered best way to detect congenital hypothyroidism in children. Congenital hypothyroidism affects growth and neurodevelopment and outcome is reversible and treatable. Aims and objective to study the prevalence of congenital hypothyroidism in babies born to hypothyroid mothers delivering at ESI Hospital Basai Darapur and neonatal outcome in terms of growth and development till 6 months of age. Material and methods. A prospective observational longitudinal study was done to include 63 newborns born to hypothyroid mother. Mother was assessed for hypothyroidism, followed by assessment of baby in terms of Apgar score, birth weight, head circumference, length, and thyroid profile done at birth and at 2 weeks of age and again at 4 weeks. If thyroid profile was abnormal, baby was assessed at 6, 10, 14 weeks and 6 months for clinical anthropometry and developmental assessment. Result: out of total 63 newborns, none of the neonates born to hypothyroid mothers had congenital hypothyroidism. In our study, most of the mothers, 58.7%, started thyroxine therapy during second trimester, followed by 22.2% who were started during first trimester, and all had regular follow-up with good compliance to treatment prescribed. Out of total 63 babies, 23 had birth weight less than 2.5 kg. 40 had birth weight between 2.4 to 4 kg. In our study, prevalence of transient hyperthyroidropenia born to hypothyroid mother was 4.8% at 3 to 5 days after birth. Only 2 neonates had PSH level greater than 10 milli-international unit per liter on day 15, and none of newborn had PSH greater than 10 milli-international unit per liter at 4 weeks of age. No significant association was found between maternal TSH and newborn TSH level. On follow-up, newborn had normal growth and development. Our conclusion: no case of congenital hypothyroidism was detected in our study among newborn born to hypothyroid mother. However, transient elevation of TSH was present in 5 babies, which improved by 4 weeks of age. Baby born to hypothyroid mother who were timely diagnosed antenatally and received regular treatment and follow-up had favorable neonatal outcome with normal growth and development till 6 months of age. However, our sample size was small. This has to be replicated in larger trials. Thank you.
Thank you, Dr. Sanjeev.
Yes, sir.
Well presentations. So, two questions. So, how did you define hypothyroidism in mother?
The hypothyroid by chemical feature and laboratory study.
No, in mother. So, in your aims, so as per your aims and objective, so you want to, hello?
It's detected during gestational age.
So that's why I'm asking you, what was the criteria for diagnosis of hypothyroidism in mom? Okay. So
During
so how many of the out of 63 neonates, how many of them are preterm and term infants?
preterm, sir,
Because you in your description it was shown that out of 63, 23 had birth weight of less than 2.5 kg. So how many of them are preterm and how many of them are were term infants? Because the diagnostic criteria would be different on different day. So have you repeated any sample for TSH and free T4 in preterm or late preterm group?
yes, no, sir.
Okay, thank you.
Hello. Hello, Dr. Sanjeev.
Yes, sir.
Was there any study done on the antibodies in mother? TPO antibodies or
No antibody found, sir. It was during antenatal visit. So report mostly mother had previously report not bring.
okay, thank you.
So now we quickly move on to the next presentation by Dr. Chetan. Effect of kangaroo method care on retinopathy or prematurity in neonates less than 1800 grams or below. Dr. Chetan,
Hello.
you can start.
Yes, ma'am. Good afternoon, everyone. So my topic is effect of kangaroo mother care on retinopathy of prematurity in less than 1800 grams or below 34 weeks of gestation. In the introduction part, so the retinopathy of prematurity (ROP) is a vasoproliferative disorder of retina seen in premature infants less than 32 weeks of gestation, and is a significant cause of preventable blindness across both the developed and developing countries. It can also develop in preterms infant more than 32 weeks of gestation if they had turbulent NICU stray course or prolonged oxygen therapy. In India, every year, 500 children are estimated to become blind from ROP. Literature has proven that the analysis of the risk factor that influence the development of active ROP revealed that statistically significant effect was observed in case of gestation age, birth weight, APGAR score in the first and fifth minute, as well as the longer duration of oxygen therapy. So the kangaroo mother care is a method of care of preterm or low birth weight neonates by placing them in skin to skin contact with mother or other caregiver in order to ensure their optimum growth and development. KMC is a preventive modality which has been proposed as an alternative to conventional neonatal care for low birth weight infants. KMC has proven to reduce morbidity and mortality in low birth weight infants. The underlying physiological mechanism thought was breast milk may protect against the development of ROP, may reflect the antioxidant and immune protective properties of human milk. In addition to the antioxidant properties, human milk also contains immunomodulatory substances such as secretory immunoglobulin, lactoferrin, lysozymes, cytokines, oligosaccharides, antioxidants, enzymes, and cellular components. The current study plans to explore the relationship of ROP with ineffective and effective KMC along with the breastfeeding. We hypothesized that clinical stability provided by KMC would lead to reduction in any stage of ROP and severity of ROP in neonates who received KMC, who received effective KMC during the hospital stay. So the materials and methods our research question was what is the effect of KMC on ROP in neonates weighing less than 1800 gram. The aim was to know the effect of KMC and breastfeeding on ROP in neonates weighing less than 1800 grams or 4 weeks of gestation in a tertiary care hospital. So the primary objective was to identify effect of KMC on any stage of ROP weighing less than 1800 grams or below 34 weeks of gestation admitted in NICU in New Delhi. And the secondary objectives were to study the epidemiology of and incidence of ROP at a tertiary care hospital. And the second was to study the effect of KMC on ROP requiring treatment intervention. So the study design was prospective. It was a prospective cohort study, and the venue was NICU at the Department of Pediatrics in VMC and SJH over a period of 20 months. Study population was neonates weighing less than 1800 grams and less than 34 to 35 weeks of gestation. The sample size calculated was 350, and the outline of the study was after ruling out exclusion criteria, mother with neonates less than 1800 grams and 34 weeks of gestation were enrolled in study after taking informed and written consent of the parents. Perinatal variables, demographic data, clinical data such as Apgar score, congenital diseases, respiratory data, respiratory support, mechanical ventilation was noted. KMC will be divided into significant and non-significant. Significant KMC would be defined as any KMC done for more than 6 hours in 24 hours for 6 consecutive days during the hospital stay or after the discharge. If no ROP was detected at initial examination, the infant were re-evaluated once every 2 weeks until their discharge from the hospital. Thereafter, the eyes will be examined once in 4 weeks until 42 weeks of age when retinovascular development was complete. If ROP was detected, the examination were performed every week till the disease started resolving or progressed to threshold level. In such cases, cryotherapy was performed after taking informed consent from the parents. The changes of ROP were classified according to the ICROP guidelines. So, in the results, we enrolled 783 because as we compared, as we suspected, the incidence of ROP was much lesser. So we increased the sample size to 783. Neonates were enrolled in the study, whom 5 were lost in the follow-up. The mean birth weight of the cohort was 1.46 plus minus 0.19 kg, with the mean gestation age 31.58 plus minus 1.49 weeks. Approximately 2/3 of the enrolled neonates were preterms, less than 37 weeks, and 48.7 were females. 301 neonates were delivered by LSCS. 40% of neonates received effective KMC. Total 66 neonates developed ROP, which either needed further screening or intervention, out of the which majority were neonates who received ineffective KMC. Overall, 8 neonates needed intervention for ROP in form of laser. The incidence of ROP was higher in gestation age less than 32 weeks as compared to gestation between 32 to 34 weeks. However, none of the neonates above 34 weeks developed ROP. Similarly, birth weight less than 1500 gram has higher incidence compared to birth weight above 1500 grams. Effective KMC reduced the risk of ROP, which needed repeated screening or intervention by 99%. The relative risk was 0.05 and for every 5 neonates between 1 to 1.8 kg receiving KMC. One ROP needing further screening was prevented. The primary outcome of the study, that is the effective KMC on ROP, is depicted in the following table. So, presence effective KMC was given to 480, where present ROP was found in 5, and ineffective may 61 cases were detected. So our conclusion was that in KMC, which is an evidence-based low-cost intervention to improve the mortality and morbidity of low birth weight neonates, has significant benefit in reducing any stage of ROP and ROP needing intervention, thus preventing a significant cause of childhood blindness. Thus, it is crucial to implement and disseminate this intervention effectively in neonatal centers across the country. Thank you.
Thank you, Chetan. I would say very good study with a good sample size. So definitely congratulations for doing such a great study. So I have two questions for you.
Yes,
so
sir.
One is you mentioned that the effective KMC versus ineffective KMC, and out of 66 infant who developed ROP, So 61 were in the group of ineffective KMC. You don't think that probably ineffective KMC were done because of the sickness of the baby? That's why that group had a lot of ROP.
Yes, some of the babies were sick. Some of them were
So
on
that's why I
ventilator
wanted to
also.
know how many of them were sick, because that is the problem with the methodology. Otherwise, it would have been a very good study.
Sir, I don't exactly know the numbers of the.
No issue. So have you heard about the logistic regression model or?
Yes.
Okay. So third questions. So in your study on part 1, you showed that presence of any ROP. So 5 versus 61, you showed that the RR is 0.05. In bracket, you have written 0.02 to 0.22. Can you explain this RR? Just explain this value and tell me what does it mean.
Sir, it was the relative risk. Sir, it was for the incidence of risk among the exposed group and incidence risk among a non-exposed group. So, sir, the relative risk larger than 1 represent that risk have increased due to the factor exposure. And sir,
okay, good. Good.
Yes, sir. And the value obtained by this by subtracting 1 from the relative risk is an excess relative risk, as like some.
Can you explain this in a slightly better language?
Sir, it was less than 1.
I think you have done a very good study, so there is no doubt. That's why I'm asking these questions. I'm not going into the detail of your. Okay, so what do you mean by NNT, number needed to treat?
Then no needed for treatment.
Okay, just read about this NNT. Okay, thank you.
Yes. Okay.
So now we move on to next presentation by Dr. Rituparna Mana, epileptiform electrographic changes in autistic spectrum disorder without epilepsy. Dr. Ritu, you have 5 minutes. Please start.
Please stick to the time.
Hello. Hello.
Yes,
Am I
you are
audible?
audible. Yes, you are audible.
I am Dr. Rituparna from ABVIMS and RML Hospital, Pediatric Department. My study was on epileptiform electroencephalographic changes in autism spectrum disorder without epilepsy. In this, our aim was.
Can we have the study on the screen from the technical team?
Dr. Ritu, can you share your slide? We don't have your poster or your presentation, sorry.
Actually, sir, I am presenting from my phone, so I don't have this.
Do you have this in your phone? Or on your mail ID?
Yes, sir.
Okay, so I think we can give her 5 minutes so that she can share screen and move on to next presentation and come back to her. Is that okay?
Yeah.
Okay. So before she,
okay, sir.
Dr. Ritu, you can arrange for your screen till we take up Dr. Aarti, right?
Okay, thank you, ma'am.
Okay. Dr. Aarti, can we have your presentation? Dr. Aarti, so you can start. Can someone unmute Dr. Aarti, please?
Yes, ma'am. Am I audible?
Yes, you are. Please go ahead.
And the topic of my study is functional bladder capacity and non-invasive urodynamics in children aged 5 to 15 years old presenting with primary monosymptomatic nocturnal enuresis. So in introduction, nocturnal enuresis, as you know, it impacts the emotional state, self-esteem, as well as the social development of the child. Enuresis, it can further divide into the 2 types, primary and secondary, as well as monosymptomatic and non-monosymptomatic. Primary is one who never attained the nighttime dryness in the last 6 months, whereas secondary is the one who achieved the 6 time dryness in the last 6 months, but again the symptoms appear. In monosymptomatic, the only symptoms is the nighttime bedwetting, whereas in non-symptomatic, we have the lower urinary tract symptoms like urgency, frequency, displaying, or presence of the holding members. So the exact cause of PMN is unknown, but several factors may be contributory. Actually, in my in thesis, I have also looked out for the positive etiology, but here I am just presenting the main functional capacity part. So the etiological maybe obesity or the maybe the what is the significant HI features or
Mr. Rohit, there's too much of echo. Can you help? Mr. Rohit, there's too much of echo.
I'll continue.
Please continue.
So there are three pathophysiological mechanisms which have been postulated which cause analysis as first is the abnormal circadian release of ADH or ADP, arterial vasopressin. Second is the small body bladder volume, and third is the impaired arousal from sleep, which prevents waking to the child to go to the toilet. So urodynamics have proved to a critical usefulness for the diagnosis and development of treatment in selected cases. However, only a small proportion of patients with MLE will profit from UTIs, and considering the cost of the procedure, the potential discomfort to the patient as well as the family. So, UTIs, urodynamic studies have been described as routine investigation in children with primary systematic nocturnal headaches. Studies on the clinical spectrum in Indian children as well as a study on to look for the functional bladder capacity in India are very scarce. And the low functional bladder capacity in is still an area of research. So I have done this study to look for the functional bladder capacity, whether it is appropriate or low in the children with the primary monosymptomatic. So the research question is through children with the primary monosymptomatic nocturnal epilepsy, they have low bladder capacity. The primary objective was to look for the functional bladder capacity by ultrasonography in children with PNN, and second is to study the non-invasive urotometry in children with PNN and to correlate the maximum volume recorded in bladder diagram with functional bladder capacity by ultrasound and water volumes in urotometry. So this is a hospital-based observational cross-sectional study, and children attending to the OPD 5 to 15 years old, I have included them. And this study is conducted in department of our department, pediatrics, radiology, urology. Because this is a very less stage presenting the OPD, so sample size is very small, and also the studies done earlier were very few in number. Thus the sample size calculated from the previous study as well. So the sample size is 46 only. So after taking the informed consent from the parents, so I have evaluated them on enterometry to look for the obesity. Also, I have given them a proton, which is a clinical management tool. I have done the clinical examination of abdominal spine and investigation. Look out for the secondary cause of I will be given a chance to determine the obesity and modify it to for a state to look for the socioeconomic status. Because this is a tertiary care hospital, so many referrals are taken and the population pertaining to lower background are coming into the government hospital. So I 6 cases which were analyzed by the ultrasonography clinical management tool and the bladder diary which I have given to them, bladder diary as well as the container. And out of the 46, 21 were further undergone urotometry. Actually, some patients had urotometry dated in the March end, but because of the ongoing pandemic, so the COVID as our super specialty block is converted into the COVID. So most of the urotometry is still pending, which I am continuing further also. So I have taken the 23 cases who further undergone urotometry. So in ultrasound scan, it was noted that 37 patients out of the 46 they have low functional bladder capacity. Low functional bladder capacity is defined as less than 65% of expected bladder capacity. And It was noted that out of the 30 and abnormal seen only in 5 children, and therefore planned for a very.
I think let's stop, ma'am. Let's better ask a question.
Yeah, I think she had a lot of echoing her voice. So please go ahead.
Yeah.
Rajesh sir and Dr. Ankur can take over the questions.
Dr. Aarti, can you hear us?
I need to send an investigation.
I think she's still presenting.
Yes, sir.
Can you hear us?
Yes, sir.
Okay, so unfortunately we could not hear you because of lot of echo. So I have only one question. You showed 2 yellow charts. What is that chart? Could you please explain this? Two graphs you are showing now. Correlation of MBV by bladder diary and FBC by ultrasonogram. And there is another chart. What is this chart? And can you explain this chart? Okay, if you don't know, then just say yes or no, please, because I can't hear you.
Dr. Aarti, can you hear us?
Let's leave her, move to another session. I mean,
we can move on to the next.
Yeah.
Okay. So now for the last presentation for the day, we have Dr. Ritu Aparna, and she can introduce the topic and go ahead with the presentation. So she has the last 5 minutes. Dr. Ritu, please. Can the technical team display her poster?
Hello, am I audible?
Yes, you're audible. Can we have your poster from the technical team? Okay, we have.
I am Ritu Barna from ABVIMS and RML Hospital, Department of Pediatrics. My study was on epilepsy from electroencephalographic changes in autism spectrum disorder without epilepsy. In this study, we had total 30 of autism spectrum disorder patient who have no previous history of epilepsy. It was an observational cross-sectional study. Aim of our study was to detect any epileptic from EEG changes are present or not. Inclusion criteria was depending on the clinical criteria in according to the incline criteria of INDT ASD scale of DSM-5, and the children with ASD was taken who has no previous history of seizures. So proper history and examinations of the previous papers of the patients was done to rule out any history of seizures, and these patients were taken and EEG was done, and EEG evaluation was done by doctor expertise in EEG reading. As a result of this study, there was a total awake EEG recorded in 9 patients and sleep EEG recorded in 21 patients. Among 21 studies in which there was a sleep EEG was recorded, sleep spindle was present in 14 cases, that is 66.7%, and whereas the sleep spindle absent in 7 cases, that is 33.3%. Among 30 ASD children, 4 children, that is 13.3%, have isolated epileptiform discharges identified in EEG record, which was slightly high when compared to the general population of the children of same age group. And among these 4 children, generalized high voltage 3 to 5 spike and wave epileptiform discharges were seen in 2 patients, and the duration was 0.5 to 2 seconds. One patient was generalized high voltage polyspike wave, and another patient shows the generalized delta wave activities, which was abnormal in according to the age group distribution. No significant background frequency changes was detected in EEG, but abnormal amplitude changes was detected in these autism patients. Background amplitude was abnormal in 15 patients of sleep recordings, that is 71.5% of sleep record, and 2 patients of awake recording, that is 22.3% of the awake recordings. Background amplitude was higher in sleep state in autism patients. Now coming to the discussion. Generalized discharges was found in total of 13.3% cases, that is 4 cases among 30 children. There was no focal discharges recorded in EEG. Total 13.3% showed isolated epileptiform EEG changes, which are significantly higher than the general population, but it is statistically insignificant. Abnormal background activity was seen in 22.3% in awake record and 71.5% in sleep record. On analysis of background voltage, higher background voltage recorded in sleep EEG in autism children under our study and when compared to the normal population. Upon analysis of sleep EEG recordings, sleep spindle was absent in 33.3% of cases, which was quietly high, and duration of sleep spindle was less than 1 second in 64.3% subject, and they were poorly formed and located predominantly in the frontal area. The paucity of sleep spindle in ASD children is much higher. In coming to the conclusion, the epileptiform discharge recorded in ASD patient in our study were not significantly high when compared to the normal population of the same age group. But the background abnormalities was obtained in this study was quite abnormal when coming to the background abnormality in aspect of the amplitude of the background recordings. But this study was done only with 30 children, so we cannot conclude properly with this study, but further study is needed with larger sample size to detect the proper background abnormalities in the EEG or any further generalized epilepsy or generalized epileptiform discharges was found or not. Thank you.
Thank you, Dr. Rituparna. What is the incidence of epilepsy in autism spectrum disorder children who do not have epilepsy, but if you follow them up, what is the incidence of them developing a epilepsy?
So actually, there was different studies. Different studies was done in which in some studies there are showing some focal discharges in the frontal lobe or in other lobes. But in some but the incidence
likelihood of developing epilepsy. Say even if you don't do the EEG, but what is the likelihood what child will develop seizures in a later life?
So actually, in autism spectrum disorder, it is quite much, quite higher than normal population. It is around 20 to 30%.
Any questions, Dr. Ankur?
No, ma'am.
Okay. Okay. So thank you, Dr. Rituparna. I think we are finished with the presentation. There's a message by Dr. Aarti from the previous presentation. Dr. Ankur, if we can take up some questions because she wants to answer. Ajay sir, any questions for her?
Dr. Aarti, can you hear us?
Yes, sir.
Okay. So you showed two charts, not two yellow charts.
Yes, sir.
Showing correlations. So what does this chart suggest?
So one. Sir, these are the two charts which showing the correlation of the maximal voided volume, which is.
You know what is the name of this chart?
Sir, this is the Pearson coefficient correlation.
Okay, Pearson. Okay, relation. No, I mean chart. There are scatter plot and scatter chart. You have heard
Sir,
about
scatter plot.
Okay, so can you just explain the one of the chart of ultrasound versus your?
So in first chart, there is correlation of the maximal voided volume, which is assessed by the bladder diary, which I have given to the patient, and the functional bladder capacity, which is assessed by the ultrasonography. So in this chart, these points are scattered. They are not aligned along the line. So it shows a weak correlation between the two variables.
Okay, so what was the value of that correlation? When you say that the correlation is good.
Sorry, don't know about this.
Okay, good. Okay, no issue. Thank you.
Okay, sir. Thank you, sir.
So with this, I think we have finished up all the poster presentations for today. I request Dr. Smita ma'am to say a few words, and we can present the results in another 1 hour. We can just compile the results. So Dr. Smita ma'am who is over here, we can have a word from her. Dr. Smita ma'am. Ajay sir, if you would like to conclude this session.
Yeah. Thank you, Dr. Hema. I congratulate all the presenters who worked hard to do their presentations. It allows them to move ahead with all the presentations so that they don't need to read it. It should be displayed on thing, and but they should be speaking with the presentation without looking at this.
So, Dr. Hema,
Yes, ma'am.
really, thank you so much. You have done it very efficiently, and I'm really thankful to all judges for their Ajay, Ankur, everyone who was there, and it was actually I went through all the presentations that way. Only one where there was some disturbances going on, but the most of presentation I went through, and I am very happy that they are doing so much of research work, and I really wish that these research work should be compiled together, and the more number of the patients should be added on each and every this thing, and we should come out with some epidemiological conclusion. But just as of now, for the postgraduates, I'm thankful to them that at a short notice they have prepared the poster, and we have to consider that point that they have been given a very short notice to submit these posters, and that's why we are very lenient also while accepting them, and while taking the final call on them. So I'm really thankful for all of the people who presented poster. I would keep on saying that you should always have a part of your heart for the research and keep on doing it. Try to be associated with it. And as a doctor, you are not doing research work, you become a technician rather than a doctor. So that is what. Thank you very much, Dr. Hema. You have done wonderful job.
Thank you, ma'am. Thank you for promoting the postgraduate students, because I think they're the future for tomorrow. They're the stars for tomorrow. So I think it is really good that we have this session in our conference. Thank you, everybody. Okay, ma'am. Thank you.
Okay.
Thank you.
Thank you, Dr. Hema.
So what time we are starting, Rohit?
Welcome, Dr. Anju.
Hi,
hello,
Dr. Anju.
how are you? Yeah, good.
Hi,
I
Dr.
just
Anju.
Please
I'm the
make some
chairperson for the next session, and very nicely conducted by Dr. Hema and Dr. Ajay and the whole team.
Thank
I had
you so
also
much,
gone through the research work, good level of research, and PGs are
Really,
very
that is
enthusiastic to
impressive.
present their research.
Thank you so
No,
much, ma'am.
Dr.
Actually, to
Anju,
follow
you are
series.
our strongest pillar. Once I think about any this kind of activity, I cannot es skip remembering you. I mean, you are always there in my mind.
Ma'am, it is all because of seniors and guides like Dr. Anju and Dr. Ajay sir and everybody who's actually given us all these things. Thank you so much for everything.
Dr. Anju, namaskar. Good afternoon.
Namaskar, sir.
Good afternoon.
कैसे हैं? Good afternoon.
First class.
You post-COVID.
Welcome, sir. Welcome.
Post-COVID recovering.
Yeah.
और मैडम सुमिता तो देखो अभी हॉस्पिटल बेड से ही है, तो स्ट्रॉन्ग लेडी, स्ट्रॉन्ग.
Very well organized activities throughout the year.
Dr. Singla, namaskar ji. Dr. Deepak Singla ji,
namaskar sir, namaskar.
Dr. Basuraj has joined us probably. Sir, Dr. Singla, thank you very much for accepting this invitation and invitation for tomorrow. And really, we are thankful.
Thank you for the honors, ma'am. It is always a pleasure.
Tomorrow we'll be starting at 1.
Yeah.
We'll be starting at 1 tomorrow.
Yes. 1 minute, sir. Ma'am, I tell you exactly. Rohit, at what time we are starting this session?
We'll start at 2.
So tomorrow we are starting at 1 p.m. with welcome address by President IAP Delhi, Dr. R.K. Naab. इसमें डॉक्टर नाब का नाम वैसे डाल देना चाहिए था रोहित. Like there is no
No confusion.
There should not be any confusion.
There is no confusion. Yes.
तो अभी 10 मिनट है.
रोहित कब हम लाइव हो रहे हैं?
वो तो अभी 10 मिनट है मेरे ख्याल, 10-12 मिनट. या कर लें?
नहीं, जितना टाइम है, because people will log in like this.
Ma'am, you can start now.
We can start, but अभी
Yes.
तो टाइम है 7 मिनट. फिर वो अटेंडी तो 2 बजे ही लॉग इन करेंगे, नहीं तो उनके लिए.
YouTube पे भी आप 2 मिनट पहले ही शुरू करना जी, 2 बजे से. ठीक है?
Right, sir, right.
ये गॉसिप ना आए तो अच्छा लगता है, क्योंकि इट इज गोइंग टू बी देयर. वो आर्काइव हिस्ट्री बन जाता है फिर वो.
Right, sir.
हमेशा के लिए. हेलो अजय.
रोहित, I am forwarding this to you also. मतलब upgraded program ना.
Okay, ma'am.
There was some confusion.
वो सॉर्ट आउट कर दिया मैंने. वो डॉक्टर गोम्बर को भी इन्फॉर्म कर दिया. he'll be coming.
नहीं, वो नहीं था. कुछ ये था कि ये जो अपग्रेडेड लास्ट वाला बना था ना, तो उसमें कुछ इश्यूज थे. हो गया सॉर्ट आउट हो गया. So
इतने बड़ा प्रोग्राम होता है, कुछ ना कुछ गड़बड़ होती है, बट
कोई नहीं.
our team has tried to manage it.
So I will start right now. This is 7.
Dr. Basuraj, welcome Dr. Basuraj.
Welcome Dr. Basuraj ने login किया हुआ है, but probably he is not there as of now.
So now
Welcome,
this
Dr. Prashant.
feature is available on phone also. I have installed this virtual screen.
What?
Yeah, I have installed virtual screen on my phone.
अच्छा.
Wow, that's very good. अच्छा लग रहा है. वही मुझे लग रहा था कि इसका वो क्यों चेंज है, dimension. Like it's more of like elongated. Yeah.
2 minutes. Dr. Harisharan is logging in.
Dr. Kishan Jani, welcome. Vice President has joined.
Dr. Arun Gupta, welcome.
डॉक्टर किशन जानी फेस ही नहीं दिखाते. इतने दिन से हम वेट कर रहे हैं उनको देखने.
हमने आज भी कॉल
किया. कोशिश कर रहे हैं हम, पर मुंह दिखाई के चलता है.
कुछ देना पड़ेगा मुंह दिखाई उनको.
So here we start.
So should we start? हाँ, जब तक मैं बोलूंगी, जब तक probably Dr. Chelani will actually. Hello. हाँ.
Dr. Basuraj, नमस्कार.
नमस्कार.
अंजू गुप्ता मैडम, नमस्कार. स्मिता मिश्रा मैडम,
नमस्कार.
नमस्कार बसवराज.
नमस्कार सर. Good afternoon to everyone.
Good afternoon to everyone. Good afternoon.
दीपक को भी बहुत दिनों बाद देखा है, दीपक सिंगला को.
जानी अपना चेहरा तो दिखा यार.
ये लो सर, मैं अभी भी
हाँ, दिल खुश हो गया भाई.
नहीं पढ़ता तो मैं सारा हूँ, पूरा आखिर तक पढ़ता हूँ. आज वोट भी डाल दिया ना सबने?
हाँ डाल दिया. ये कोई कैनवस
अनम्यूट स्मिता मैडम.
नहीं ऐसी मतलब.
So hello sir, Dr. Basuraj, welcome. Dr. Jani, please put a light in front of your face and welcome everyone. So dear friends, this is the last day of PCNI NIPID conference scientific program. We are very happy we concluded in morning session, then subsequently the poster session, and we are very happy from the attendance response and our team work. So this all has worked for betterment of the conference, and thank you everyone. I would like to take a name of everyone who are associated. Besides our NAF, Dr. Lalit Mendirata, who is President-elect, Dr. Manish Gupta, who is Secretary-elect, Vice President Dr. K.K. Jani, Our IAP Delhi City Branches President and Secretary, Central Delhi, Dr. R.K. Alwadi, Dr. Swati Bharadwaj, East Delhi, Dr. Piyush and President, Dr. Nirupma Tyagi, Secretary, North Delhi, Dr. Dinesh Mittal, President, Dr. Shalini Goyal, Secretary, South Delhi, Dr. Praveen Khilnani, President, Dr. Manu Agrawal, Secretary, West Delhi, Dr. Manish Chopra, President, and Dr. Prashant Seth, Secretary. Our media cell in charge, who was our speaker also for the morning session, Dr. Ravi Malik, ex officio President, past President, Dr. K.C. Tamaria, Dr. Ajay Gupta, who was past Secretary for the last year, but now he is a CIAP representative, Executive Board Member, Dr. Shikha Mahajan, Dr. Amit Kumar Tyagi, Dr. Dinesh Sahai, Dr. Piyush Jain, Dr. Pankaj Garg, Dr. Dinesh Mittal, Dr. Ashok Chakravarti, Dr. Shyam Sundar Meena, Dr. Shravan Gupta, Dr. Piyush Khanna. Our CIAP President-elect, Dr. Piyush Gupta. Dr. Bakul Parikh is not in the session. Dr. Bakul Parikh is our visionary president for this year, and actually we have learned so much under his leadership, and DIAP was just a dream if he was not there. So we are really thankful for guiding us so well in this COVID pandemic. We are also having our Secretary General of CIAP, Dr. Basavaraj, who was absolutely dynamic, and he was always there whenever, whatever we requested him to do. And he guided us like really a real leader. So, and I am so happy that next year you are there to support the whole program. Then CIAP Vice President Dr. A.S. Vasudev, I need not to speak about him much because he is so popular over here. CIAP Liaison Joint Secretary Dr. Harish K. Pemde. Our CIAP representative Dr. Deven Gaba, Dr. Alok Bhandari, Dr. G.P. Kaushal. I can definitely praise them endlessly because whenever we required any help from them, and rather when we are not asking for anything, they are calling us and telling that this thing is right and you have to do things like this. So that kind of guidance you always require in such a big organization. And I am really, I want to congratulate our CIAP representative Ajay Gupta, Dr. Agrawal, and Dr. Piyush Khanna. They are our new CIAP representative. And then Dr. Sangeeta Yadav. Dr. Sangeeta Yadav is new VP elect of CIAP, and she has been for such a long time. She has a history on her tip of tongue, and she can tell how PCNI started and how it actually worked so wonderfully well. West Delhi branch, which hosted recently PCNI in last 3-4 years back, and they have been a pillar for this conference. So, and then Dr. Shyam Kukreja. Dr. Shyam Kukreja is excellent person, absolutely fabulous human being, and he has been the enlightening force for us, driving force for us. If you go through our scientific program, you will see that the people like Dr. Kukreja, Dr. Taneja, Dr. Ellen Taneja, Dr. Dr. Suresh Gupta, Dr. Dheeraj Shah, Dr. Bhasin, Dr. Pemde, and few. I think I may be forgetting few of the names, but you can see that beauty of the program. It is really a combination, amalgamation of the various kind of advancement and of course the basic bedside and beyond. So I'm really thankful for my scientific committee. They have given such a strong base to this program that even so many programs are happening all around, but we can claim a uniqueness in this particular conference. So thank you very much, everyone. I would call Dr. Ramesh now. I have spoken little more than usual, but I think this is a last day, so little space of time I can claim. So Dr. Ramesh now, please tell your heart out, your brain out. Yes.
Thank you very much, Dr. Smita. I am so happy that now you can speak with strength. You are recovering, I feel, and we wish and pray to God for your speedy recovery. It is great of you that in spite of ailment and in the hospital, you continue to be there with us throughout. We are so very grateful to you. I am extremely grateful to our dignitaries from Central IAP, especially Dr. Bakul Jayant Parekh, Dr. Baswaraj, who is always with us whenever we required him, and Dr. Piyush Gupta ji, Dr. Ramesh Kumar, Dr. Anand Vasudev, our Vice President, Dr. Sangeeta Yadav, Dr. Harish Pemde, and Dr. Devendra Mishra, who is Editor-in-Chief, Indian Pediatrics, and all the CIP members and all the dignitaries who are present on the dais. I'm thankful to them. And it is not only, a small group of people working for this big event, the whole of team, the scientific committee, the finance committee, the cultural committee, the technical committee, and then we had the communication committee. The whole team was doing so synchronously work that as you have witnessed in the last 3 days, we had a wonderful program, and there was not even a small problem which arose. And especially the morning sessions, they were very popular. Even in the morning, 200 to 300 delegates were joining at 8:30 in this wintry morning. It is difficult to get up early and be there in front of the screen. So we started with the spirituality. The reason was very simple, because in this pandemic of COVID-19, whosoever has gone through it knows that how unpredictable it is. And once you are in a hospital, then you feel so bad about this. Your relatives also feel a lot of tension, and there is a feeling of loneliness, and it causes mental tension. I am very much sure once this pandemic is over, there's a pandemic of mental health problem we are going to face. That is not very far off. So the only way is to go into spirituality. So we had a morning session on the very first day, spiritual talk. Next day there was adolescent talk. Then third day there was a digital talk. And today we had a very, very important and financial talk. Dr. Ravi Malik is a great leader, and he is a great expert in as well as finances are concerned. So people like that. Even the scientific programs from 2 to 7, they were all liked by people, and we look forward to it. Even today's program is going to be a big hit. Our opening batsman today is Dr. G.V. Baswaraj, and we have the esteemed chairpersons for this. Now I'll request scientific coordinators to please go ahead with the program. In the evening, I must tell you, please join us for valedictory function at 6:45. And then after that, followed by cultural event. And tomorrow we are going to have annual day celebration starting from 1 o'clock. You can have your food earlier so that we can continue till 5:36.
So Dr. Mamta Jaju, who was coordinator, scientific coordinator today, having fever, so she cannot join. Dr. Manish Gupta will lead as he was leading on all these days, and I'm really thankful to him. And Dr. Dinesh Mittal, who is our very, very dynamic president of North Delhi City Branch. I will also chip in, and particularly in the late evening hours when then we have to take over for valedictory. So I invite Dr. Manish and Dr. Dinesh to start the program. Dr. Manish? Dr. Dinesh?
You can start the program.
Huh? Dr. Manish? No? So right now I invite our chairperson for the first session, Dr. Harish Chelani. Please put the CV. Rohit, Nikita, please share the screen and put the CV slides.
Yes, ma'am.
So Dr. Harish Chelani is very famous pediatrician and neonatologist. He has reinvented many things in the neonatal care. And we are really lucky to have him on this platform. I really want to have he's working with Safdarjung Hospital. Nikita, if you can put slides very quickly.
Yes, ma'am. Just a second.
And until then, I invite Dr. Deepak Singla, Dr. Lalan Bharti, Dr. Anju Agrawal to chair this session. So, So Dr. Anju Agrawal is also the co-chairperson for our poster and the academic activity. She is a very strong pillar of support the last year also and this year also. So she is really very humble and very cooperative and very methodical also. So this is what Dr. Deepak Singla is working with, I think, ALS and BLS program. He is a very famous pediatrician from my side where I work is the West Delhi. And he is one of the eminent pediatrician and great clinician. I don't know कि much has to be said about him because everybody knows him. Still, Nikita, I would prefer if you put these slides on the screen. And Dr. Lalan K. Bharti is recently elected as Vice President of NNF. Dr. Lalan Bharti, I know you for such a long time, 4, 5, 6 years, and we had a very great exchange of thoughts so many times. So first, Dr. Professor Chelani is working as the in charge of newborn unit department. First, please, अभी पहली slide ही दिखा दो निकिता.
Yes, ma'am.
So working in charge newborn unit department of pediatric Safdarjung Hospital, and he is trained from the Harvard School of Public Health, Boston, for the improvement of quality in health services. I will not read the whole biodata, but it's excellent. Please, he drafted the newborn section of Indian Public Health Standard 2010 of Ministry of Health and Family Welfare for districts and sub-district hospitals. This is very important. Next, Nikita, please go to next slide. Dr. Anju Agrawal, as I said, is Professor Pediatrics, present affiliation University College of Medical Sciences, Guru Tegh Bahadur Hospital. He has very special interest in neurology and child development. They have actually published, she edited a book on the neurology and child development for the IAP Delhi. And she got many awards also, James Flett Research Award, and 100 publication, 35 chapters book on the childhood disabilities, and member of Disability Certification Board, Northeast Delhi. Thank you. Next. So Dr. Deepak Singla, he is medical director, Maharaja Agrasen Hospital, Punjabi Bagh, New Delhi, 26. And honor and award, he is PALS instructor, BLS state coordinator, certified manager of the quality and the organization excellence, ASQ certificate in the infection control. So has a many feathers in his cap. So next, please. Dr. Lalan Bharti, JPC Hospital, Government of NCT in Delhi. He is now Vice President and conducted more than 100 NRP workshop, but this time we were not able to motivate him. And he is a recipient of Fellow of Indian Academy of Pediatrics, FIAP award, and so many things. So many accolades for him. So next, please. I request our chairperson to introduce our honorable guest speaker for this session, Dr. G.V. Basoraj.
Dr. Smita, for the nice introduction. And I thank the organizing committee to give us this opportunity to interact with the members of IAP Delhi and the stalwarts. And at the outset, we will be talking about the sustainable developmental goals, which have been made by UN, which have to be achieved by all the countries by 2030. And the goal number 3, which says good health and well-being, is the main goal which we pediatricians or physicians have to address to. And to address to this, we have a personality, none other than Dr. G.V. Vasaraja, whom we have seen all through the year has been so active. He is placed in Bengaluru and he is the Honorary General Secretary for the year 2021 He has more than 50 publications in national index journals, and he'll be talking to us about sustainable development goals pertaining to India, the role of IAP in it. Over to Dr. Vasaraju. Dr. Vasaraju,
thank you so much,
you
Dr.
can start your
Anju.
screen.
Yeah. 1 second.
Rohit, please take care of noises, background noises. Please mute everyone. And then Dr. Basavaraj will.
Okay, ma'am. Okay.
That will be best part.
Sir, please start.
Yeah, just a minute. Just I'm checking the presentation.
Screen share करना है ना अभी.
Can you able to see my slides?
No, Dr. Basavaraj, no.
Yeah, now I think you should be able to see. Can you able to see? Thank you so much, Dr. Anju Agarwal, madam, for your kind words. What I will be talking for the next 25 to 30 minutes about a sustainable developmental goal, which is set by United Nations for 2030, the role of IAP. IAP has got to play a major role. To achieve anything, what's most important to improve the maternal and child health outcome is what we require three fundamental things. One is a knowledge base and social strategy and political will. But Indian Academy of Pediatrics can play a major role in the knowledge base and to some extent things really to make a big role in achieving a sustainable developmental goal. Till the 2015, that means 1990 to 2015, that is, we used to focus on MDG goals, that is focused on mainly on the survival. But in the year 2060, we have moved to the sustainable developmental goal that focuses not only on the survival, it is on the well thriving as well as in a development. So early moments of matters for every child. That means we need to focus on survival, that is nutrition and development. Let's look at some of the data, what we have. This is a data which has been there in the 2018 Ministry of Health and Family Welfare, Government of India. That was the last updated. There are 25 million babies born every year. Out of this, 0.59 million newborn died annually, and estimated 32,000 of maternal death annually. So what is more important for the pediatrician is 13% of the rate of a preterm birth, 18% of the low birth weight babies born with that. This is where our crux of the matter as a pediatrician and IAP can play a major role in including NNF and neonatologist. Let us look at the pediatrician's efforts for child health. So pediatricians' efforts is very, very crucial. Children are the crux of a better tomorrow and good child health future from the basis of prosperous future. Hence, the various aspects of pediatric health care play an essential role in achievement of sustainable developmental goal, which is set by United Nations for 2030. Indian Academy of Pediatrics, which is tries to better the every aspect of child health care, has a vital role to play in achieving the SDG goal. For that, Indian Academy of Pediatrics, working with the National Health Mission, that is NHM, in at the state level, at the national level, UNICEF, For more than 50 years, we are continuously working with UNICEF in a betterment of a child. I'll come to those things one by one. WHO, these are the four organizations, government, UNICEF, and WHO is going to play an important role in achieving our SDG goal. Look at the overview of the role of an IAP. IAP has always in a development of a child, it is a core objective in our constitution or our MOU. Good perinatal care, which is a very, very important aspect where the pediatrician and the neonatologist play an important role in achieving our SDG goals. State-of-art neonatal care. This is where we are working for almost more than 20 to 30 years in collaboration with the UNICEF and government of India, especially playing an important role like a mentoring of an SNCU, which has been there in a majority of the states, NRP program. I'll come to those things. Although this is where our IAP is playing in a major role. Preventive medicine and the good nutrition, especially communicable disease and malnutrition. So we can play in a very major role. Immunization is then a core aspect of a pediatrician. So both in a public as well as in a private. So it is going to play in a major role in eradication of our infectious disease and control of infectious disease. School health program is another part of it, and adolescent health care and training module. This is where in a majority of the President Action Plan module, you are playing an important things. IAP has a role to play as an advocacy role to use of expertization of resources of a pediatric healthcare professional all over the nation, and also help to provide a valuable input to the government of India in achieving this goal. Advisory role of IAP not only at the level of a government of India and also at the level of IAP level among the national, state, subspecialty and even the city branches where the pediatrician is going to play a very important role in achieving this community level to reach out to the pillars of our healthcare system, especially grassroots level, including PHC, ASHA worker and social health care, government sector, as well as in a public private sector can play an important role. This is an initiative of a government of India where the India Newborn Action Plan, which has been initiated in the year 2014, JSSK especially it is playing a very important role in relation to the financial aspect in the government sector. So it and majority of the other thing, this is where the government started 2014 of India Newborn Action Plan. This is played in a very important role. There are 6 interventions in this. Let us look at each one. The pre-conceptualization and antenatal care, which is more pediatrician can play an important role in collaboration with the obstetrician and gynecologist in reducing the neonatal mortality and stillbirth. So care during the labor and childbirth where the pediatrician and neonatologist can play an important role in the child survival. Immediate newborn care, this is an important thing, especially initiation of breastfeeding and sustainable breastfeeding, immunization and routine newborn care where we can play a very major role. Care of healthy newborn, that is in the follow-up. Care of a small and sick newborn care, SNCU has been established by government of India. So where the pediatrician can take a role, both government sector as well as in a private sector. As a pediatrician, as an IAP can play a major role. Even NNF is mentoring a lot of NICU across India. Care beyond the survival, that is a passionate care, that is where we can all play the important role in an India Newborn Action Plan. What are the potential aspects where we can play an important role is infectious disease and IMNCI. So these are the things which is very important in reducing the under 5 mortality apart from the newborn care. So these are the other things which is really where our national body can play an important role. Preventive aspect, which is emphasis on an immunization, and that's a very important thing where IAP and members of IAP can play an important role. Role of a nutrition, especially now both malnutrition as well as overnutrition. Both the things are very important, optimizing the nutrition. So this is where we can play a role, adolescent healthcare and welfare. So IAP is already written to the National Medical Council under our President-elect 2021, 2020, that is already written to the NMC. So changing the name of an Indian Academy, pediatrics into the pediatrics and adolescent health care, medical education. Now the lot of reforms has been taken place. IAP can mainly work with in National Medical Council for a curriculum for an undergraduate and postgraduate. This is where we can play a major role. Child abuse and neglect, our subspecialty groups along with IAP is playing a very important role. Developmentally disabled children. So this is a more emphasis which has been paid in the sustainable developmental goal is your early childhood development, that is recognition of a developmental problem in the beginning. I'll come to those things in subsequent slides. Newborn screening is another thing. So role of IAP in underlying mortality is a major cause of mortality in our country. Apart from the neonatal mortality, if you look at an infant, is more of our pneumonia, diarrhea. This is where IAP is already playing a major role. So where we are, in a case of a diarrhea program, ORS and zinc concept has been propagated by IAP, and it will continue to do that to prevent a zero death in the diarrhea. It is closely working with Government of India. Pneumonia, we have introduced the pneumonia day by our IAP respiratory chapter. So we are propagating the knowledge of how to bring down the number of deaths because of any pneumonia or respiratory infection. That is where we can play a major role. IMNCI, which is serves as an healthcare professional, how they recognize an early signs of a danger. This is an IMNCI. It is a core concept, so which needs to be propagated to the healthcare. IAP can always coordinate with the Government of India to propagate this knowledge. Our different presidential action plan, we are time to time, we are revising the standardized treatment protocol, so we can come out with a standard treatment guidelines. So we are in the, it is in the pipeline. We are going to do that. Awareness needs to be created among the member about hygiene and good nutrition. That is emphasis on the breastfeeding and simple danger recognition, how the mother can recognize it, home-based treatment in the less severe cases. This is where we can prevent a lot of infection which has been admitted. This is a tuberculosis control program which has been initiated in the 2018 under Dr. Santosh Sohn, subsequently conceptualized under our past president, Dr. Digan Shastri, with the PLC, Dr. Sangeeta Yadav Madam and Dr. Varinder Singh, collaborating with the Government of India. So in the year 2020, we launched this program with National TOT under our visionary president of Dr. Bakul Jayant Parikh. In various zonal level TOTs has been incorporated along with infectious disease too, taken into the confidence, and Dr. Vijay Yavle, Dr. Piyush Gupta ji, Dr. Varinder Singh. So we are almost conducted because of this COVID things. The things has come now, the talks on to conduct in a virtual program of a tuberculosis NTEP program. So we are planning to roll it out in the 2021 to all the branches of Indian Academy of Pediatrics. Coming to the role of IAP in immunization, is IAP again can play an advocacy role in both in implementation and making a recommendation. So we have Dr. Sangeeta Yadav Madam as an Joint Secretary of Liaison, subsequently Dr. Vasudev, our present Vice President, and the Joint Secretary, Dr. Arish Pemde. So they are the one who are liaisoning within the Government of India to recommendation of an immunization and also introduction of a newer vaccines like a pneumococcal vaccine and rotavirus that can especially bring down a lot of mortality because of a pneumonia and diarrhea. And also members of both private as well as public stress the importance of a cold chain, which is very much necessary, that for the efficacy of a vaccine, it has been focused in a lot of our practical guidelines on immunization, which is in a program which is conducted, and we are also planning it out in the subsequent year too. Ensuring the greater coverage of a vaccine in the current national immunization schedule, because a lot of myths in a social things where the anti-vaccine lobby is in a one which is playing in a lot of roles in creating a lot of taboos in the social thing, where IAP can create an awareness and universal immunization program can be enhanced. Mission Indradhanush program, which has been a flagship program of Government of India, where IAP can play an important role, where the catch-up immunization can be usually done by the public sector, where IAP can also educate the private practitioner and also involve in the Indradhanush program. Of course, in the 2 years back, we have MR program, that is measles and rubella vaccination program. IAP is played in a very active role in implementation of an MR program by Government of India and NHM. And pulse polio, yes, polio has been eradicated, where IAP is played in an important role in both in advocacy, implementation, and also creating awareness among the practicing pediatrician. So nutrition is another part where the IOCF is coming out with different guidelines, Indian Academy of Pedia in association with IAP. So we are coordination with the NAPSI to promote and initiate the breastfeeding and human milk bank guidelines, which has been done by our IVCF chapter, support for run the women milk bank, and we are planning to come out with guidelines for that. So in the year 2019, where we have done a lot of work on this, because there was no done that, where this time where we have done a lot of things on a virtual program. This is in a breastfeeding in India, where our IOCF current chairperson, Dr. Ketan Badwa, our past president, Dr. Digant Shastri, and all other members really played an important role. And also in a diarrhea program, ORS Day celebration, which has been done by all our branches. So this needs to be strengthened, where a little bit of enthusiasm has been lacked in the year 2020 because of a COVID situation. Now the things is improving, unless there is a second wave, where we can start looking into that. Adolescent is one of the important aspect in the Indian Academy of Pediatrics, is playing in a major role. This is adolescent is the most neglected age group, both by pediatrician and adults. That is why it was in no man's land. So our Honorable President Dr. Bakul Parekh, along with Piyush Gupta ji, President 2021, so taken an initiative to write to the Government of India as well as NMC to change the nomenclature of pediatrics into pediatrics and adolescent care, where we can take care of an adolescent, which is the most neglected at present, because adolescent care is very, very important, especially to bring down the maternal mortality as well as the newborn neonatal mortality. This is an area where we can focus more and we can make a big change here. And for this, where the guidelines, especially adolescent friendly health initiative, teen site prevention, online module for the school teacher, nurturing of adolescent in schools, it has been launched by Indian Academy of Pediatrics. In the year 2020, where in an indoor pedicon, we launched the Awesome Aya program at indoor, where you can see all the dignitaries of President Dr. Bakul Parekh of 2020, Piyush Gupta ji, J.S. Tuteja, and C.P. Bansal sir, with an adolescent chairperson, Dr. Ajit Singh Chawla and Sushma Desai, within a national scientific convener, Dr. Preeti Galigali, and Dr. Purna Kurkure, where we have conducted, after launching the program, trainer module at indoor. Subsequently, we have conducted a lot of program across India. School health program, which helps in the major health, detecting the major health problem, where so once you detect it, they can refer it to the hospitals, where now a lot of social security programs, which is run by the Government of India, where we can utilize. So, and midday meal program, which has been implemented by Government of India, where the things has been affected because of this COVID situation. This is where we can play an important role. So reaching an unreached where the IAP is doing in a lot of charity activities involving all the branches. This is one of the things which has been conducted with Surat branch, Dr. Chetan Shah, present executive board member, and the caring for the under 5 privileged children, a lot of charity activities which has been done across India. This is one of the coalfield branch of an IAP. Dr. Atan Bardhan, member of IAP, is playing a lot of important role there. So Maharashtra also, within the government of Maharashtra, has taken a lot of initiative. Our Joint Secretary Admin, Dr. Samir Dalwai, along with our President, closely working with a Bal Swastha Karyakram in Maharashtra too. So medical education, this is a lot of revamp is taking place where the IAP is playing a proactive role under our President, Dr. Pish Gupta ji. So we are trying to bring out a lot of changes in the NMC, both in undergraduate and the postgraduate. Apart from that, we need to look at it in other healthcare professionals. How do we train ASHA and Anganwadi workers, where which is related to the care of a newborn and especially in the children, where they can play a major role in immunization and nutrition. MES program, this is a program which has been done by Dr. Ellen Taneja and Dr. A.K. Sharma. So in the year 2019 and as well as 2020, we are conducting in a virtually. So where the medical emergency management for the school children will be taught here. This is the program which has been run when the COVID was not there physically, all those things were been done. Early childhood development is one of the most flagship program of 2020 as well as 21. So we are working closely with UNICEF to roll out more than 300 program across India in the next 3 years, where we are focusing on the cognitive, social, and emotional and physical development. This is one of the core aspects of our SDG goal. So we are already working with UNICEF. So definitely it will make a big change in the development of a child, family, and community, as well as where health, education, and social protection can be important thing, where the pediatrician can play an important role along with an IAP. So this is an early childhood development in 2019. We started in the 2020. It has been implemented. 2021, we are taking it to the more. Initially, we are planning for a 150 program. Subsequently, more than 300 program. We are planning already. UNICEF has been and other pharmaceutical companies has come forward to help this flagship program. Children with the developmental delay and disability. This is one area where which is the most neglected. So I think Anju Agarwal madam knows about it. So this is an area where IAP can play an important role. We are working with a developmental disability chapter of an IAP. Whatever the help which is required from central IAP, we are already offering to them to take it forward. We have in the indoor, we have done in a program on autism, subsequently virtually too. So this is in a program which is a Kawaljeet Singh, secretary of this, and Samir Dalwai. So where we launched the TOT program and we conducted across the India. Strategic planning for the survival of a newborn care. This is the most important thing. We look at that. So what present maternal mortality rate, which is currently it is 130. What SDG goal is looking at less than to achieve at less than 70. We should have been achieved by 100, but the data which is yet to come, we'll see. Neonatal mortality at present it is 24. So planning to achieve it by 2016 in this by 2025. SDG goal to achieve it less than 12. Hopefully we'll be able to do it because we have enough time where IAP can play an active role on that. We are already, our President Action Plan is focused on to this, to reducing the neonatal mortality. Infant mortality rate is another thing. Underpay mortality, where presently it is 39. So this is where we can bring it to the less than 25 by 2030. So total fertility rate, all those things, we can play an important thing in that. What is the phenomenal progress we have made it in the last more than 1.5 decades is we could be able to bring down the teenage marriage, teenage fertility, and institutional deliveries, which has been significantly increased to 78. initiation of breastfeeding, this is where the IAP has played a major role, but still we need to be, so it is around 41%. We should be able to achieve it more. Children with diarrhea received ORS, where the famous IAP has played an excellent role in the 2018, 19, even 2022. So in a prevention of a death because of a diarrhea, immunization coverage is also been improved, but still we can play an important role in that under Mission Indradhanush program. Facility-based newborn care, this is where IAP and NNF is mentoring a lot of SNCU, so where we can give a technical support to bring the quality of care in that. Continued care of a newborn intervention, like just propagating the knowledge of vitamin K at birth, antenatal steroid, that can prevent a lot of things. So Mission Uday and other program we are planning to come out in 2021 to bring down the neonatal mortality. And NRP program is our flagship program, which has been initiated in the year 2009. Now we are conducting virtually in the 2021. Hopefully we'll take it the physical program. This is a very important program which is really helped to bring down the neonatal mortality, especially birth asphyxia and all. So this is how we conducted the program over a year from 2019 to almost a decade, where we conducted a sustained improvement. Because of a COVID situation, it has been, now at the moment it is not going well. We are taking it up in 2021. Dissemination of national guidelines and public health messages through the extensive network of our subspecialty branches, we can play an important role. Junk food guidelines, this is the flagship program of our President Piyush Gupta ji of 2021. So there we are planning already in this line. So in 2021, this will also be propagated. And despite of covering a lot of things by the IAP, still IAP can play a major role in a lot of other things. Yes, we will do it in the years to come. So coverage and quality and equity, gender dignity, this is the most important thing in our things where we can achieve a lot of things. So just I'll end my presentation. So with the quote of Walter, our greatest natural resource is in the minds of our children. That is why Indian Academy of Pediatrics can play an important role. Political will is also important. Our former Prime Minister, Dr. Jawaharlal Nehru ji, has quoted with the children of today will make the India of tomorrow. The way we bring them up will determine the future of the country. Was true even today. This is where the political will is also required along with an IAP. So John F. Kennedy quote, children are the world's most valuable resource. It's the best hope for the future. That's by our USA President. So thank you all. I'm sure with the cooperation of all the branches of our Indian Academy of Pediatrics, we can play a major role in propagating and achieving our SDG goals for the year by 2030, well in advance by India. Thank you all. If there are any questions, we can take it up.
Thank you, Dr. Babsraj. I think it has been an excellent presentation covering the role of the Indian Academy of Pediatrics, the advocacy, making it in a policy decisions. And I particularly feel that as you mentioned, that Indian Academy of Pediatrics, we may also, foster a collaboration, making a consortium with the NNF and the FOXI, because ultimately we have a common agenda of the RMNCH, taking it forward. And second biggest thing which I personally feel, which you also mentioned about in the dissemination to the private sector, because 60% of the healthcare is still with our healthcare, the private healthcare providers. So the government guidelines, they are not only for the government people in the system, public system, but those must be implemented across the country. And it is the role of the FOXI, NNF and IAP to find out the barriers and the challenges so that each member can support the government in the implementation of the various flagship programs which you had talked about. so that ultimately they get implemented. And I totally agree with you. When we talk about the implementation of the program, it should be intact survival, so that disabilities and those also should be taken care of. Thank you very much, organizers, for giving the opportunity, and I'm sure my other co-colleagues as a chair would also like to comment. Thank you very much.
Thank you, Dr. Chilani, sir.
Hi, Manish. How are you? It is always a privilege.
Fine, sir. Thank you, sir.
Hello, Dr. Chilani. Good afternoon.
Hi. Hello, Lalit. How are
It's
you?
a privilege to have you. And hello, Dr. Basav Raja, and hello, all the chairpersons.
Thank you, Lalit sir.
Please
Dr.
carry on, sir.
Dr. Anju, please give your comments, ma'am.
Okay, like it was a nicely conducted talk. Dr. Vasav Raja has highlighted what IAP is going to do to bring down the maternal mortality rate, neonatal mortality rate, and under 5 mortality rate. Under 5 mortality rate actually covers a lot of things. It covers the infrastructure, education, participation with the FOSCI and NNF, which Dr. Chilani highlighted. And so collaboration is very important. Plus, we have to educate the children. So IAP should have a role in formulating guidelines for like early development. They should have a role in formulating the early educative years of the child for proper this thing. Rest, IAP is very way. The tuberculosis control program, malaria control program. There is advocacy, there is education, and there are guidelines for management of these diseases. And IAP is also doing about not.
Rohit, please mute others, those who are.
Hello, you couldn't listen to me.
Yes, ma'am.
Yeah, please speak again.
Sir, please continue. We are, ma'am, please continue. Yeah.
Please continue.
Dr. Vasav Raja has really highlighted very well the role of IAP in bringing down the neonatal mortality as well as the under 5 mortality. We are dealing with the communicable diseases as well. We have to accelerate to the non-communicable diseases also for having a long-term decrease and increasing the quality of life. Because no poverty, no hunger, partnership, they are all the sustainable developmental goals. They have mainly made sustainable development goals as if it is Ram Raj. Everyone will have everything. So we are going to aim for that. And IAP is playing an active role in that. And I thank Dr. Vasav Raju for highlighting these key points.
Dr. Singla? Dr. Singla? Dr. Lalan Bharti?
Lalan Bharti is not there.
So
Madam, Dr. Lalan
Sandeep.
Bharti is busy and we wish him good wishes for obvious reasons.
Dr. Singla was there actually.
Yes, I don't see him now. I would be looking for it.
So Dr. Sandeep, please continue. Dr. Manish, please.
Thank you, ma'am. Thank you, Dr. Smita. Thank you, Dr. Basav Raja, for excellent talk.
Thank
And
you so much,
thank you, our learned chairpersons, Dr. Harish Chilani, sir, whom it is always a pleasure. I was sir's resident in 2001, sir. And thank you, Dr. Anju Agarwal, madam, for your comments. Thank you. So now we will move on to our next session and talk. In next session, we have two talks by two very experienced learned speakers. That is Dr. Anurag Agarwal and Dr. P.S. Narang. For that, I would invite our chairpersons, Dr. Sisir Paul. Dr. Sisir Paul is a very senior pediatrician and director of pediatrics at Rainbow. At Rainbow Children Hospital, and Dr. Sunil Gombar. We all know sir's immense clinical work in pediatrics and hematology. Welcome, Dr. Sunil Gombar, sir. And the other...
Thank you, sir. Thank you for inviting me.
Dr. Dheeraj Bahal.
Dr. Dheeraj Bahl, he is HOD RML Hospital. Welcome, Dr. Dheeraj Bahl, sir. So over to chairpersons to introduce the first speaker and the talk. Please, sir.
Introducing.
Dr. Gombar sir, आपको introduce करो.
मैं कर दूं?
हाँ जी.
Yes, sir. Yes, sir.
Oh, I'm very happy to introduce Dr. Anurag Agarwal, who is a colleague of mine from Maulana Azad Medical College. and he has been working on rabies. I have been listening to him for years, and I learned a lot from him. Today also I learned from him today from rabies. He is now presently the elected EB member from Delhi. He got the maximum number of votes. So I wish him good luck that he takes the IAP forward the next year. Dr. Anurag Agarwal.
Thank you so much, sir. Thank you for the kind introduction.
Thank you, sir. Thank you.
It has been always a pleasure meeting you, sir.
Same here, sir.
So should I start sharing my screen? Because the time limit is 15 minutes and we have been very strictly told कि 15 minutes से ऊपर 1 second नहीं जाना, नहीं तो बंद कर देंगे screen. धमकी दी गई.
Start sharing. Start sharing.
Evidence based medicine says अभी तक किसी की बंद नहीं की गई है.
अच्छा, तो मतलब मैं फालतू में slides कम कर रहा था. मैं आधे घंटे.
That is.
The reason is very clear. We have cultural program.
Is my slide visible?
Yeah, visible.
I'm trying to make it full screen. Let it be full screen. Let me try and make it full screen slideshow. Yeah, great. Okay. So today the topic allocated to me is to talk about only rabies immunoglobulin, and I've been given 15 minutes. So I'll try to do justice to this topic in 15 minutes. So why do we want to talk about rabies? This is the first question. See, this is a very lethal, of course, untreatable disease. And once you had it, you have had it. It's 100% fatal and nearly 100% preventable. The data, which is pretty old, shows around 50 to 60,000 deaths per year, with around 20,000 deaths in India. Although the data which was collected around 2 years ago showed us around 4 to 5,000 deaths. Again, it is the tip of the iceberg, and most patients are not reporting to hospitals. They are being told to go home because there is no cure. So, and another thing is that around 40 to 50% of victims are children, and they are shorter in height. So the animal, the biting animal, which is usually the dog, bites them on their neck, faces, hands, and the upper part of the body. So to the next slide, the question is that which animals transmit rabies? And herein, I would like to say, take it the other way around, which animals do not transmit rabies. I get a lot of calls for rodent bite. Rodents do not transmit rabies. Rabbits have not been shown to transmit rabies in India. Earlier, we were saying the same for squirrels, but around 15 dead squirrels were looked for rabies virus in Sri Lanka, and they were found to contain rabies virus. So now we say that with squirrel bite also, especially if it is unprovoked. I remember one of my medicine residents came to me around 6 months ago. She had a squirrel bite in our parking lot. The squirrel simply jumped on her and bit her. So it was an unprovoked bite. We advised he take the vaccine and the serum. So now we all know the common treatment which is being used is washing the wound, which is very important. It washes off around 80 to 90% of the virus, disinfection and vaccination. But does it always work? So a few case reports I am showing, there are hundreds of cases across the country which we come across nowadays. They are not being published also because it's a very known fact. A lady presented to a hospital with symptoms of rabies. She had received a vaccine. She had been bitten on nose and face, and she developed rabies. Reason? She was not given immunoglobulin. Another case from Aurangabad, same story, vaccine 4 doses given, developed rabies. Reason? RIG not given. Another case for Bangalore. So we have lots of cases. There was a data from IDH hospital. They collected around 20 patients data. Out of them, around 10 to 12 patients had received the vaccine, but were not given immunoglobulin. So what is wrong? Do vaccines fail? Is it so? We all are pediatricians, so we know that as soon as vaccine is given, there is no protection. It takes around 7 days to 21 days to develop protective antibody titers. The same is the story here. The first 7 days are not protected. During these days, we require passive prophylaxis, which is ready-made antibodies. And this vulnerable period has to be specially covered by these antibodies. Another story is that whenever there is a bite on the highly innervated areas like face, neck, fingertips, or there are multiple exposure sites, or sometimes the bite is so deep that a nerve ending is cut. These are the ones wherein the virus is deposited directly on the nerve ending. And once the virus binds to the nerve ending, nothing can be done. There is no treatment. The virus will ascend to the brain and you will have a full-blown case of rabies sooner or later. So these are the ones these patients are at a very high risk. So now coming to immunoglobulins, which is my topic, we have around 4 varieties of immunoglobulins available to us in the market at this point of time. One is rabies immunoglobulin derived from blood of animals. Another is derived from humans. So animal is ERIG, humans is HRIG. And then there are 2 more which are monoclonal antibodies. I'll be talking about them subsequently. So when we talk about passive immunization, the human rabies immunoglobulin dosage is 20 international units per kg body weight. There is no upper limit of maximum dose which can be injected depending upon the size of the wound and the weight of the patient. Equine rabies immunoglobulin, the dose is 40 international units per kg body weight. Again, there is no upper limit. And as per manufacturer's recommendations, the PI product insert, which we all talk about a lot, especially in our practitioner group, is that it mentions that test dose has to be given. Although WHO says that test dose is not required, and recently our NCDC national guidelines and our consortium against rabies guidelines, we have done away with test dosing. The simple reason is that by the mechanism by which the test comes, sensitivity test comes positive, and the mechanism by which the reaction occurs is different. This simply means that if the sensitivity is negative, does not mean that you will not have a reaction. Therefore, whenever you give a equine product, you have to have all the paraphernalia ready to tackle a reaction. In fact, that is true for any injectable which is given to any patient. The whole paraphernalia should be ready. We as pediatricians always keep things because we inject vaccines, so this should be ready. And so now how to do sensitivity? This is also important. We take up 0.1 ml of the serum and we dilute it. We add 0.9 ml more of normal saline. So we make it 10 ml, 1 ml, 0.1 ml of this, 0.9 ml of normal saline. Total solution becomes 1 ml. So that is 1:10 dilution. And we give it on the flexor aspect of forearm as per manufacturer guidelines. On the other hand, ideally a control should be given, which should be plain normal saline. And we observe for wheal, erythema, induration, itching, tachycardia, fallen blood pressure, and feeble pulse. Reaction is positive, you have to go to human or monoclonal antibodies, that is RMAP. So now another important point, we have to infiltrate as much of the serum possible into the wound, and the remaining, if any, should not be given intramuscularly. I have put it in bold. Please do not give any remaining serum intramuscularly. Infiltrate as much as possible into the wound. That is much more important. So inject RIGs into all wounds. This all word is very important. Patient has, suppose by 6 puncture wounds. Normally a dog, when he bites, there are at least 4 to 8 marks, 2 to 8 marks, 10 marks there, depending upon the intensity and the number of bites. And we have to cover all of the bites. Do not leave 1 or 2 puncture marks without RIG, because even if 1 mark is left, 1 bite is left without RIG, the virus from there can bind to the nerve endings and ascend to the brain and cause rabies. We had a case, IDH had a case wherein one of the patients did receive RIG, but still developed rabies. We looked at the case sheet, we talked to the attendants, we found that the patient has had multiple bites. So maybe 1 or 2 wounds were missed, or the virus was directly deposited in the nerve endings. So the next point is that if RIG is insufficient by volume, we have to dilute it with sterile normal saline. Up to equal volume can be diluted. Please do not use distilled water for sterile water for diluting the RIG. And the presently available preparations are very safe. This statement is very important. I personally, when I was in a non-teaching hospital, had used around 50,000 vials over last 4 or 5 years. And in MAMC also, we are using equine product regularly for all our patients. This is available with the government supply. And we have never had to admit a patient to the intensive care unit or the ward with a severe reaction to the immunoglobulin. Yes, there can be a few vasovagal syncopes, etc. And but they are not severe reactions which require admission. So this is a video of infiltration. Again, this video is very important. I'll put off the audio. Let me see. So the audio is off, the baby is crying, child is crying. So what is important here is that the needle is inserted from outside the wound directed towards the wound. And then when the serum is pushed, it should ooze out of the wound. If you look at it, the serum is oozing out of the wound. That is what constitutes sufficient infiltration into and around the wound. If there is a large wound, multiple punctures have to be made to inject the serum. So this is one video. Let me see if there is this is the same video. So this is another video. Here you can see multiple punctures are there, and maybe this is an adult or there is no audio luckily. So infiltrating from outside. Here a bleb is being literally a bleb is being raised. Another wound. So all of the wounds are being covered one by one, and this technique is important. Do not go through the wound. Go from outside the wound towards the wound. So the third wound being covered. So these were the videos we made from our rabies clinic when the sister was giving it. And if you can see, there is some amount of oozing from the wound, and this is sufficient. So all the wounds are being covered. So another one of our female lady patients, she was being injected onto the face, another child being injected on the eyelid, eyebrow area. This patient is being injected into the neck region where he was bitten. So now what are the various kinds of immunoglobulins available to us? Equine. So equine, there are three brands available to us. One is Equirab, another is Averic, third is Winric. So these are the three brands available to us. They are all of equally good quality. Humans, we have two brands which are available, Berirap P from Bharat Serums and Suya Echeric from Prosper Life Sciences, Delhi. So these are both imported products being marketed by these two companies, and presently these two are available. So now what are the problems with equine rabies immunoglobulin and human rabies immunoglobulin? One is limited availability. So the equine product is made from horse serum. Large horse farms are created, animals are brought in, then they are injected with the vaccine, made hyperimmune, then their plasma is tested. Finally, when they have a lot of antibodies, their plasma is drained from them, and the product is made and then marketed. So this again is of course against animal rights also, but this is the way this product is made. Another problem with HRIG is high cost, because the same story goes on with humans and the cost is pretty high. It is an imported product not being manufactured in India. Third is the safety profile. See, ultimately they are made from serum and blood, so there could be a theoretical risk of blood-borne pathogens, and there can be a high risk of severe allergic reactions with the equine products, especially type 1 and type 3 anaphylactic reactions. The type 3 serum sickness with equine immunoglobulins is this immunoglobulin which we talk about. And of course, the skin sensitivity issues which have to be managed with the equine product. So what do we have? So currently we have rabies monoclonal antibodies. There are two varieties available. One is fully human rabies monoclonal antibodies. It is the fourth generation, most advanced, available at present, available in our country since 2017. And the dose is 3.33 international units per kg body weight. The other product is murine, which is mouse rabies monoclonal antibody. This is the first generation antibody, and it is available. It has been made available over the last 4 to 5 months. Dose is 40 international units per kg body weight. So what is this murine and human? So I just made a slide, although I'm not an expert on this, but I try to understand what is it basically. So the murine one contains all the sequences in the antibody are from the mouse, whereas there is another variety which is known as chimeric, which contains both mouse and human sequences. Humanized contains mainly human sequences, but there are some mouse sequences, and human contains only human sequences, and there are no mouse sequences. So if you have an antibody which is completely human, the chances of developing of autoantibodies, that is anti-antibodies or anti-drug antibodies, are very, very low. So that is the advantage of having a fully human antibody. So RMAP, which is now marketed as Ravishield, is completely human IgG1 monoclonal antibody that binds to the ectodomain of G glycoprotein. So this is a very highly preserved region on the virus. So there were some issues that suppose a mutation takes place, what will happen? Will this antibody be protective? Yes, it will not be protective. But this G glycoprotein has been found to be highly preserved. It does not mutate at all. That is the reason this product has been marketed, and this product was tested against around 25 different isolates of wild type of street isolates of rabies virus, which were collected from India, Asia, Africa, and it was found to neutralize all the viruses. All these 25 wild isolates which were which were collected from these regions. Only one which was collected from Peru, I think, was causing a problem. But remaining, so the viruses which are prevalent in India, Asia, and Africa were all neutralized. And a study was conducted, comparative study was conducted, wherein this vaccine plus HRIG was given and vaccine plus RMAB was given in Syrian hamsters when they were injected with the wild virus, and it was found that the protection was similar. So this is the publication. And then there was a phase 2, phase 3 clinical trial which was held comparing with HRIG in India on humans. And it was a multicentric trial. The results were excellent. In fact, at day 14, it was found that the titers, protective titers were very much higher than the with RMAB as compared to human HRIG. So ultimately WHO accepted it and said that a single monoclonal antibody product which was licensed in India has found to be safe and effective and should be used. Finally, NCDC also, after a lot of persuasion, agreed to the product, and this product is being is made available across the country and is marketed in around more than 18 countries across the world. And we are doing a phase 4 trial with this product also. The target was 4,000 patients, but courtesy Corona, the trial is going slow. And till date, I have enrolled a huge number of patients and we have never had an issue. So again, the dose is 3.33 international units per kg body weight. This is comparable to 20 units per kg body weight of HRIG and 40 of ERIG. So what does it mean basically to us as a clinician? So when the bite wound is small, we cannot inject a large amount into the wound. So this is a highly concentrated product, and therefore it will give you a better virus binding when used as compared to the other two equine or human rabies immunoglobulin. And therefore it will be less painful to the children, more convenient to doctors, and saves a lot of time to both the doctors and the patients. So it has been a well accepted product. It is available in two strengths, 50 IU and 100 IU. And a slide on murine monoclonal antibody. So this is the first generation monoclonal antibody which contains two monoclonals, Docaravimab and Miromavimab, that binds to site 2 and 3 of the glycoprotein. And the dose is higher because what the authors and the manufacturers claim is that because they are using two monoclonals, so 20 of one and 20 of the other, so it becomes 40 IU per kg body weight. And so they wanted to do an equivalence trial with HRIG, that because the dose of HRIG was also 20, so they said we will take 20 of one and 20 of the other. They conducted a non-inferiority trial which was published around 4 months ago. I have put in a correspondence also because a lot of claims were a bit fuzzy, and therein they reported ADAs in around 60 to 70% of the patients, anti-drug antibodies. So this simply implies that only this product can be given only once in lifetime. It cannot be repeated if the patient has not completed the complete vaccination course. Another thing is that no sensitivity testing is required. It has been recommended for use by WHO, and it is more expensive than the product, the other monoclonal antibody product. So to summarize in a table format, all the 4 products available. Equine was the product which has been used over last 60 years. HRIG has been available for last around for 35 years. Murine RMABs were developed around 35-40 years ago, but are available for last 6 months. And fully human was developed in 2008, but is available in the market for last 3 months. Sources we have discussed: horse serum, human serum, and the remaining 2 are, of course, from mouse and human antibody. Dosages 40, 20, 40, and 3.33 IU. Immunogenicity is a major problem with ERIG. We cannot repeat the ERIG because if you repeat ERIG in a patient who has not completed a course of vaccination, in case of second or third bite, there are chances of type 3 hypersensitivity reaction coming early and more severe, and can even lead to anaphylaxis again because of the ADAs. Whereas this is not a problem with HRIG. This is a problem with murine cocktail RMABs because of ADAs, and fully human RMAB, this is not a problem. Again, serum signals like ADR, anti-drug reaction potential, is there with ERIG and murine. It is not there with HRIG or fully human RMAP. Cost, ERIG is the cheapest, available in all government setups. HRIG is the costliest and available in 3 or 4 government hospitals across Delhi. Murine is costlier than ERIG and fully human RMAP, but cheaper than HRIG. And fully human RMAP lies somewhere between ERIG and murine cocktail RMAP. So it is somewhere at number 2 as far as cost is concerned. Some states in the south have also procured it in their national programs also. So to summarize, RIGs are the missing link in rabies prophylaxis. Simply means that use a monoclonal, use an antibody, use a rabies immunoglobulin in case of animal bite category 3, whichever what variety the patient can afford or you want to use, but use some kind of a RIG. Please do not send the patient without RIG in category 3 bites. How to find it is a category 3 bite? Any bite which bleeds is category 3. As simple as that. If there is a doubt, that was it bleeding or not, look for a scab formation. If there is a scab formation, it is category 3. Still there is a doubt, move a spirit swab over the area which the patient says that he was bitten. If there is some kind of burning or some kind of burning sensation, it implies that there was a breach in the dermis and epidermis. Use of RMAP and RIGs is a must in all category 3 exposures, along with vaccines and wound washing. Amongst all options, RMAP is a safer and more cost-effective option, and medico-legally also prescriptions of RMAPs and RIGs is a sound strategy. And with this, let us end rabies together, and we should target rabies 0 by 2030. This is our target, and let's hope we are able to achieve it together. A lot of activities are going on dog sterilization and dog vaccination, but because of Corona, things have been put on hold. But the plan is that to sterilize dogs across Delhi in next 2 or 3 years. Let us see what happens, because the budget is now also a constraint. And thank you so much. For any further queries, you can always send us a mail, look at our website, and of course, I'm always available on telephone. Thank you.
Thank you, Dr. Anurag, for a crisp and nice presentation on a very life-saving problem. And nowadays, of course, with monoclonal antibodies available, we are still getting a lot of, previously HRIG was a lot short. At that time, somebody from NICD has suggested use a double dose of rabies vaccine as the first dose if you don't have immunoglobulins. Is that still true?
Sir, yes, it was a strategy around 10 years ago, but now we have ample amount of immunoglobulin available across the country. So that logic does not stand. Even if we give a double dose, that will not give us a protective antibody titer in next 3-4 days. So logic does not hold at all.
That is an extreme probably when it is not available at all.
Yeah, so that was a old story, long time back. It has been removed from all protocols now.
Anurag, I have one thing to say. That in the end, the note is very good that you end rabies by 2030. But keeping in mind the epidemiology of the rabies, the countries which have even end the rabies, we are at a very frivolous stage. You see, you really can't end the rabies.
Exactly, sir.
Is it a right statement that you can end the rabies?
Sir, at least we can control it to the extent that we get very infrequent cases, to the extent that...
Yeah, that's right. But we can't end the rabies because of the epidemiology as such. Even in the North Americans and other places where they have not been able to contain because of the, you see, so much of migration and so much of vectors being there. Anyway, it was a very nice presentation, Anurag. Nice.
So basically, 96% cases of rabies are caused by dog bites. So yes, the 4% cases will always remain, which come from the wild, and they are the ones which act as reservoirs. I totally agree with you, sir. So this is a slogan to motivate people. Let's try and end TB, end rabies. So we have an NTB strategy also, National Tuberculosis Elimination Program. So
maybe we can have end rabies deaths.
So once you develop rabies, only 15 cases till date have survived. So they are anecdotal case reports. Otherwise, once you have rabies, you have had it. It is a condition which does not have any cure.
We have to keep our targets high, then only we can achieve.
Yes, bilkul.
Dr. Anurag, I have noticed many children, say about 4 years of age or 6 years of age, when they visit a government facility for dog bite, they are given tetanus shot regularly without asking whether they have received the first booster at 1.5 years or second booster. Even if sometimes I have told my patients you don't need a tetanus for next 5 years, but they still get it.
Definitely, I understand. If you
Ajay, if I can answer, you see, logistically, you don't have a card when the people reach the government setup. And there is no clear documentation. I understand you would have told them, but as a logistic problem or seeing the children from the lower strata, what I feel is it is better to inject tetanus toxoid rather than, so that is why in general we give it.
You're right.
The problem was rabies, tetanus was given, but the RIG was not given.
So in fact,
Dr. Anurag, Dr. Sham Kukreja wants to make a comment.
Please, sir.
There is some Sylvian cycle of rabies. Dr. Sham, sir, please.
There is a Sylvian cycle of rabies in the jungles, in the forest.
Yes.
So no can eradicate rabies from the.
Yes, definitely, sir. I agree with that. So that is the reservoir. Otherwise, if in the dogs the virus does not survive for more than 10 days. So that is the reason. If you remember, there was an observation period. So the issue was that where is the virus coming from? Which is the reservoir? So it is the Sylvian reservoir in the wild, which is providing the virus to these animals, the dogs.
Very nice talk. Very nice.
Very nice.
Anurag, one thing. Anurag, can I have one word from you?
Definitely, sir.
अनुराग,
हाँ सर बताएं।
सर आप हर बार जो हमें एक ही आप पढ़ते हैं कि 20,000 डेथ्स इन इंडिया, हर जगह यही लिखा आ रहा है कितने।
बिल्कुल सर, मैं इसका रीजन बताता हूँ आपको।
एंड सेकेंडली आपने बोला कि सभी डॉग्स को हम स्टरलाइज कर दें, व्हाई नॉट वैक्सीनेट द डॉग्स?
बोथ सर,
क्योंकि स्टरलाइजेशन से वो थोड़ी ना होगा, वी आर डिक्रीजिंग द पॉपुलेशन बेसिकली।
सर both things are planned. When you sterilize a dog, you vaccinate the dog also. It is not a single thing which is done.
Then it is okay.
चीज होती है, साथ में ही होती है, sterilization and vaccination. So if I go into that, it will take a lot of time. Next session delay हो जाएगा आपका, but
thank you, Dr. Thank you. Let us move to the next talk. Chairpersons, please introduce the next talk and speaker. Dr. Dheeraj Bahl, sir.
Anurag, please stop your screen share.
Right, sir.
Dr. Gombar, sir, you can introduce, sir.
Well, I will be too pleased to introduce Parminder Singh Narang, because I have studied together with Dr. Narang. And I learned a lot from Dr. Narang. We used to study from our pre-medical days. And then he went to greener pastures to UK for Great Ormond Street. And we continue to stay back at the Maulana Azad. But I am very happy that he is a colleague of mine, and we keep talking to each other off the screen also. And it is so that he is talking on a very important topic. He is head of the department of the Max Hospital, Shalimar Bagh, along with the Dr. Chitkara, who also happens to be my colleague. And he is talking on a very important topic, which is a very practical topic, because he is a very practical person. He always takes a topic which is very important at the present scenario. So he's talking on commercial immunity enhancers, whether it is a myth or truth. Dr. Narang.
Are you able to see my screen?
No.
No.
No?
No, you cannot start sharing the screen.
No.
I am able to see you.
Okay, wait. Look, I want to share from my end, please.
Please.
Sir, share screen दबाया आपने sir? Have it clicked on share screen?
Okay, wait.
On the bottom of your screen, there is a green button, share screen.
Rohit, you have sir's presentation?
No, I know. I want to do it myself.
So you will definitely do it, sir.
Okay, wait.
So green button दबाएंगे, फिर आपका एक
Okay, okay, okay.
उसमें आपको okay
Yeah,
करना है.
done. Yeah.
There, sir, it is coming. Yes, it's visible, sir.
Okay. Right. Okay. First of all, thanks for giving me this topic. Although Dr. Gombar says a practical part of it, yes, practical part of it. And I'm very thankful to Dr. Kukreja, who said that I should be doing this topic. The rising age population across the globe, the number of 80 plus are increasing, and they are going to be tripled to 425 million in 2050. So everybody is talking about increasing of your immune status or increasing your health, because this is a scenario of anti-aging. And with the present coronavirus coming up, this is a famous saying that every challenge, every adversity contains within it the seeds of opportunity and growth, by Roy J. Bennett. So befitting in today's time and future ahead, everybody is going to talk about how to be anti-aging, how to keep on looking young. In fact, today, Hindustan Time, there's an article by Dr. Sinclair from Australia that we can reverse the aging because he was able to generate the cells into the retina by injecting. So these are the things which is coming up. From the time when we had a famous Ayurveda Kada to the commercial preparation, 2020 is a year of building health. Today, everybody is talking that we want to remain alive. We want to remain well. Tell me or tell us the way we can do it. Now look at this. April 24, 2020, Ministry of Ayush formulated Ayush Quath for immunity boosting of the masses for the COVID-19 pandemic. And look at the ad. Ayush Quath is the only approved possible remedy for COVID-19 recommended by Narendra Modi. I don't know where they brought this and selling it at 780. So, whereas if you look at what is Ayush Quath, तुलसी 4 भाग, दालचीनी 2 भाग, सौंठ 2 भाग और 3 ग्राम लेकर 150 ग्राम गर्म पानी में डाल के पीजिए और आपकी कोविड नहीं होगा. But at the same time, this simple, and I listened to Modi's speech of 2.5 minutes promoting Ayush. He never promoted any product. He did say that Ayurveda has a big potential of reversing or improving your health. Friends, the race was on. Everybody says बीमारी से लड़ने के लिए क्षमता बढ़ाएं. हमारे बाबा रामदेव, आयुष क्वथ, stay immune, immune tablets, immune boosters, not only immune boosters, immune Rice Krispies, and everything is latest to immune, and that is Hamdard, Ayush, and everybody. Not only that, in Ahmedabad, they started making sweets. Usme giloe, long, kali mirch, soont, tulsi dal ke sweets khai. Immunity booster sale reaching high and high and is growing by 7.5%. Chavanprash, elderly products, haldi doodh, super products. And look at this there here, a product for sleep, product for play, product for work. So there are things, and long going on is Yakult and all detox products and Tulsi. Come on, let's increase the sale. Dauber serving Kala Langar to the police so that police takes it, no problem, sell it to everybody. Ayush distributing immunity tablets. Then go vegan, join us in the service of healthy, become vegan. But then KFC says immunity boosting by chicken because they added vitamin B6 in their chicken, or chicken has vitamin B6. So immunity boosting, whether that holds anything, let's look at this. How to build child's immunity and protect them from assault. whether this immunity booster or immunity enhancer or health has got a different meaning. I did talk to my Ayurvedic consultants, and Ayurvedic pillars, Triya Upasthama, the pillars of Ayurveda. The three pillars of Ayurveda are Ahar, a balanced diet, enriched with haldi, jeera, black pepper, dalchini, adrak, so on. And it says, eat your Ahar after sunrise and before sunset. Nidra, a sleep, adequate sleep type. So, Ayurveda is not talking only of only eatable thing, but it is talking about Nidra. And then it's talking about Brahmacharya. There, it comes with two words. Acharan is the way we live our life, and Brahman means infinity. So a lifestyle which leads to immunity has three components. Vyayam, get up in the morning, exercise. Ahimsa, non-violence. Truthfulness, satyam. Santosha, that whatever you have, you should have contentment. Shaucha, cleanliness. And non-indulgence in lustful thoughts, actions, or speech. So Ayurveda has given that pillar that to remain healthy, adopt to this Traya Upasthama. And that is very important. And everybody use this. And then Ayurveda explains that these are the three doshas, Vata, Pitta, and Kapha. And I'm not going to detail because it revolves around the five tattva we are made of: air, water, earth, fire, and ether. And Vata is mother, Pitta, and Kapha is grandfather. And we all have three doshas. Maybe one is more prominent than the other, and then they have diets for this. So then oxygen radical absorbent capacity. This has been there, and they have high in spices and herbs, and high in a lot of the fruits, highest in avocado, highest in mangosteen. And you need to take about 500 ORA key capacity per day. But if you take more than 5,000 in a day, you are wasting. It's all coming out in your thing. But making all these things complicated, everybody wants a shortcut. And that shortcut is all these products which are giving advertisement on ORAC, we're giving advertisement with various health supplements and so on. But let's see what WHO says guidelines for protection from COVID. WHO says you develop a three-layer protection: your body, surface, and space. You develop this protection, external protection, and you develop an internal protection. See, the NIIA triad gives everything in very shortcut. If you have a good nutritional status, you have a good immunocompetence, you have a good ability to fight infection. So 1, 2, 3, NIIT triad. But if that triad becomes disturbed, you are micronutrient deficient, you are malnourished, you suppress your innate immunity, you decrease your adaptive immunity, it reduces your T cell mediation, and that causes a dysregulation of the host response, a loss of immunity, so more infection. That altered metabolic pathways affecting nutrient utilization causes all this problem. So now, friends, you see, if you look at this defense, fortifying immune modulation, they are nothing but actually, if you have a deficiency, they give problems. Layer 1 is a physical barrier, and the immunomodulator for that are vitamin A, C, E, and zinc. Layer 2 is a cellular immunity: B6, B12, D, C, folic acid, iron, zinc, and copper. Layer 3 is antibody production, and that is all except vitamin C. So various types of immunoboosting agents by ingredient, they have vitamins, minerals, herbal and botanical extract giving high ORAC, amino acid, probiotics, omega-3 fatty acid, and the sources of them are like plant-based or animal-based. If you have a deficiency, we know that if you have a deficiency, to maintain your immune health, there is a problem. So adequate levels of folic acid, B12, are the measures for your immune dysfunction if you are deficient. And that immune deficiency is depicted because you are deficient in these things. But then role of vitamin D. So directly saying role of vitamin D is only there if you have a deficiency. If you don't have a deficiency, then these are not the things to be used on and on. Vitamin D supplementation play a role in the prevention. But advertising that it's treatment for COVID-2 infectious disease is not right. So immune response to virus, definitely in a population which is deficient in vitamin D, may be a problem or may not be a problem. Very important, we all know beneficial role of iron during childhood. Oxygen transport, metabolism, immune defense, cellular immunity, motor and cognitive development, and that prevents infection. So iron deficiency has undernutrition, and undernutrition has low immunity. So friends, when all these complicated things were there, everybody wanted a shortcut. And that shortcut was, okay, instead of improving your health by a proper Ayurveda method, by a good physical exercise, let's take antioxidants. I know all these colorful things are antioxidant, okay? These colorful things are antioxidant and they are very, very good. There is undoubtedly our spices, cinnamon, clove, herbs, they're all full of antioxidants. These antioxidants help for the oxygen transportation in the system. And as I said, some of the antioxidants like cranberries, elderberry, the count is around 13,000 per 100 gram. We need about 500 units of ORAC per day. So we don't have to eat 200 grams of all these things. I've seen cases, people eating 60 to 70 grams of haldi every day to prevent infections. So that kind of a scenario is continuing, and we are now looking at these shortcuts by eating cloves, organos, beta carotene, antioxidant. So let's add colors to your life and diet. Don't go on to all these products which are there. My take-home message is immunity booster is not a medical term. It is often used in common parlance for foods that have antioxidant properties. But these are the part of a balanced diet, which maintain our immune system and general health. I repeat, immunity booster or immunity enhancer is not a medical term. A healthy immune system can only be achieved with adequate sleep, a balanced diet, exercise, adequate sunlight, unless the patient is suffering from immune system disease, such as immunodeficiency, AIDS, bone marrow cancer, or chemotherapy. They don't require immunomodulation. They require adequate amounts of all the three things, which is a diet, rest, exercise, and that is it. With that 219 coronavirus COVID-19 pandemic, it is essentially important to understand that no supplement diet other than lifestyle modification, other than physical distancing, other than social distancing and proper hygiene and a mask wearing can protect us from COVID-19. All these products are making a big thing. Immunity is not one thing. There is an immune deficiency which have a specific treatment. These are the deficiencies of minerals, cofactor, vitamins, which have a specific problem. And apart from treating iron deficiency, folate deficiency, and vitamin deficiency, all these products are not required. And one of the consequences you see when you have a inflammation, a lot of time we are using steroids to actually suppress the immunity. And that is important because one of the consequences of stimulating or overacting your immunity is the absence of infection is inflammation. So we don't want to increase the cytokine response. And why immunity enhancer? Who is healthy according to doctors, according to parents, according to industry? According to doctors, health is a physical, social, and mental well-being. But still, lot of parents ask for unnecessary prescription of tonics. Doctor sahab, bachcha tagda nahi hai, kuch to de do. You cannot spend too much of time and then you end up writing some tonics, which they take home, they give it for a few days and they stop taking it. And according to parents, healthy child is an obese child. A healthy child is the one who do not pick up any disease. For them, even one cold, they say, bachche ka immune system weak hai, kuch to de do. Industry exploit this and manufacture lots of supplement and with non-authentic studies and sell these so-called immunity enhancer. We use these products to prevent any infection. So friends, rightful prescription is to holistic approach which treat their deficiency, give them infection prevention advice, and give them proper counseling. The global immunity boosting food. This industry has reached 1 billion and is growing at 6.2%. And after 2020, it's growing by 7.5%. And it's going to be 10 billion in 2030. It's going to be 29 billion. So look at the growth from 1 billion to 29 billion by 2030 is all because we are looking for a shortcut. In summary, my friends, a good diet, eating lots of greens, lots of colorful things, vegetables, fruits, eating in a right manner, eating good healthy diet, exercising, remaining fit, and keeping yourself in a good state of mind in an unstressful way is the only way you can improve your immunity, your health. Thank you.
Thank you. Nice talk.
Great talk.
Thank you.
Thank you, Dr. Narang. It was really wonderful talk. Our chairpersons, please give your comments, sir. Please unmute yourself, Dr. Paul and Dr. Gombar, sir.
Dr. Gombar, please unmute yourself.
Dr. Gombar, sir, please unmute.
Sir, click on the screen, the speaker screen. Dr. Paul, you can speak, sir. You are unmuted.
Yeah. No, I just said it was an excellent, crisp presentation. And at the end of the day, it is a natural way of life. Our immunity doesn't lie in a bottle of tonic or a strip of tablets, as Dr. Narang has nicely composed. And in a brief presentation, he has enlightened what we should be doing in our clinics, not writing those tonics after tonics.
I could have gone into more details about the Ayurveda part and a lot of those things. You know, the best, the commonest fruit, elderberry and cranberry, and they are put into the bottle, and even Tata is selling this as a immune booster. And though they have a very high ORA value, which is very, very helpful. And then, you know, I mean, it is not a replacement for your diet. It's not a replacement for your exercise. So in combine, the immunity booster word, immunity enhancer word is something which should have been eliminated. And I have in my clinic, like when we give vaccination, we talk about their development, we talk about their nutrition, and we talk about prevention of infection. So that is a holistic approach in giving the proper advice. But of course, Ramdev has done a business of 500 crores on Coronial alone, and the 20, and in fact, if you look at the difference, India is hardly anything. That 500 crores hardly anything. If you look at 29 billion industry, and the commonest is everybody has been abroad. We buy gummies of vitamins and gummies of fruit extract from the health shops, and you can easily have them by putting them in gummies in the shelf. I don't know how long they're going to last, whether really by the time you take them, they're worth it. So the best is to take the natural products. I mean, I'm very much clear that the haldi, cumin, they all are very good, but taken in moderation. And the last thing which I did put in the slide, I forgot to mention, I asked the physician, they are seeing more cases of hypertension because they are eating
Thank you,
too much
sir.
of.
We'll have to move on to next session, Dr. Naran, sir.
We're getting late. Short of time.
Thank you, Dr. Shishir Paul, Dr. Gombas sir, and Dr. Dheeraj Bahl sir. And this was really a wonderful session. The take-home message is, while my wife takes care of immunity and diet, and Dr. Naran sir, I would like to invest in the immunity booster companies for next 10 years. That will give good return. So let's move on to the next talk. And for this, I invite our President-elect, Dr. Lalit Mehndiratta. He has few important announcements to make, and also he'll conduct the next session. Dr. Lalit Mehndiratta, sir, please.
Thank you. The esteemed faculty is doing a wonderful job for last 3 days. I can understand the virtual programs not so easy. I'm really thankful to all the chairperson, speaker, our delegates, technical staff. It has been a wonderful program which is going on for last 3 days, and today is the penultimate day. And I welcome you all again on behalf of IAP Delhi President-elect next year.
Rohit, please share the slides.
My dear friend, Secretary Manish Gupta, I will just take 1 minute to announce, make 2 announcements. First of all, we wish everybody a very good, happy new year next year. I wish this pandemic is over. We will meet more physically. And we start with IAP Delhi with the program of PCNI again, as we our tradition of IAP Delhi. The proposed dates has been 11th and 12th. We wish, pray God, and everyone I pray should pray that we should have a physical PCNI next year. So registration is on from tomorrow. And Manish, we can start from today. It will be possible.
We can start, sir. Everything is ready. As you and Dr. Nath say, we will launch it, sir.
And we have the those who candidates, the delegates who are registered with us for last year, they need not register. The new registration will be 2,000 rupees, and it lasts till 31st of March. So we hope, and this will be another mega event like this one. And the second more announcement, so we will be sending the link. And Rohit,
Rohit, second slide, please. Rohit.
Yes, sir. Yes, sir. Yes.
Please show the second slide. And we start our new year with the pediatric rheumatology updates, and it will be done virtually because of the corona pandemic. The dates are 14th and 15th January. It will be the afternoon session, and we will enrich all pediatricians, the general basics of hematology. And we have the eminent rheumatologists who will be also joining on for a session, Dr. Sujata Sani. And of course, we'll be going this program from 2 to 5 p.m. And it will be a virtual program. All IAP members can register with the link of 200 rupees and non-IAP members for 300. I hope this program will be a wonderful beginning of the next year, and we hope this pandemic will gradually go away. I wish everyone a good and God bless everyone. And now I come to this program.
I wish the new team all the best for the next year, and my and Dr. Samita's services are always there whenever you.
Sir, you're always there. So
Thank you, sir. You are always our team, our guide, sir.
And I can see so many faces in front of me.
Thank you, Dr. Smita, madam.
Dr. Prashant, Dr. Shyam Kukreja, and every one of us, Doctor. And hopefully
And I want to make one announcement for the delegates. Those who have registered with us for 2,000 or 2,500, 500 are deducted this year. The rest of the money will be utilized for your registration for next year.
Thank you, Dr. You are already in, sir. You were not visible that time. Actually, screen में यही तो problem है. Somebody छुपा के बैठा था. और वो photo गायब हो जाती तो you can't see. This is the minus point. Dr. Kukreja, I can see only the picture. Dr. Kukreja, I can't see. You know, he's there, but physically he's there. Anyway, I start the next session, and I wish we have the blessings of all the esteemed faculty next year. And next program, our session is on short stature. So I would like to invite the chairperson for that. And it will be a very useful panel discussion for general pediatrician. And I can assure you that for chairpersons are Dr. IPS Kocher, please. And nobody can know he is the specialist of pediatric endocrinology and his consultant at Indraprastha Apollo Hospital and has so many awards, sir. I cannot enumerate all because the time is not that much. Second chairperson is Dr. Manpreet Sethi. And she's an eminent pediatrician and also a consultant pediatric endocrinologist. And next chairperson is Dr. Deepa Pasi. She's a consultant at Noida Apollo Hospital. She's also working on adolescents and adolescent health, and she's also a pediatrician. And another chairperson is Dr. G.P. Koshal, and we very well know him. He has been the past IAP president, and he's a wonderful. And nowadays, he's also a CIP executive member, and he's a wonderful human being. So we begin the session. I will request chairperson to please start the session, and please be brief, and we can finish in time. Thank you very much, sir.
I think the moderator you forgot. The moderator is Dr. Vaman. The moderator is Dr. Vaman.
You please introduce, sir. You please introduce the speaker.
No, I am supposed to moderate, Dr.
Yeah,
Lalit.
he is supposed to moderate.
Acha. Dr. Vaman is going to what?
Okay, thank you.
Excuse me, Dr. Vaman is our esteemed faculty and he is going to moderate this session. I am really thankful to him that he accepted this invitation because he was so busy. Actually, we have to change the schedule for him, and I think he will be really wonderful moderator for this session, and we are going to learn so much from him. Thank you very much, Dr.
We all know about
Vaman.
him. We are all following the IAP growth charts being developed. He's also a consultant pediatric and adolescent.
So you are invited, Dr. Vaman. Please take over and introduce your panelists.
Thank you very much. So we move on, and I'll now share my screen so that I can tell you what the plan of this panel discussion is. So I hope you all can see my screen. Can you? Can you all see my screen, please?
Yeah, can see.
Okay. So as already said, we have this wonderful three panelists. Dr. Kaushal has dropped out. So we have IPS Kochar, Manpreet Sethi, and Deepa Pasi. They have already been introduced, so I won't spend time on that. We have 50 minutes of time to go through short stature, which of course is a very big topic. So I have this theme that I'll actually introduce the anthropometry and short stature basics for 10 minutes. And then we will move on to the panel discussion with our esteemed panelists. And then in the end, we will take question and answer for 5 minutes. Okay, so let's talk about short stature. We believe that children are actually not bothered about short stature, but it is untrue actually. Somewhere there in the back of their minds, they're always thinking about it. And every now and then, these poor little things might be sitting there in one corner and thinking as to why am I short, but they cannot express themselves. They start expressing themselves only when they get to the age of adolescence, when actually it is too late. And it is not unusual for me and Dr. Kochar and all those who do pediatric endocrinology to get a referral for a boy at 18 who is now fully developed into a man with beard and mustache, and for a girl who has been menstruating for years together, for their short stature to be treated. The important thing is that if pediatricians actually monitor them properly, they can pick it up early and refer early, so we can help these children. So I urge all the pediatricians to actually do growth monitoring. And I once again would like to emphasize that you all are great when it comes to taking weight of patients because you have to calculate the dose. But when it comes to measuring the height, I must say that it's a bit disappointing. So I do urge all of you to please take heights as well, at least once in 3 months in infancy and once in 6 months later on. So does it matter? Now look at this beautiful photograph that I have. This is Barack and Michelle Obama, and this is Sarkozy, the French premier. Now look, this man is the chief of France, and look what he's doing. He's lifting his feet to look at least as tall as his wife. So if short stature actually matters at this stage of supremacy, can you imagine a common person feeling so bad when he or she is that short? So it does matter at all levels. People may not be expressing it, but it does matter. So how do we actually define short stature? So you define short stature by studying the growth of a child. So anthropometry is the most important tool to diagnose growth disorders in children. It's therefore very important to learn and understand growth charts, growth parameters, and growth monitoring. So for a pediatrician, how do you know that a kid is short? So first thing to do is measure on an accurate stadiometer. You should have a good stadiometer fitted there on your wall, not a wobbly paper sort of a thing that doesn't give you accurate measurements. So in an infant, please use infantometer. In a child, use a wall-mounted stadiometer. Please measure both parents. Don't depend on what they tell you as their heights. People who come and say I'm 6 foot are often just 5 feet 7 inches tall. So please measure them. Use IIP 2015 growth charts for older children. And for younger children, IIP modified WHO chart. Plot the height and weight. And children below the 3rd percentile line are considered to be short or stunted. Now in 2007, together with my esteemed colleagues, I wrote the growth monitoring guideline for Indian Academy of Pediatrics. They were updated in 2015. So for those of you who want to know how to monitor, how often to monitor, what is child health surveillance, this document can be used as a template. But understand the chart. See, the top line is the upper limit of normal, 97. Bottom line, the 3rd percentile is the lower limit. In WHO growth charts, you have a 1st percentile line. That's very abnormal, severe stunting. And the middle line is the average. Same is true for weight and head circumference. But very few pediatricians I have found out recently are actually using weight for length charts. See, these are extremely important. You can only comment on nutritional status of a child who is young if you do weight for length, and for an older child, BMI. But these charts are a little different. The upper limit is 99th percentile because WHO gives a lot of allowance for babies to be fat. But as they grow older, that thing comes down. And the orange line is the 3rd percentile. That's for moderate acute malnutrition. And the 1st percentile is for severe acute malnutrition. Similarly, for older children's IIP chart, same thing. 3rd percentile is the lower limit of normal. Green, the upper limit of normal. Blue is the average. Same is true for weight charts. But when it comes to BMI, these charts have been fitted for Asian Indians as 23 adult equivalent cutoff for overweight and 27 adult equivalent cutoff for obesity. So they are lower. If you look at WHO charts, they're 25 and 30. But for Indian children, you have to lower them because we are thin fat Indians. In the sense, for the given BMI, our fat percentage is much higher. So these have been lowered as per the International Obesity Task Force guidelines. Now remember the ICP model. When has the child first developed short stature? If the child is short in infancy, it's nutritional defect. If the child is short for the first time in childhood, it's thyroxine or growth hormone. And for the first time coming as short stature in puberty, it's generally sex steroids. So nutrition, thyroxine growth hormone, and sex steroids. So remember, when was the first time short stature developed tells you what are the disorders you are looking at. Now, these are the formulae for mid-parental height. Once you have taken the parent's height, you should use this simple formulae, mother's height plus father's height plus 13/2 for boys and minus 13/2 for girls. And then you add 6 to 8 centimeters above and below this mid-parental height to get the mid-parental range. And where do you plot it? You plot it here as these red arrows have shown. So you plot it at the age of 18 years. So you know that this child's target height is on the 10th percentile and the spread is below 3rd percentile to just about 25th percentile. And then when you plot it, after correction, this red dot is the actual height of the child. And you see here that he is below the 3rd percentile. But when you do the correction for the mid-parental height, as you can see the black arrows here, he falls within the mid-parental height percentiles. So it's important then to look at the child's position when compared with the mid-parental height. Now see, growth deceleration alone can be abnormal. So you may have a child who has, say, had brain tumor, who was somewhere here within normal range, and then after a few months he comes back to you, he's still within normal range, but look at the deceleration. When you plot his growth velocity, it's here on the right side of the panel. He is way below the 3rd percentile line. So you can actually see that growth deceleration alone can be abnormal. And these are the Indian height velocity charts, which our group has published in Indian Pediatrics in 2019. So you can use the Indian growth velocity. You don't have to use the Tanner velocity charts anymore. These are the simplified Indian height velocities. First year 24 centimeters, second year 12, third year 6, and then until puberty 5 centimeter per year, and during puberty you get a very nice growth spurt. Now look at the proportion of the child. Am I looking at a short child who is disproportionate? And which side is shorter? Is it the upper body or the lower body? If the lower body is short, it's skeletal dysplasia. If the spine is short, it's metabolic or storage disorders. These are simplified upper segment, lower segment ratios. At birth 1.7, 3 years 1.3, 9 years 1, and adolescence 0.9. Now we have these Indian upper segment, lower segment ratios as well, which we have published in Indian Pediatrics in 2019 again. So you can use the Indian proportions of upper segment and lower segment. They are a little different than the Caucasian. Our children become 1:1 earlier than the Caucasian. At 7 to 8 years in girls and 9 to 10 years in boys, it's 1:1. Now this slide is pretty important because depending on how short the kid is, you have a diagnostic group. If the child is just below the 3rd percentile, you are looking at familial or idiopathic short stature, constitutional delay in growth and puberty, chronic malnutrition, or an SGA sequelae. And we have a talk coming up on SGA by Dr. Deepa. But if the child is very, very, very low, then you are looking at a serious disorder, such as a skeletal dysplasia, a hormonal disorder, a syndrome, bone disorder, or severe chronic disease, such as chronic renal failure. So if you look at the differential diagnosis of short stature, there are normal variants, which are very common, familial and constitutional delay. Then there are abnormal variants, which are disproportionate, as I said, or proportionate. In proportionate, prenatal insult is IUG or SGA, then dysmorphic syndromes, chromosomal abnormalities, and postnatally, it is endocrine, psychosocial, malnutrition, and chronic disease. So these are the common causes of pathological growth. They are endocrine or hypothyroidism, growth hormone deficiency, Cushing syndrome, or you have this endocrine and the picnic, as we call it, as psychosocial, iatrogenic, chronic disease, nutritional, SGA, chromosomal, skeletal dysplasia. Now, this is the investigation pyramid for short children. You start at the baseline with CBC, ESR, bone age, urine analysis, kidney function test, calcium, phosphorus, venous gas, albumin, and transaminases, thyroid function test and karyotype in girls. And these top ones, I think you should leave for the specialist to perform. This is the last slide of my introduction, is an approach to short child, normal looking or abnormal looking. If abnormal looking, can I diagnose a syndrome? Or is it disproportionate? If the disproportion is severe, short limbs, skeletal dysplasia, short spine, storage disorders, mild hypothyroidism and constitutional delay. If normal looking, follow the growth velocity. If you have low growth velocity, then do a bone age. Normal bone age is short normal child. Retarded bone age is endocrine disease. If you have normal growth velocity, then you have a short normal child, which is either idiopathic or familial. Now, we have also produced Turner syndrome charts for India, and they are published this year. And this is in Indian Journal of Endocrinology and Metabolism. And now we can use our own Indian Turner syndrome charts to plot Turner data. You don't have to use the Michael Ranke's Turner syndrome charts because they're quite different to Indian Turner charts. And last month, we have put up user-friendly growth charts for pediatricians because I realized that pediatricians are very, 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 very busy people. They don't have time to calculate BMI, or they don't have time to calculate mid-parental height. So I have eliminated that. I have given pediatricians now a quick BMI lookup tool here in the corner. So all that you have to do is look up the weight against the height, and then you get whether the kid is normal, overweight, or obese. And I have eliminated the MPH calculation as well. All that you have to do here on the right side is join the father side to the mother side, and wherever it falls is the percentile for the child. So I really wish and hope that with these two important calculations eliminated, my dear pediatrician friends will actually monitor more effectively and will be more useful for the family and the child and for India as a whole. With that little introduction, I would now like to move on to our panel discussion. And our first panelist is Dr. IPS Kochhar. And IPS is going to talk to us about case scenarios in growth hormone deficiency. So over to you, IPS.
Yeah, I'll just share my screen. Can you just stop sharing and I can share my screen?
Yeah, I stopped it. Yeah.
Good afternoon, Dr. Nob, Dr. Smith, and Dr. Lalit. So thanks for inviting me for this talk here. We'll start off with, all Dr. Vaman has given us very nicely. He has shown us the way forward to things, and he has made things very, so all the basics have been well covered by Dr. Namit. Dr. Vaman, and he has told how to, and thanks to him, now new growth charts have come up, which is very, very pediatrician friendly. So I think more and more people will start plotting in the skin. So I will talk about a short stature. First scenario is an 8-year boy who's referred by a pediatrician with short stature. The height is 110 centimeter, which is less than the third centile, which I show you on the growth chart, the IEP growth chart. The weight is 15 kg also, which is less than third centile. The parent's height, mother is 160, father is 168. So, and this being a boy, it'll be mother 160 plus 13 plus 168 divided by 2, which will show you what exactly it is. A year back, his height was 108 centimeter. So his height velocity is basically time in change in centimeters upon time in years. So which is basically 2 centimeters in last 1 year. So 2 centimeters per year. So he's he's not going at all well. So it's other relevant history which is available is the birth history. He's a term, birth weight 3.5 kg, no midline defects, is developmentally normal. The growth history, they noticed that, this child was doing well and they started some faulting, started occur by the age of 3 years. So his height velocity was less, but it's not actually monitored. So in the past history, there was no history of any chronic disease, any tumor, CNS tumor or radiation. We are very particular trying to find out, so anything central causing any problem for him. No dysmorphic features, so skeletal is unlikely, other like Turner, Noonan, other things are out. Turner will not be able to get for girl, Noonan, other possibility. System examination is all normal. So all system is out. Neonatal period, something significant there. There is some perinatal asphyxia. There was hypoglycemia during his neonatal period, and he had a prolonged jaundice. So the radiological examination, there was no pituitary lesion seen. So this is the growth chart, which is showing what's happening. So you have the mid-parental height. This is 160. Mother's height plus father height per 30 divided by 2, which is 170.5 centimeters. And this is his, height velocity, which is 2 centimeters per year. So he was here. After 1 year, he came down to here. So he's going away from the third centile and also moving away from the mid-parental height. So that may definitely there's something going wrong. Any child who crosses 2 major centiles during the growth period, they must be evaluated. Something is definitely going. And this child is very, very short to the mid-parental height also. So definitely this child needs to be evaluated. So what was done was, seen, the important thing which was done was height age was seen, bone age was seen, and a weight age was done in this child. So the height age is how do you do it? As with Dr. Vaman's growth chart, you just draw perpendicular downward on the 50th percentile. So what is the meaning of height? Height age means age at which the height is on the 50th percentile. The weight age is weight at which the age is at the 50th percentile. Bone age is bone maturation, age at which the bone matures on the 50th percentile. So here how you draw perpendicular from up to here, like down on the 50th percentile, again pointed downwards on the x-axis. So this is your height age. In the same way, the weight age, you draw perpendicular down the 50th percentile, again perpendicular downward. This is your weight age. So you have the weight age and the weight age. This is there. Now, the height age is approximately, which is given here, is on 5.2 years. The weight age is, 6.8 years. So you have this condition where the height age is more affected, weight age is less affected, chronological is 8 years. The important thing to, as Dr. Mohammed mentioned, that you must have the, range. So in this child, if you draw the range also, he's still very short. So his range is like 170.5 plus 6 and 176.5 minus 6. So 164.5. So he's still very short. 164.5 is somewhere here. So he's definitely short. So everywhere he's short. He's from all definitions short. So you have seen the height age is more affected as compared to the weight age, and the bone age is delayed. As Dr. Wamani mentioned, bone age is delayed in most of these patients if they have these issues. Now, seeing further, the further investigation were done because we were thinking in terms of maybe an endocrine cause, thyroid function test was normal, his cortisol and ASTH was normal. The other anterior pituitary hormones, all these just in 8 years old, was prolactin, cortisol, FSH, everything was normal. A growth hormone stimulation test was done. You can do a clonidine, you can do glucagon, you can do, which is available in India. Arginine is not available, GRH is not available, insulin is less down now because the new society has said that whichever growth hormone stimulation test you use, the guidelines GRHS 2019 that whichever you use, it does not make all have the same specific sensitivity. So use, but you must try to prove it by 2, at least stimulation. So growth hormone stimulation tests were done. The release was 4 nanogram per ml in this patient. So this is quite low, and minimum you have to take. The new guidelines is 7. Earlier we were taking 10 nanogram per ml. If it is less than 10 nanogram, then that means it's growth hormone deficient. So therefore, this patient was started on growth hormone therapy, so which is 0.60 milligram per kg per week, and or which is 0.02 unit per kg per day. So that is approximately, it's just 1 unit per day. So 1 unit per day, the growth hormone started on this patient. So what did you get in this case? For a pediatrician to learn, this basically what was there. This we had found that because every pediatrician do a height age and a weight age, all this can be easily done. And the chronological age was more than the weight age, more than height age, 8, 6 point and 5.2. And the child is short and thin for the age, but the height is most affected. See, the weight was also less, the height was also affected, but the height is more affected as when you did the weight and height age. Then the next thing came out was when such a situation occurs, when weight is always more, most of the time it's likely to be endocrine disease or a skeletal dysplasia. Now, since the child had no dysmorphic features, and it was proportionate, so therefore they are unlikely to be skeletal. So most likely endocrine cause. The other international pointers, in the neonatal period, the child had perinatal asphyxia, hypoglycemia, prolonged jaundice, and there was the history was there that it was normal going, there was faulting started at the age of 2 to 3 years of age. Radiological examination, no pituitary lesion, abnormal pituitary, and proportionate short stature. So most likely to be an endocrine cause of short stature. So it indicates this thing. This was an isolated growth hormone deficiency where all the other hormones were normal. The thyroid function tests were normal, the cortisol was normal, all the other prolactin, everything was normal. Now, so therefore, in this case, you have, once you've drawn the height velocity, weight velocity, you've drawn all the things. So this patient was started growth hormone, which I told you 1 unit per day. So when the patient was started on growth hormone, what was the outcome of growth hormone therapy, which was started on this patient? So you can see a growth hormone initiation was done here. And with the time, the child picked up and he started going up, up, up and going up. So what makes a difference is this, maybe this child will see a GHD deficient because he was quite deficient. But patient who has started late, they will not maybe reach that. So again, the thing, as Dr. Warman just reinforcing the statement that early diagnosis and early referral makes a lot of difference. So guy had gained occurred over a period of time with growth hormone initiation. Coming to another case scenario 2, the present history is there's a 10-year, 8-month-old boy come with a complaint of same poor height gain noticed for the last 4 years. Birth history, there was nothing like in the last patient, we had some problem. The neonatal period, there was uneventful neonatal period. The past history, there was no history of any systemic illness, no history of any facial puffiness, medial lethargy, constipation. We're trying to rule out hypothyroidism or the factors. Then systemic, we ruled out. We're trying to see anything in the CNS area. So vomiting, there's no history of vomiting, no posture giddiness, no history of failure try ruling out other causes. And development history was very normal milestones. So he's, it's quite short, but he's a normal milestone. So height is 113. So very short, you can see his height is less than versatile. Height age is just 5 years. His weight age is 5.5 years. Again, weight is 18 kgs on the weight age. The other parameter which was on this child of 10 years, 8 months was that he had stretched penile length of 4 centimeter, which is less, testicular volume 1 ml. No midline facial defect, and the voice was high pitched. So this is, this we find in this child. So the other, immediately, the investigation, some were done by, as Dr. Mohammed said, there's some investigation done at the pediatrician and some at the specialist level. So the investigation which was done, hemoglobin was 10 gram done by the pediatrician, thyroid also done by the pediatrician. He did not understand it. He said that, sir, लगता कुछ गड़बड़ है. T4 इसका 38, but TSH तो normal है इसका. So this is something to, there's something catchy here. Serum creatinine was normal, so kidney function tests were almost normal. Serum calcium was normal, phosphorus was normal, so unlikely to be any kidney cause or, rickets or hypophosphoric. Bone age was very, very less, 5.4 years, so marked delay in the bone age. So cortisol was 60 nanomoles. This was actually done at the, at the endocrine level, 60 nanomoles, which is on the lower side. ACTH was also low, 5 microgram, the normal 11, 8 to 8. So therefore, this child had something else going on. So with this investigation, one can say that maybe the child had something wrong happening in the pituitary area, his he was secondary hypothyroidism. So TSH is normal, T4 is low. So the secondary hypothyroidism, the cortisol levels are also low. So therefore something is happening. And then, a stimulation test was done. Now it is very important to understand the stimulation test will only be done once you have corrected the thyroxine you have given to the patient, corrected the thyroid function, and you've corrected cortisol. So first thing is to correct the cortisol. Once you have given hydrocortisone, once you give hydrocortisone, your cortisol levels are fine. Then you can, after some time, give thyroxine, because if you give thyroxine to patient who's hypocort, he might go into crisis. So therefore, growth hormone is to be only tested only once you have corrected the thyroxine, once you have corrected cortisol levels, and then only you can do. So growth hormone stimulation was done after doing all this correction. So the clonidine stimulation test was found to be very low. So at 0 minute, 1 nano, 30 minute, 1 nanogram, 61. So as you can see here, whether you use a new definition or the old definition, it is very less than 7 even. So therefore, this patient definitely had growth hormone deficiency along with hypothyroidism, secondary hypothyroidism, along with hypocortisolism. So maybe in the future, I might have, something wrong with this, LH and FSH. So maybe with those also may be involved. Gonadotrophin may be involved in the future. That only with time will come to know. So it looks like that because his penile length is also less, and restriculum. So MRI was done in this patient. It showed sign of pituitary hyperplasia. So the pituitary was solved. So immediate diagnosis came, it was a case of panhypopituitarism. So in the first case, we saw there was deficient growth hormone. In the second case, also is growth hormone with other hormone involvements. So the treatment was started in this patient follow-up. Child was started on, as I already told you, hydrocortisone thyroxine was given before the growth stimulation test. Once growth hormone test showed that, so he was started on 0.7 milligram per kg a week of growth hormone. He gained 22 centimeters in 2 years. These people respond very well once they are started on proper hormone treatment. They do very well. And the child need to be monitored every 3 to 6 months. With the height velocity, you must do a T4 levels. Whether you do a free T4, you must do a T4 level because TSH has not the role to play. And you do an IGF-1 to see whether the growth hormone you're not crossing. So you maintain T plus minus 2 standard deviation. The IGF-1, you do the electrolytes for cortisol, and to see for any other adverse effects of like any problem with losing of growth hormone. So just a quick 2 slides of what is growth hormone deficiency in children. It is one of the endocrine causes of short stature, height more than 2 standard deviations below the population mean. The incidence is 1 is to 4,000, is 1 is to 10,000. So it's not very, very tough. But maybe we're not getting so many cases in our country is big, and there are a lot maybe in the rural population, there'll be so many patients who need treatment. It is defined as to cut off based on growth homeostasis as complete or incomplete. So growth hormone may be isolated or in combination with other hormones, which we showed in both the cases. The etiology of growth hormone, this every pediatrician asks, kyun hua, is idiopathic in 60% of the cases. We do not know the cause. In the known, it is a known, in the case we have the known, we have it, the causes may be congenital or genetic in 50%. So there's some gene effect, a lot of genes which are involved, and there may be some abnormal pituitary. So therefore, maybe the pituitary stalk is small, or maybe it's ectopic pituitary, maybe, there is a hypoplastic pituitary. And the acquired organic is 25% with the CNS tumors, CNS radiation, CNS infiltration, trauma, RTAs are known to cause this. It is we have seen 1 or 2 cases after RTA. So what are the normal clinical pression? Growth retardation, increased subcutaneous fat, especially of the tongue. In the Indian phenotype, it may not be like this. In the Indian phenotype, you might find thin patients also who may have GHD. So this is just just to make you understand it. Small hands and feet, sparse hair, high pitched voice, small chin, doll-like faces, and a micropenis, which you saw in this patient, one of the patients. The diagnosis is very, very important to take clinical and oxygenal criteria whenever you talk about growth hormone deficiency. You cannot just rely on the growth hormone stimulation. All the guidelines mention like this. So the various stimulation tests, insulin, arginine, clonidine, and glucagon, the peak growth concentration below 10, new GRS guidelines, they say less than 7. Bone age is very important. MRI, according to the case, you may need to do MRI. So the treatment is start early as possible after diagnosis confirmed. The objective of giving growth hormone to this patient is normalization of height during childhood and attainment of normal adult height. So subcutaneous, it's a subcutaneous injection which is given every evening, 0.025 to 0.05 milligram per kg per day. And if growth hormone still persists after we have completed growth, so the definition of growth completion is if you have achieved a bone age of 14 in a girl, bone age of 16 in a boy, or you are growing less than 2 centimeters, 2 to 2.5 centimeters per year, you have to stop growth hormone. So once you have given a team and you still find that it may be contributing to it needs to further, so you have to retest and it may be required for full somatic adult development, including lean body mass and bone mineral equilibrium. Thank you very much for your kind intention. I give the mic back to Dr. Vaman.
Yeah, thank you very much, IPS. That is absolutely delightful. And I think you covered the entire aspect of GHD and MPHD. But once again, we will, in the conclusion, we will of course have this point, but 2 points that I would definitely take home from your talk is that early diagnosis, proper investigation, and appropriate dose is what you need to do for GHD. Thank you. So we now move on to Dr. Manpreet's talk on Turner syndrome, another common condition seen by pediatric endocrinologists. So I would request Dr. Manpreet to share her screen and continue with Turner syndrome talk.
Yeah, I will do that. Is my screen visible?
No, I think IPS, you just have to stop.
I stopped sharing.
Is the screen visible?
No, not yet, madam.
I already stopped sharing.
Yeah.
I'll share. Desktop.
Do you have a backup, Vaman, so you can start from your side?
Yeah.
But just a minute. Is it visible now?
No, it's not coming.
Why is it not coming? Because there are some.
Oh, it's half coming, not came.
No, now it's
It's there?
yeah, it's
Visible now?
Yeah, it's come now.
It's visible, right? Sorry for the technical glitch. So good afternoon, everyone, and thank you very much, the organizers and Dr. Vaman Kadilkar for this opportunity. We'll straight go to the case. So this was a 9-year-old girl who came to the clinic with her parents.
No. There's some other slide coming.
Conclusion.
This I think Dr. Vaman's.
Dr. Vaman, I think I'm sharing the screen.
I think Dr. Vaman, you have to stop sharing, then she can share.
I did that. Just Manpreet, you may just have to once again share your slide.
Okay. I'll just do this once more.
Yeah.
Yes, now we can see.
Yeah.
Clear
now?
Yeah.
Yeah. Okay, so this was a 9-year-old girl who had come with her parents with complaints of short stature. Parents said that she was always short and as being growing very slowly as compared to her peers, is not outgrowing her clothes and shoes like other children usually do. On a detailed history taking, there was no evidence of any underlying systemic disease, any features of constipation, any other features of any chronic underlying illness. And except for the fact that the parents were quite categorical about the fact that the child was scholastically weak. Her birth history, she was a full-term, appropriate for gestational age child with a birth weight of 3 kilos, and family history was non-contributory. So this is the child. On examination, if you can see, she was a rather short and stocky built girl. There was no obvious facial dysmorphism, but on looking closely, there was a mild right divergent squint. The right earlobe was mildly deformed. There was a little hypoplastic tragus. She had dental overcrowding. She had a rather short and wide neck, a pretty shield kind of a chest with widely spaced hypoplastic nipples. There was cubitus valgus. And though her metacarpals were by and large fine, her left foot metatarsals showed a hypoplastic 4th and 5th metatarsal, and the nails were very characteristically hyperconvex, narrow, small nails. So these were the features noticed on examination. On coming to the anthropometry, she measured 114 centimeters at 9 years, which is clearly below the 3rd centile. And it fell at a score of minus 2.5 standard deviations. Her parents were also both short, but mid-parental height was 152 centimeters, which was about 1 standard deviation below the mean. And weight was rather fine. around the 50th centile. Now, if you see, between her height standard deviations, her height standard deviation score was significantly lesser than the mid-parental height standard deviation score also. All right, let's go further. Now, as Dr. Kadarkar and Dr. Kochar have elaborated in the presentations before, once we have a short stature less than the 3rd centile, it warrants a full workup. So the first line investigations or the baseline investigations, which I am not repeating, done for her were pretty normal, including the thyroid profile. Bone age was 9 years, which was same as her chronological age. So the next step as per management of any short child is actually looking at the growth velocity. However, none of her previous height records were available, so retrospective growth velocity charting was not done. But because she was less than the 3rd centile and she had subtle dysmorphic features, the next investigation as per protocol that was ordered was a karyotype, which made the diagnosis very clear, and this was a case of a pure monosomy 45XO. Let's come to the management now. Once we diagnosed her with Turner syndrome, she was first screened for all the comorbidities associated with Turner syndrome as per protocol, and luckily for her, nothing was found. Management was then started for augmenting her growth with growth hormone, which is started in a slightly higher dose than in growth hormone deficiency, as told by Dr. Kochar in the previous investigation, in the previous presentation. Now, when we look at her growth, progress of her growth on this Turner specific growth chart, so the treatment was quite rewarding. In the first year itself, her height velocity increased to 8.5 centimeters per year, and she was slowly climbing the growth chart and she was crossing the centiles. Now she is 12 years of age, and over the last 3 years she has accumulated 20 centimeters. She has added 20 centimeters to her height. Here I would just like to compare it with Dr. Kochar's case in the last slide, where the patient of growth hormone deficiency actually gained 22 centimeters in 2 years. Turner syndrome, of course, they do well with growth hormone, but not as good as children with growth hormone deficiency. All right. Now she is 12 years of age, and the next management will involve her timely induction of her puberty. I'll be talking about this in the coming slides. Let's just first look a little bit at Turner syndrome. Turner syndrome contributes to about 3% of the cases of short stature in India. It's a rather common genetic condition, with the incidence being somewhere between 1 in 2000 to 1 in 2500. The mechanism of growth failure in Turner syndrome is manifold. Most importantly, there is skeletal dysplasia because of absence or haploinsufficiency of the SHOX gene, which is expressed on the short arm of the X chromosome, that is missing in Turner syndrome. There might be a mild growth hormone secretory dysfunction. There is, of course, estrogen deficiency because of underlying gonadal dysgenesis in Turner syndrome. And any undiagnosed autoimmune diseases like hypothyroidism or celiac disease further worsen the height outcome. Now, growth faltering in these girls actually begins rather early, and they fall below the 3rd centile by early to mid-childhood itself. Growth rate is typically low. They don't have any pubertal height spurt because of absence of the estrogen effect. And finally, untreated girls end up with a height of around 136 to 142 centimeters in the Indian setting. That is about 20 centimeters less than the average height. So what do we do? What can we do to augment their growth? So the answer is growth hormone. Growth hormone treatment is very rewarding in cases of growth, in cases of Turner syndrome, and it significantly improves the height outcome. It should be started as soon as growth faltering is noticed, and higher doses, as I said, are required of growth hormone for Turner syndrome as compared to growth hormone deficiency. And final height in Turner syndrome girls will actually depend upon when growth hormone was started, what was the dose that it was given, and for how many years could it be given for the child. Also, pure Turner syndrome girls, pure monosomies, don't do as well as the mosaic Turners, who do slightly better. And another aspect about optimizing growth for these children is actually the timing of the induction and the completion of puberty, which needs to be carefully looked at. Now let's just look at this growth chart of a girl who was diagnosed rather early at 3.5 years of age, and she was started on growth hormones so early. As you can see, over the years, she has gained significant height and has ended up somewhere close to the target height. So this is because with starting the treatment early, her duration of treatment has been long enough for her to accumulate few centimeters every year, so that it all adds up in the end and gives a good cumulative final height. Now compare this with another girl who was diagnosed late and started treatment late. So although she has done better than what she would have done without growth hormone, she ultimately did not end up having as good a height she would have had the treatment started early. Okay. After growth, the next aspect of management of Turner syndrome is puberty. We know that most of the girls of Turner syndrome will not develop spontaneous puberty, especially the pure monosomies. So pubertal induction has to be done at a particular time, and the best time which studies have found for optimizing growth is around 12 years. We shouldn't wait very long to delay the induction of puberty, because that does not improve the height outcome. It is done using conjugated estradiol, which is the estrogen of choice, and it is started in very low doses with very gradual increments at about 6 monthly intervals till a full adult dose is achieved after about 2 to 3 years. Now we have tried to give the girl all the secondary sexual characteristics with this estrogen therapy, and we have prepared the uterus now for a withdrawal bleed. And this is the point where we add progesterone, and the girl can achieve menarche, and this therapy is continued throughout life. Having talked about the growth,
we only have 9 minutes left, and we have Dr. Deepa.
I have only, this is my second last slide.
Yeah.
Okay. So having talked about growth and puberty, the next aspect about management of Turner syndrome girls is actually looking for comorbidities, actively screening them for comorbidities at diagnosis, and then following them as per protocol. Amongst these, the most serious that require dedicated follow-up are the cardiac abnormalities, specifically the left-sided heart defects, which require supervision under a pediatric cardiologist and regular follow-up as per protocol. Sensory neural hearing loss, recurrent otitis media leading to conductive deafness is also very common in Turner syndrome girls, requires to be looked at diagnosis and screening regularly every 3 years. These girls are also prone to developing metabolic syndrome, obesity, and regular metabolic profile checking is recommended. Autoimmune disorders such as thyroid disorders and celiac disease are more common in this subset of population, and again need to be screened at diagnosis as well as every year or 2 years. And this completes actually the whole type of management of Turner syndrome, that is for growth, for puberty, and for comorbidity screening and then follow-up. I would finally like to end with certain key messages about Turner syndrome, that it is a relatively common genetic condition. It may present with all the classical features of Turner stigmata, few features, subtle features, or with no features at all. So we should have a relatively high index of suspicion. It should be suspected in all short girls. Karyotype is the next investigation to do after the baseline workup in all short girls, even if there is absence of any particular Turner stigmata, before we evaluate them for the growth hormone IGF axis. And early growth hormone and timely pubertal induction significantly improves the height outcome in these girls. Thank you.
Thank you, Dr. Manpreet, for that excellent presentation. So picking up requires clinical suspicion, start early, give a higher dose, and treat for many years. That's the key messages. Thank you for that. So we now move on to our next speaker, which is Dr. Deepa Pasi, and she's going to tell us about the SGA and growth in small for gestational age children. So I would request Dr. Deepa to share her screen, please, and start her talk. Dr. Deepa, I think you're muted still.
Dr. Deepa, please unmute yourself. Dr. Deepa, please unmute.
At the bottom left-hand side of your screen, there is a mute button.
Yeah, thank you. Share.
And you need to share your screen.
Yeah. Is it visible?
Yeah, it's coming up. Yep.
Okay. Yeah, okay.
It's visible right down to the bottom of your talk.
Yeah, is it okay?
Yes, but you will have to go straight to your section, your talk.
Okay. First I do the slaughter, huh? Just a second. We can't see on
Dr. Deepa, should I tell Rohit to share the slides?
No, I have started it.
Okay.
Give me 2 seconds.
Okay.
Right? Is it visible now?
Yes, yes.
Yeah,
okay.
Please carry on. Yes.
Yeah, good afternoon, good evening, everyone, and thank you for giving me this opportunity to be among the elite endocrinologists, Dr. Burman, Dr. IPS, and Dr. Manpreet. And my sincere thanks to Dr. Burman and Dr. Manpreet for guiding me through this PPT. We'll come to the case history of an SGA. It's a 7-year-old boy with short stature. There is no history of any systemic illness. Development is normal. Scholastically, it is good. Always shorter and lighter than peers, somewhat fussy eater. The birth weight was 1.6 kg at 36 weeks of gestation. Birth length not available and an uneventful NICU stay for 7 days. The family history was unremarkable. Now coming to the anthropometry, which has been emphasized all throughout the this PPT, is that weight was 17, which was minus 1.67 standard deviations, and height was 107, which was minus 2.57 SD, and the mean parental height was minus 4.9 standard deviations. On examination, there was no dysmorphism, no disproportionate, no history of Russell-Silver syndrome. Here I'd like to point out that SGO can be syndromic, and one of the syndromes is Russell-Silver syndrome, which we're not going into it. We're just dealing with SGA with catch-up growth. The thyroid was normal, prepubertal, the Tanner score was 1, bilateral testicular volume was 2 ml, and there was no systemic problems. The growth velocity past 2 years about 4.5 centimeters per year, following the same curve, and the prospective over the next 3 years was 4 centimeter per year, and near normal growth velocity rules out the growth hormone deficiency in this particular case. The insulin growth factor 1 and the insulin growth factor binding protein 3 were normal for age and the bone age. The investigations, all baseline investigations were normal, bone age 7 years, and it was not delayed. Diagnosis was small for gestational age with failure to catch up. Management is growth hormone. We gave 0.045 milligrams per kg per day, daily subcutaneous injections, and dose was higher than in growth deficiency. Growth and growth velocity followed over the next 6 months in this particular case. So in this, when the pre-treatment was there, the height velocity was 4.5 centimeter per year, and this was where the growth hormone was started, and the growth velocity increased by about 8 centimeters per year. Now, the follow-up, the child is 11 years, height is 138 centimeters, the gap has been reduced to minus 0.64 standard deviations. Height gain was of plus 1.9 standard deviations over the baseline, still prepubertal, and the IGF-1 levels maintained about plus 2 standard deviations. Now coming to the definition and the epidemiology of the SGA, well, SGA has been used to describe a neonate whose weight or the crown heel health at birth is at least 2 standard deviations below the mean for the infant's gestational age, equivalent to the 2.3 percentile based on the derived data from an appropriate reference population. This is very important because the reference population data will be totally different from one country to another. Now, the definition of SGA is not straightforward. It requires the following things: the accurate knowledge of the gestational age, and ideally, it is based on the first trimester ultrasound examination. So one must take the maternal history nicely, accurate measurements of birth, of weight, height, and head circumference. This has been emphasized throughout the panel discussion. So it is very, very important that as a pediatrician, we should monitor the weight, height, and head circumference at all well baby visits. A cutoff against reference data from a relevant population. This cutoff has been variably set at 10th centile, 3rd centile, or at least less than 2 standard deviations. Now, the prevalence of the SGA preterm births by the United Nations Millennium Developmental Goal region in 2010, the prevalence of SGA babies range from 5.3% of live births in East Asia to 41.5% in South Asia, and the prevalence of preterm SGA infants range from 1.2% in North Africa to 3% in Southeast Asia. 2/3 of the small for gestational babies were born in Asia, and preterm SGA babies total 2.4 million, and maximum were born in India, Pakistan, Nigeria, and Bangladesh. Sorry. Now, to the etiology of SGA, it is multifold: the maternal factors, placental abnormalities, and the fetal factors. Maternal complications can be chronic infections, systemic lupus erythematosus, fibroids, birth weight, parity, age, short and long intervals between births, previous stillbirth, socioeconomic status, maternal education, maternal drug use like smoking, alcohol, marijuana, drug usage, then the gestational age, weight gain, and the twin pregnancy, anemia, and epilepsy. All these have the bearing on the outcome of an unborn fetus. Placental abnormalities are preeclampsia. Other placental abnormalities in the fetal are multiple genetic syndromes, intrauterine infections, inborn errors of metabolism. Now, the small thin babies, there are two things. One is the intrauterine environment, and the other is the fetal genetics, which has a bearing on the baby's weight. The poor intrauterine nutrition has a direct effect leading on to small thin babies, and same as the gene influencing insulin resistance will cause small thin babies, and all of them cause insulin resistance, leading on to susceptibility of these children to type 2 diabetes and cardiovascular diseases. Clinical assessment of SGA newborn. Well, SGA newborn, the condition is this, and checkup for clues is the maternal placental factors, the physical examination, and the medical history. They can be, the diagnosis is either symmetric or the asymmetric. Now, in the symmetric, there will be low birth weight and birth length, and as well as the birth head circumference. Whereas asymmetric, it will be low birth weight and birth length, but the head circumference is spared. Same is the case with maternal placental factors. Now, why is it important to take the maternal history of birth length, head circumference, and gestational age? It is because you can compare it with IUGR, that is SG or AGA, proportionate or disproportionate, and history of IGR, drug intoxication and infections. Also, what will be the interpretation? These all lead to growth retardation in utero and can lead to SGA birth weight, and 15% of the SGA children do not catch up in height. Feeding history.
Last 2 minutes we have, Dr. Deepa.
Okay, I'll just hurry up. The endocrine consequences, well, the IGH axis, the mean IGF and the IGF binding proteins, 3 levels are reduced. The hypothalamic pituitary axis is spared. Puberty, well, it is affected in SGA normally or slightly advanced with no effect on the gonadic function or the fertility. But it has also been seen that female born SGA, the age at the pubertal onset and the age at menarche are advanced by about 5 to 10 months, and the prenatal growth restraint may be associated with higher FSH levels and smaller internal genitalia in adolescence. The ovulation rate may be decreased in adolescent girls in SGA. And whereas the males born with SGA, there is high risk levels of FSH and low levels of inhibin B and a low testicular volume during the adolescence. Growth pattern of SGA, about 80 to 95% babies who are born SGA do show catch-up growth soon after birth. But the catch-up growth is the acceleration in growth of SGA babies after birth. This results in the infant reaching a length or and weight equal to or more than the third centile, that is falling between the -2 standard deviations. The maximum catch-up growth usually occurs in the first 6 months, but may continue up to 2 years. So 10% of the SGA babies fail to show catch-up growth despite good nutrition after birth. They continue to grow up at a percentile that is lower than -2 standard deviations and the target height percentile. Hormonal determinants of short stature in SGA. We have already discussed this. Now 60% of the children shows low spontaneous growth hormone secretion over 24 hours. Management of short stature in SGA. Two things we have to see: the failure to show catch-up growth and the blunted pubertal growth spurt. To help these children achieve normal stature, it is important that they have a good catch-up growth. Now, endocrine management, growth and puberty, early evaluation is very important, and the growth hormone has been approved by the FDA and the European Agency for the Evaluation of the Medicinal Products. Children with a recognized syndrome respond less likely to growth hormone than to the non-syndromic SGA, which we have seen in this particular case. Treatment emergent adverse events are not more common during treatment with growth hormone in this population, and nor have additional safety concerns have been arisen. Now, the patient selection for the growth hormone therapy: SGA children who do not show catch-up growth till 2 to 3 years of age, height less than -2 standard deviations for the population, the predicted adult height for at least 1 standard deviation below the target height to eliminate the influence of the familial short stature. Catch-up growth is better if treatment is started at a younger age because it is more cost-effective. Dosage is about 0.2 international units kg per day is efficacious and safe at initiation of therapy. When rapid catch-up growth is desired, lower doses can be used if long-term therapy is planned. Prior to starting treatment, it's very important that the BP should be checked. Samples for lipid profile, fasting and postprandial glucose, and fasting insulin should be taken. GTT tests with insulin levels have to be seen, and BP should be monitored. And the above tests should be performed every 3 months to 1 year, depending upon the degree of risk, along with the routine lab tests doing and with the growth hormone monitor therapy. Key messages: 10% of the children born SGA do not show catch-up growth and end up as short adults. Lack of catch-up growth in these children is probably due to the abnormality of the growth hormone IGF-TEC axis, often due to maternal, fetal, or placental problems and/or exposures or idiopathic. SGA infants have relative growth hormone resistance, seen as elevated growth hormone with low IGF-I levels. The growth hormone therapy leads to growth acceleration and normalization of height during childhood. Long-term growth hormone treatment normalizes the adult height. Growth hormone therapy is safe in SGA children, but it is important to monitor for side effects. And over to Dr. Vaman for the keynote. Thank you.
Thank you, Dr. Yeah, I would. Okay, so I only have this slide of conclusions, which actually is pretty clear according to what our esteemed panelists have said. So primarily, it's a common condition, short stature. Understanding the anthropometry for pediatrician, I think, is the key. And growth monitoring is necessary part of child health surveillance. Please use the IAP modified WHO charts for under 5 children and IAP growth charts for children older than 5 years. Pediatrician-friendly growth charts where BMI and MPH calculations have been eliminated have now been prepared, and this month are on the IAP website. I request all pediatricians to download and use them. It saves you time. Newer genetic testing is becoming useful in the diagnosis of short stature, as you heard in case of Turner syndrome and Russell Silver, etc. Therapeutic options for the treatment of short children are ever expanding. And IAP growth chart mobile application is very useful for pediatrician for everyday use. So with that note, I would like to conclude the session by thanking all my panelists, thanking Delhi IAP, thanking Dr. Mendiratta, and also the Delhi IAP group for inviting all of us here. And I hope that we have done justice to the topic of short stature. Thank you very much. And namaste.
Question answers.
Thank you. Thank you, sir. I think question answer can be done in the chat box, if you don't mind. And I will request Manish we can proceed for the next session. Manish?
Thank you, Dr. Lalit sir, for a nice discussion by Dr. Vaman, Dr. IPS Kochar, and everyone. We have really learned well in this session. So now we move forward to the next session, which are two talks on typhoid vaccines by two extremely learned people, Dr. Arun Wadhwa and Dr. Shyam Kukreja sir, from whom both we have learned so much. And to chair the session, I invite Dr. Anju Agarwal. We all know Madam, being a professor at JTB Hospital, UCMS, Dr. Anju Agarwal Madam. And our other chairperson is Dr. Lalit Mehndiratta, who is President-elect 2020. And Dr. Lalit Mehndiratta, welcome sir, very senior and pediatrician from IIP West Delhi. And third chairperson is Dr. Kiran Agarwal, who is senior pediatrician and has been past President IIP Delhi. Dr. Kiran Agarwal, please. Now over to chairperson to introduce the first speaker and talk, please.
Dr. Anju, you can introduce.
Yeah. So today we are going to have an important session on typhoid vaccines. Like people are used to the previous typhoid vaccines, and every day we are developing new typhoid vaccines so that we are able to control typhoid fever. In addition, we'll have some advantage for paratyphoid A, B, C. So one aspect is that. Secondly, once a vaccine is introduced, after some time the question comes up, is a booster required? So that will be, I think, one of the things which our esteemed speakers are going to speak about. And first talk is by Dr. Arun Wadhwa. He's a well-known pediatrician practicing in South Delhi. And nowadays he's studying vaccinology and teaching vaccinology for last 15 years. So over to Dr. Arun Wadhwa.
Thank you, Dr. Anju. So before I waste much time, I think we should get going, isn't it? Okay.
Manish, how much time we have for this session?
15 minutes.
15.
Thank you, Arun.
So we'll talk about typhoid fever in very brief because everybody knows about typhoid fever. I'll talk about the new typhoid vaccine. Okay, so I have to state that I've been on the advisory board of these companies, so there could be a little conflict of interest, but I'll definitely try not to do any thing which is conflicting. So about typhoid burden, globally they have 11 to 22 million cases every year. And unfortunately, 30 to 40% of the global burden is in our country, 30 to 40%, which is a big number. And this chart, as you see, is self-explanatory. The India-Pakistan region is dark blue. Then you have green areas and the yellow areas, which have the least, including South America, which have very less burden of typhoid fever. Secondly, typhoid fever is also the third most common cause of morbidity amongst the communicable diseases. First, we know is the respiratory tract infection, second is the diarrhea, and third is the typhoid. So imagine that is the importance of typhoid in communicable diseases. Unfortunately, the mortality of typhoid is higher in children and peaks between 5 to 9 years of age. This graph, you can see initially it's a little less, peaks here, and then after that goes down a little bit. So in our pediatric age group, the mortality is the highest. Children also have the highest incidence of typhoid fever, and the younger children get more severe disease, more complications, more hospitalizations. To see the statistics, 27% of cases occur in children less than 4 years. 27% means 1/4. And you can also have 2.9% in less than 6 months. This is WHO data, so it's authentic. Typhoid is very common in less than 2 years. We saw 2.7%, 15% occur in less than 2 years. This is another study. Typhoid fever in less than 2 years presents mostly with non-specific symptoms. This is important because you may not suspect typhoid and the symptoms are non-specific. Another unfortunate thing which is unfolding now is the development of resistance. So once you have multi-drug resistance, it means they are resistant to these 3 antibiotics I'll tell you just now, the nalidixic acid group, but of course not ceftriaxone. So least resistance is there to ceftriaxone, but there's in our country and region almost 7% of the cases have become multi-drug resistance. Then you have another form which is the extreme drug resistance. So MDR would be they are resistant to the first line drugs, but cephalosporins, third generation cephalosporins, they are still sensitive. And XDR would mean they are resistant to all the recommended antibiotics for the typhoid fever. And in this study, November 16 to 18, 2 years, 5,274 cases of XD were reported. And this was fortunately not in our country, but this is what is emerging in our subcontinent.
So if you see, the typhoid is very common in children, less than 5 years, mortality is more, hospitalization is more, diagnosis becomes a little difficult. Now that bacteria is developing resistance, multiple MDR and XDR, we have to prevent. And prevention would mean, first would be having good water supply, sanitation, using clean water, using good food and vegetables. So most of these things are not in our hands. Some of them are, but some of them are not. So best protection would be by taking a vaccine. The typhoid vaccines which are there in the market could be easily divided into two, parenteral and oral. Since this is not available in India, it's available in US. The parenteral is divided into polysaccharide and conjugate. And conjugate has 4 varieties. The one which we have in our India is the TT1, and the new one, which is the CRM1. Then you have V-Repa, which is the original one, which was first discovered in Vietnam, studied in Vietnam. After that, it has been handing over to a Chinese company. So they are doing the phase 2-3 trials. And the VIDT1, the DT conjugate one, was invented or discovered by the IVI, the South Korean Institute, International Institute of Vaccinology. And it is now undergoing trials in Bangladesh as phase 2 and 3. So since they are not in the market, they're not in commercial use, we'll consider it on these 2 vaccines. First, before we go into the 2 different conjugate vaccines, first of all, we must know the difference between polysaccharide and conjugate. The conjugate vaccines give you TH cell activation. That means memory cells are there, which are not there in polysaccharides. There's an antigenic switch. That means IgG1, IgG3 are produced. Here only IgM are produced. Booster response is there because of this TH response, and conjugate vaccine give a good booster response. The antibodies can be seen before 6 months of age, but after 6 months are generally better. And response in infants is high, which is not there, does not help in 24 months and below. So you have better and long-lasting immunities. There's a booster response. There is long-term protection. If we compare the efficacy of polysaccharide and conjugate vaccines in Pakistan, they had seen the efficacy of 31%. In Indian studies, it's 57%. So both of them are not actually very good. The trial which was there in Nepal, which was a recent one published, was the 81% efficacy. So this is a very good trial. And the Vietnam trial, where the different conjugation was used, this is a TT conjugate. This one was the V-Repa conjugate, where 88% was found. So any day, conjugate vaccines are much better. 31, 57, Pakistan and India. It's 88 in Vietnam and 81 in Nepal. So you can see in this area, the efficacy was almost 1.5 times more. What is this conjugate vaccine? Conjugation is when you combine the toxoid, the polysaccharide with another conjugate protein, which increases the immunogenicity. And this conjugate vaccine is actually composed of 2 things. One is the original VI antigen and the conjugate protein, which increases its immunogenicity. And this new typhoid conjugate vaccine, which I'll be talking about today, both the things are different. So the VI polysaccharide is different. The conjugate protein is also different. This is the structure of VI polysaccharide. What is the VI antigen? It is responsible for immunogenicity. It helps the bacteria to evade killing mechanism and survive. It is not required for causing disease because they have found that VI negative typhoid can also cause disease, although it's very mild. And this VI antigen is not unique to Salmonella typhi only. It is there in paratyphoid C, it is there in Streptobacter frundi and S. dublin also. Important thing to note is that VI antigen is not there in paratyphoid A and B, and that is why we have not been able to still make this the tetravalent or the bivalent vaccine, because VI antigen is not there. So we have to make a vaccine where VI antigen is not required. So we'll have a trivalent, bivalent only when we use something else other than VI antigen. So what is the Streptobacter frundi? It is in Germany, it means friend. It is a soil bacteria which lives as commensal in animal-human intestine without causing much disease. And it is important in the maintenance of nitrogen cycle. It is a BSL-1 organism. That means there is no environmental risk of contamination. It's a safer source of vaccine. The typhoid actually belongs to BSL-3. I'll show you the chart just now. And the VI antigen derived from frundi and typhoid are structurally and immunogenically exactly same. And the guidelines given by WHO and IP, Indian Pharmacopoeia guidelines, they say that you can use either one of the 2 to make the vaccine. So this is a biosafety level I wanted to share you. This is biosafety level 4, which the microbes pose very high risk to those people who are there in the lab or working around it. Examples are the Ebola virus, where it had mortality of 50-60%, Epa virus. Then BSL-3, where SARS-CoV-2 comes, CoV-1, typhoid also comes here. And BSL-1 is the one which microbes do not cause any disease if you are immunocompetent. These are normally staying in our skin. Yeast, Citrobacter frundi is also here. This is bacteria. This is BSL-1. So this structure of the VI antigen derived from frundi and typhoid is exactly the same. You can see the structure is the same. It has been proven that they are same by the nucleomagnetic resonance imaging. Then you have the similarity of immunological same. Both are recommended by IP and WHO, and the amount also is used the same 25 microgram per 0.5 ml. So these are the screenshots of IP and WHO guidelines, which say that the capsule VI polysaccharide consists of this, and you can use either one of them to make the vaccine. Why do we want to use Citrobacter frundi instead of the typhoid VI polysaccharide antigen? Because frundi is a safer option. I showed you just now is that it's a BSL-1 organism rather than BSL-3, which is typhoid. There's a benefit to the vaccine receiver because there are not many toxins since BSL-1 organism is there, makes the vaccine also very safe. Benefits the environment because there is no risk of environment contamination. Then to the manufacturer also it's beneficial because the people working in the lab are also safe, and the yield of the VI polysaccharide is better if you use Citrobacter frundi as compared to the TI from the typhoid bacteria itself. Then the second difference between the two vaccines, the new one and the older one, the second was the conjugate protein. Here, instead of tetanus toxoid, they've used CRM97. What is this? It's a cross-reactive material. It is a non-toxic mutant protein of the diphtheria toxin. So it's derived from DT only, and it is derived from the mutation. The FAR gene, which was used, is the 197 gene. So that's why it's called the CRM197. It is non-toxic mutant of DT, non-toxic to animal models, has homogeneous chain length, binds into membranes, and irrespective of pH, it can penetrate the membranes. It has a stronger binding, so conjugation is better. Since there is no formaldehyde used, because in the TT protein, the formaldehyde is used to inactivate. Here, formaldehyde is not used, so there is no residual toxicity of formaldehyde. Maintains the structure during processing, and it has a better conjugation, as we saw just now. So we can say that CRM197 is a smarter protein. It is well characterized, highly purified, it is safe, and immunogenicity is the same as compared to the other conjugate protein. And this is not a new protein because it has been used earlier in hepatitis. If you know, it has been used in Prevnar, it has been used in Menveo, and more than 100 million doses of CRM conjugate protein vaccine have been used worldwide. So this is the difference in structure, DT conjugate and the CRM conjugate. This is a complex structure which keeps changing. The purity is only 60 to 70%, and here the purity is more than 98%. So you can see the structure that this is a more homogeneous, uniform structure. This is a more complex structure which keeps changing. So purity also keeps changing. It loses the natural structure during multiple cross linkages. It induces exactly the same typical antibodies as we expect from a conjugate vaccine. That means IgG1, IgG3 or more. The dark one is the IgG1. So you can see IgG1. It's typically what we see of a conjugate protein. This was one study I found where the immunogenicity and safety of a fully liquid aluminum phosphate adjuvant, the HIV vaccine, the CRM conjugate vaccine was compared to the tetanus toxoid vaccine, not typhoid. And they found the seroprotection rates were 99.3% in the CRM conjugate and 95.6% in the TT group. So the CRM conjugate worked better than the TT group. This is another study I found, which the HIV was used as conjugate. The conjugate protein was CRM or tetanus, and they found the CRM vaccine was much better as compared to the TT conjugate vaccine used. To show you in a simple form, this is a graphical form. The conjugation was much better in CRM as compared to the TT form. There's another study I found where it was in meningitis, this was studied, where the DT conjugation as well as the CRM conjugation vaccine was compared. And they found that the repeated exposure to TT because of vaccination, what it does was it resulted in a drastic suppression of the anti-carbohydrate response to case of TT conjugate vaccines after a slight, although the reduction was also there in CRM, but it was much more in the TT conjugation vaccine. So when you use a subsequent vaccine containing TT, the response was less, whereas when you use the CRM repeatedly, the response was reduced, but not as less as the TT one. So some people may ask whether the TT-DT used in the vaccine protects against diphtheria or tetanus also. It's actually no. And in fact, nobody has studied, although it does result in increase in antibodies against the respective antigens, but nobody has measured.
But people have definitely found that excessive use of TT, DT in conjugate vaccines leads to increase in reactions to TT, DT used in the later years. We know that when we use tetanus toxoid repeatedly, it leads to more side effects. And studies have also shown that repeated previous exposure to TT can suppress the immune response to polysaccharide when it is attached to TT. So these are the minus points. And TT, DT, the used in conjugation cannot be treated as vaccine. And although if the antibody increase may happen, but they're not protective. So this new vaccine is not a new vaccine. It was developed by the Novartis Institute of Health. And in 2014, it was transferred to BE. After that, BE did increase the amount from 5 to 25. Purification was improved. Less than 5% free radicals are there. Earlier, they were 40% free. Particle size was homogenized. Structural similarity was proved. And the identity of VI polysaccharide proved in each batch using the assay of the dot blot method. The first clinical trial was done where open label single arm was done. This is a phase 1 trial. And they found that the seroconversion on day 28 was 99.6, converted more than 4-fold rise. And 90% of the subjects did not show any adverse events. Then after that, phase 2 and 3 were done. 602 Indian subjects were there, 9 centers across India. So this was the 9 centers where it was done. These were the 9 centers all across the country. 311 children in the control group, which was using the TCV TT vaccine, and this was the group, the experimental vaccine. And as you can see by the graphs, the blue one is the CRM conjugate vaccine, the red one is the TT conjugate vaccine, and the immunogenicity in the years 6 months to 2 years, 2 years to 18 years, and 18 years above are exactly the same. This is the overall, so it's exactly the same. Percentage of subjects which showed more than 4-fold rise were also the same. This is the CRM one, this is the TT conjugate one. And long-term protection, this is one interesting thing you must see, that the WHO has said that if the initial values are more than 4.3 microgram, it means there is long-term protection. That means, but long-term doesn't mean lifelong, it means only 4 years. And the long-term protection was also there. This is the typical graph, the red one and the blue one. This is the long-term protection cutoff. This is the seroconversion. So we can see both of them had good long-term protection also, more than 4 years. In short, this is a very important chart to tell you the safety of the comparison of the safety. You know, the number of subjects who had at least one adverse event were 26 in this CRM group, and there were 47, almost double in the tetanus toxoid group. And if we see the mild, moderate, severe, life-threatening effect, there also it was almost half, 24, 44, 4 and 3, so and 18 and 37. The side effects were almost half because of probably a better conjugation. These are the adverse events. You can see the red one is a TT and blue one is a CRM conjugate. Fever, pain, erythema, swelling, all of them were much less in the CRM conjugate vaccine as compared to the tetanus toxoid. And the systemic side effects also like vomiting, fever, headache also were almost half or even less. So we can say that it was well tolerated, no side effects. Number of people having adverse events was 8% as compared to the 15%, and similar findings have been there previously also. So in short, to summarize, we can say Frundi was used, conjugation is different, CRM, and better safety profile of this vaccine. There are 2 other studies going around to see the long-term immunogenicity, also the timing of the booster dose. So these 2 studies are underway, and they will find out when should the booster would be given. So it's a new generation vaccine with advanced technology. First TCV vaccine with CRM conjugation contains 25 microgram. Had been demonstrated to be 99% seroconversion as compared to the comparative vaccine. And good thing is that IAP, ACVIP also 2020 recommendations, which came just 5 days ago, also have said that it can be used in children between 6 months to 45 years of age. And the best news is that yesterday only, 2024 December, it has also got the WHO pre-qualification certificate. So that also is completed. Thank you so much. Thank you for the patient hearing. I think I finished just in time. Thank you.
Very nice, Dr. Arun. I think we can have the next session from Dr. Kukreja, and we can have questions.
Without wasting time, we can have the next session from Dr.
Thank you. Thank you. Dr. Kukreja?
Okay, I'm sharing the screen. Thank you.
Dr. Kukreja is our scientific organizing committee chairman.
Conference chairperson. He is the conference chairperson, the spearheading the whole movement.
Yes, he is the backbone of science, and all this organization has been really upheld by Dr. Kukreja. Sir, welcome, sir. And he is the director and head of the departments at Max Specialty Hospital, had been the chairman of Pediatric Infectious Diseases chapter, pediatric infectious disease and immunization. And he's a very good human being. You can ask him anything, anytime. He's always at help.
Thank you.
Welcome, Dr. Kukreja. Please go.
Thank you. Oh, I'm sharing the screen.
I think Dr. Kukreja has lost contact now.
We don't see Dr. Kukreja.
नहीं थोड़ा कनेक्शन प्रॉब्लम हो गया होगा तो अभी आ जाएंगे.
Right, sir.
Dr. Wadhwa has nicely highlighted the new vaccine. So now we'll have both the vaccines. You can choose anyone.
Rohit, you have Dr. Shyam Kukreja's presentation? Rohit?
Yes, sir.
You have Dr. Kukreja sir's presentation?
No, sir.
Wait a minute, we'll be connecting.
There's anyway a question in the chat box, Dr. Arun, which says booster or no booster. As I said before your talk, everyone
I
is
was
going to
about to
ask
put in the
that.
chat box. All questions are welcome except for the booster dose.
Okay, why not?
Although WHO doesn't say booster dose, IAP follows WHO, and this is because of that. The WHO says no booster dose because they feel one dose is cost effective. So for mass use, company use, the government use, one dose is good enough. But for individual use, maybe we can give a booster 3 to 5 years from the last dose.
Does it
So we have seen lots of breakthroughs with one dose.
Okay. Does it not induce T cell immunity? So we may not need a booster.
No, that's
Does
what
it not induce?
depend on the natural boosting.
Dr. Kukreja is back.
It may not happen.
Okay.
Okay, I'm sorry, Dr. Nav, आपने मुझे भेज दिया था कल का Zoom का, so I connected that.
Oh नहीं, वो तो
It is the same for
Sorry, I'm sorry. Okay, typhoid conjugate vaccine. So I'll be speaking. Dr. Arun has spoken regarding the vaccine which is soon coming, and I've spoken.
It's already there in the market.
It's already come. Okay. Okay, I'm talking about the vaccine which you have been using, and I'll just sort of go through it rapidly because you're already using it, and share some thoughts regarding this vaccine. Okay, I am also have a conflict of interest. I am in the advisory board of several vaccine companies, including this. Typhoid conjugate vaccine, when you want to use it, first of all, you want to know, is it really required or not? Let's see that. Vaccine is basically to prevent this typhoid disease. And typhoid disease, I know, spreads through orophycal route. Now, ideally, it should be prevented by interventions on wash. And what is wash? Wash is you have to take care of water, you have to take care of sanitation, you have to take care of hygiene. But unfortunately, these things will take time, although there's now a big attempt to improve all this over the last few years. Now, they can still, I think they are will take another maybe 10 to 20 years. So vaccination is a shortcut. And whenever we vaccinate, the first question arises, is there a sufficient disease burden? I think you may have a question about other diseases, but all pediatricians sitting here are seeing typhoid every day in their practice. Just to tell them, we belong to a high endemic area, means 100 cases per 100,000. We are the one who contribute most deaths as far as typhoid is concerned, 1.5 lakhs deaths per year. Now, if you take last 15 years data, there's different data like 140 episodes per 100,000 in Kolkata, 270 per 100,000 in Delhi, 976 in one of the study done by AIMS in urban slums of Delhi. In Indian subcontinent, if you take in Pakistan, it is 451. So it is definitely more than 100. So we belong to high endemic area. If you take the incidence in the different age group, you find the incidence is too high even in 2 to 4, it is there in 0 to 1, and the peak incidence is there in 5 to 15 years. If you take febrile episodes, in the still in children less than 1 year, they contribute significantly. So it means this is a burden in my country. And this was the data which is from 2008 studies. I was searching the latest data, and the SAGE study of 2017 tells us that 1/5 of the cases they tend to occur less than 4 years, and 10% are less than 1 year. So indicating there's a high disease burden. Wash interventions have to wait. So there's a need for vaccine. And if I have to have the vaccine, I have to cover this age group where the disease is going to be more catastrophic and more severe. So there's a need for early vaccination. So I come to the conclusion that vaccine is required because of disease burden. Now take this case. This is a classical case of typhoid. The child came to me 15 years. This is the temperature, high grade fever, dull, sick, pain, abdomen, coated tongue, spleen tip is there, 7 days fever is there. And these were the counts, CRP is high, eosinopenia is there, very suggestive that I'm dealing with the typhoid. I sent the blood culture, start on IV ceftriaxone. And this is in 2016. So what happens? I get this report in Max Hospital, and that is it is resistant to ceftriaxone. Luckily, I want to convey this message. It is not common. So it happened 4 years ago, only in 2 cases, and both these cases were brother and sister of the same family. Now, when I was a consultant in 88 to 90 in Batra Hospital, I had, I think, 7, 8 VIPs admitted children with me, and 4 were of leading doctors of this area. And they were not improving, and they were on chloramphenicol and combination of ampicillin. And I was really surprised what is going on. So I got a cultures done from Batra Hospital. There used to be a very enthusiastic microbiologist, South Indian, I'm forgetting the name. And she'd sent the cultures and heart brain infusion broth, first time I heard in life. And then she grew this bug. And then she sent these samples to Kasoli also because they were coming resistance, and clad H58 strain we came to know then. The resistance was there to cephalosporins and fluoroquinolones. Sorry, the resistance was there to ampicillin, chloramphenicol, and trimethoprim sulfamethoxazole. And then in 90s, we started using 3rd generation cephalosporins, ceftriaxone, and fluoroquinolones as the first line drugs. Now, if you take Pakistan, Dr. Arun was also telling about this, and they have been something like 10,000 cases reported so far in last 3-4 years. And there, the resistance is there to all 5 classes: chloramphenicol, ampicillin, trimethoprim, methoxazole, fluoroquinolones, 3rd generation cephalosporin, all 5 classes. And this is known as XDR typhoid. And it is sensitive to only azithromycin and meropenem. And if you take the data further and you find out, and the studies have been done in London, and they found that there is a resistance gene by the name of QNRS, which gives resistance to fluoroquinolone, and the resistant gene, which is CLAD58 strain, contains the gene which is integrated into the chromosome to have resistance against chloramphenicol, ampicillin, and trimethoprim sulfamethoxazole. Now, how this resistance came against ceftriaxone? So they find there's a plasmid which this bug, this typhoid bug, has taken on lease from E. coli, I think for a permanent lease. And this is BLAST CTXM gene 15, which gives resistance to ceftriaxone. So this is the bug which is circulating in Pakistan. There's always a concern that this bug may come to India. And then the worry part is we have an increasing azithromycin resistance. So indicating that there's a high burden, there's an impending resistance of typhoid, the intervention to wash will take time. So there's a safe and effective vaccine. Why not use this? So there's a huge justification of having the vaccine. So Dr. Arun has also told you now we are coming to the 4th generation vaccine, VI polysaccharide conjugate vaccines. He has told you the deficiencies of polysaccharide vaccines because there's no boostability. Every time you give it as a new dose. And We know the conjugation can be done with CRM, it can be done with TT, it can be done with DT, and they are time-honored things which we have learned over a period of time. And now these are the 3 vaccines which have been available. This is a Robin vaccine, which was invented in 2000 and 2001. There are studies in Vietnam. This vaccine is not being used now. There's a conjugated vaccine with tetanus, which we are using. And this is the vaccine which Dr. Arun was talking about. Now there's a study, which is a 2015 study regarding the vaccine. That is a vaccine which is conjugated with TT. And in this you find if it is used less than 2 years, this is the baseline levels of GMT. And they jump to more than around 2000 in the age group less than 2 years. And after 2 years, it is still 4-fold. If you take the 2 years to 45 years, it was the baseline level was 10 and it is still 81 after 2 years. So indicating, I think they have got a data of 7 years, which is not published, and that's why it has not been told to us. And there's a seroconversion as with that vaccine and this vaccine, almost 98, 97%. In less than 2 years, 98%, 97%. Now, if you take the boostability, after 2 years, this was a level in less than 2 years, cohort 1. And after booster, it is going sky high. If you take a conjugate polysaccharide vaccine in the age group more than 2 years, it was 81, it is going again sky high. Now coming to regarding single dose, it is supposed to be working more, single dose is working on a long-term basis. That is why the immunization committee has not recommended second dose in the latest recommendations. Now, coming to serological correlates of protection, it is a question mark. Like in pertussis also, you have a correlates of protection. But there's still a question mark there. Even if we know that if there's a pertussis toxin levels, anti-pertussis toxin levels are high, it gives little protection to them. But we do not have a cutoff. Let's have a study which has been done. I come to this. We had a correlates of protection in this Robbins vaccine, which is a exotoxin of Pseudomonas aeruginosa conjugate vaccine, which was the first vaccine used by used in typhoid vaccine as a conjugate vaccine in Vietnam in 2001. But it's very difficult to replicate because there are a lot of differences in the antibody detection methods also. So, and do not have the seras of those patients now available. Now, coming to a latest study, which is done and published in this about a month ago, I was going through this study and this interesting. They say we have what they did was, there was a controlled human infection model where the vaccine is given and after that the humans are challenged with typhoid bacteria. And they found who's protected and who's not protected. I'm come to that study also. In this, they found there's a higher VIG titers are there in those who are protected. There are higher GA titers also, immunoglobulin A, immunoglobulin G. Both the titers were higher and they were correlating more. And they feel this is, but the threshold they could not find. They could not have a cutoff in this study. And then they said this antibody-mediated functional responses, particularly phagocytosis by the neutrophils, is also an important marker. They feel all these humoral factors are important to evaluate and develop vaccines, future vaccines. And why we do not have a correlates of protection? This is the question I've been raising on the IAP forum for several years, because I say I do not believe that you can have a serological correlates of protection in typhoid fever. What are the reasons for that? The reasons for that are, if you take correlates of protection in Haemophilus influenzae, Neisseria meningitis, Streptococcus pneumoniae, we have a cutoff available, but we do not have a cutoff in typhoid. What is the reason for that? See what happens, these are all hematogenous bugs. As soon as they go to the throat, they reach the bloodstream. If the antibodies are there, they'll be destroyed. Now in case what happens in the typhoid in the initial stages during the incubation period, this bug is intracellular. it remains, I say, encapsulated bacteria like those 3 bugs. There's no early bloodstream invasion. And what happens is these bacteria are transferred from the gut lumen to the lymphoid tissue by the macrophages, and this remains away from the immune system. So they bypass the immune system. As soon as they come into the blood, then you have a manifestations of typhoid. If you see all other bacterial infections, like take pneumonia, pneumococcal pneumonia, there's a chill on day 1. If you take tonsillitis, there are chills on day 1. If you take typhoid, what happens? Chills do not come on first 3-4 days. Classically, the chills come on day 4, day 5. So that is a sign of peaking bacteremia. Those peaking bacteremia comes after 4-5 days. So this will, the reason we believe that the pathogenesis is so different, because the bug immediately doesn't come in contact with the antibodies. That's the reason it's very difficult to have correlates. That's the reason IgA correlates are correlating. Now, if you take this controlled human infection model, in this, what was done, these subjects were given VI conjugate vaccine. After that, they were challenged with the bugs, typhoid bugs, and they found the efficacy is to the tune of 54% against any bacterial, against any typhoid infections, means the culture positivity. But they take the definition of fever more than 38 followed by bacteremia, then the protection was coming 87%. It is quite okay, but the most important study, which to my mind is this efficacy trial in typhoid conjugate vaccine in Nepal. This is the most important study. And what has been done in this study is, this is phase 3 randomized control trial in Lalitpur, Nepal, done between the age of 9 months to 16 years. There were subjects 10,000 in TCV group and 10,000 in meningococcal vaccine group. Blood cultures were taken after, say, giving the vaccine over a period of 1.5 years. In this, 7 participants in TCV and 38 participants in Men-A vaccine were found to have typhoid. And the vaccine efficacy by this is calculated as 81.6%. If you take a very good study, which was Dr. Soor's study in Kolkata slum, this was on VI polysaccharide, and it was as good study done in 2 slums. In 1 slum, they gave this VI polysaccharide vaccine. Another slum, they gave some placebo vaccine, and this was 65%. In Pakistan, as Dr. Arun was telling, 35% efficacy. So that way, this gives a lot of confidence to me. If the human model was showing 87% protection, this is giving us 81%, and the epidemiology of Nepal is very similar to ours. So this is a first pre-qualified vaccine by WHO. Indian Academy of Pediatrics is recommending between the age of 6 to 9 months to begin and give a early protection. Regarding 1 dose or 2 doses, I have a strong opinion that children less than 2 years should be given at least 2 doses. After that, we can watch it. And most conjugate vaccines, as you know, they need 2 doses. We know less than 2 years, the system, our immune system is not mature. If you take any conjugate vaccine, pneumococcal, you take meningococcus C, you take vaccine like H influenza, all conjugate vaccines where there's a bacteremia in the blood, means bacteremia is obviously in the blood. So they need 2 doses. Why this vaccine needs to be given 1 dose? That's the first question. 2, less likely there is exposure to subclinical infection in less than 2 years. So there won't be any boosting. And the GMT titers I showed you, that's the reason I showed you, it reached a lower level as compared to in the age group 2 to 45 years. So my belief is, if you are giving the vaccine in first year, maybe this child will need another dose after the age of 2 years. And thank you very much.
Thank you, Dr. Kukreja. It was a wonderful session.
Thank you, Dr. Kukreja, for nicely highlighting the serological correlates. In the study which they did, I think in less than 2 years, there was a fall in titers, but still the titers are more than the protective level.
Yes, that's right. That's right. That's right. You're right. But my worry is because they have not been exposed to subclinical, they are likely to fall further. And that might be the reason IAP is not keen to recommend second dose so far.
Well, it will take time.
Yes. Actually,
question of time.
It happens.
The recommendations evolve.
Normally, pediatricians use the vaccine as a their own strategy. For example, we were using polio vaccine at 4.5 years. Now the IAP has come with the recommendation. So first pediatricians use it, and then the recommendation comes.
Yeah, recommendations will evolve over the time. Any other questions?
Thank you, Dr. Kukreja. I think, and thank you, Dr. Arun. I think we don't have time. Any questions can be put in the chat box, and I will request Manish to proceed for the next session.
Thank you, sir. Thank you, Dr. Kukreja. Thank you, Dr. Arun Wadhwa, sir, and our chairpersons, Dr. Anju Agarwal. Thank you very much. So let's move on to our next talk. Next talk is on PCV vaccinations, the pivotal questions to be answered. And this is expert talk by Dr. Bhaskar Raju. And to chair this session, we have Dr. Shalini Tyagi. She is a pediatric pulmonologist at Metro Hospital. And fortunately, she is also from my college in Ahmedabad. To introduce Dr. Shalini Tyagi, and other is Dr. Ganesh Kulkarni. He is the chief pediatrician at Sanjeevani Hospital, Aurangabad. Welcome, chairpersons. Kindly take forward further the talk.
Thank you. This is Dr. Bhaskar Raju. Some of you might have heard about me. I'm a pediatric gastroenterologist. Of course, it is there, the slide for you to read. I'll probably you can remove that. I'll share my screen. If you stop sharing your screen, I can share mine.
Dr. Shalini and Dr. Ganesh, you can introduce.
Yes. I thought you had already done the job. You want me to reintroduce them?
No, sir. No, sir.
Probably not. Yeah, they have done the job. I'll get on with the program. At the outset, thank the organizers for thinking that I am fit enough to moderate a session. I think there is a little bit of a confusion. Who's going to speak? Who's not going to speak? I'm not the speaker. The two people who are recommended here, a chairperson and co-chairpersons, are the ones who are going to do most of the talking. I'm just putting the contest in place. Today, we'll be answering a few pivotal questions which are there in every pediatrician's mind. I know this is probably a sponsored program, but I can give you an assurance that this will be very secular, very generic, and without bias. And whatever that is said here will be backed up by verifiable, quantifiable facts which have been published in peer-reviewed literature. We have two excellent panelists with excellent academic background, and they are not going to come into anything unless they are sure of what they are talking about. So you can be sure there will be no bias in today's lecture. There is a question in every pediatrician's mind. What matters most while choosing PCVs? This doubt has come because there are some who believe there is something called vaccine serotype coverage, which is what we are going to take as a serious issue in order to make a decision. While there are many, of course, who believe it's not the serotype coverage which matters, but the net reduction in disease load following vaccination, which needs to be taken. I think the speaker, I'll be putting this question to Dr. Ganesh Kulkarni. He'll be able to explain to you what is the serotype coverage and how is it manipulated or calculated, and how is it of not much relevance in today's. Of course, one of the vaccines, there are two vaccines available. All of you are very familiar with them. One has 13 valents, and they advertise their vaccine saying, in fact, in public domain, saying choose wisely, choose the vaccine which gives the broadest coverage and the best vaccine. While the other company, which manufactures PCV10, claims the overall efficacy matters, additional coverage doesn't really translate to better efficacy on the ground. Dr. Ganesh Kulkarni, your opinions on this?
Thank you, sir. Choosing between PCV10 and PCV13 has always been as difficult and as easy like choosing between Trump and Biden. So on the same lines, when I have to say something about, as a clinician, if you ask me this question, I will always say, not a vaccine is important, but vaccination really is important. But as a scientific enthusiast, if you ask me this question, I have some reasons to say the advantage of one over the other. It has always been the perception in human mind that more is the better. And similarly, we all know that PCV10 and PCV13, the difference between these two is 3 different serotypes which have been added into PCV13, the 3, 6A and 19A. So out of these 3 serotypes, when the addition of these 3 serotypes, what actually is, and which is a fact, is that PCV13 has more serotype coverage. And these are the Indian studies that is there in front of us, which is taken from the Indian, the IIP book of vaccinology. And it has shown, these multiple Indian studies have definitely shown that there is an edge for PCV13. It has a better serotype coverage. See, looking at all these studies, you could find that almost in the tunes of 9 to 20%, the difference of serotype coverage is there between these two vaccines. But serotype coverage is everything. Does serotype coverage means the vaccine is better? Of course not. Here I'm going to unleash a different concept, and that is less yet better. Now, these are the different studies from Sweden, Canada, New Zealand, and Morocco, where you could see that serotype coverage difference between these two vaccines ranging from 10% to almost 21%. But that's not the case when it comes down to the disease protection. To me, single most important factor about every vaccine is about its ability to reduce the disease burden in the community. And that is called as effectiveness of a vaccine. So when you compare the effectiveness, these two vaccines have comparable effectiveness when it comes to the community protection. And that is the reason. Now, just to go into the details, the Swedish study, this has been a most popular study, which was published in Clinical Infectious Journal. And this study was actually a study wherein in 2019 January, first time PCV7 was introduced in Swedish counties. And in October 2009, it was changed to PCV10 and PCV13. So there were almost 21 counties in Swedish country. Some of them started using PCV7, PCV10, and some of them started using PCV13. So it was head-on comparison. When it was compared in 2000, it was almost 7 to 8 years, these two vaccines were given simultaneously in different counties, the same ethnic platform. And what was revealed when the study data came up, it showed that effectiveness was comparable. See, PCV10 is showing 73% reduction in the disease burden, while PCV13 is showing 70% reduction in the disease burden. So 73% and 70%. I'm not going to say that this is better and that is less, but it is almost comparable to each other, despite having more serotype coverage in PCV13. So when it boils down to community, the effectiveness, these two vaccines are almost at par and comparable to each other. Now, why does that happen? This happens because of 2-3 different reasons. One is, not all the serotypes which are included in the vaccine really transmit into disease protection. For example, the serotype 3, which is there in PCV13. But we all know that the efficacy about this serotype 3 and the total effectiveness is almost negligible. So there is no point in addition of this particular serotype in. It just increases the number, but it does not really add on to the value. Now, second thing is, there is something which is called as real life cross protection. Now, PCV10 has certain serotypes which take care, which cross protect other serotypes which are there, not available in the PCV10. And thus it expands its disease protection in the community. Now, third factor is, pneumococcal epidemiology is a static thing. But nowadays, with addition of different serotypes, what is happening is, we are coming across replacement disease, wherein addition of serotypes does not really help. It's a very complex phenomena. They do not, we think that we are adding more and more serotypes into a vaccine and making it better, but that's not the case. Addition of more serotypes, it's more of complicating the things more, because they are clearing the serotypes in the nasopharynx and giving away a place for non-vaccine serotypes. And the disease burden is almost the same. So that's the reason just addition of serotypes is not giving us the answer. So that's the reason when we have PCV10, which almost has an equal comparable efficacy, effectiveness, and that's the reason why we should think of using PCV10 as
Yeah,
compared
thank
to
you. I think you made a very good point. When you say serotype coverage, all that it means is you collect all the data about serotypes that are prevalent in one area and then tick off the ones which are present in the vaccine and find out what is left. As you said, that way of assessment leaves two things out. One, it assumes that every serotype which is present in the vaccine is going to be protected. And two, it assumes that that serotype will protect only against it, and it doesn't take into account the cross reactions or cross protection that's likely to be seen. So thank you very much, Dr. Ganesh. I'll go. The Finnish study, in fact, showed when it came to cross protection, PCV10 was probably slightly better because the non-vaccine serotypes were significantly higher in PCV13 areas, and which is why the 3% difference came, though it is not statistically significant. Now, the very vital, the most pivotal question I'm putting to Dr. Shalini Tyagi, what is your perception? PCV10 perhaps does not offer great protection 19A, as many pediatricians believe. It is only indirect protection, it's not direct protection. Do you believe in that? The evidence seems to suggest that PCV10 does have good and excellent protection against 19A. Your data, please.
Thank you, Dr. Raju. Now, the 19A is the bad boy of the pneumococcus family, you know, the more virulent kind, the more antimicrobial resistant kind. So we are really worried about the 19A protection. So as far as a vaccine is going to protect against a disease process, it will protect, you know, it can have a direct protection. You introduce the antigen and the body produces antibodies against that particular antigen. That is direct protection. That is what we usually aim at. Now, there's something called cross protection. Cross protection is when the body produces antibodies to the antigen, which are structurally similar to the antigen which has been introduced. This has been a very important way of protecting the humankind, you know, from several other viruses. That's how we have survived over the years, by generating cross-protecting antibodies against the viruses beyond which we were exposed to. And third is the indirect, wherein you reduce the burden rate, the carrier rate, and the exposure reduces. So vaccine is going to be effective in community through all these three mechanisms, just beyond the direct protection. Now, talking about 19A in particular, 19A is present in PCV13 and 19A has cross antibodies are there in PCV10. That's what the both vaccines claimed. To assess the efficacy, we can assess that in three ways. The first and the most important is effectiveness. That means the impact of the vaccine in curtailing the disease caused by 19A subtype. So this was studied in so many, you know, some of them have been mentioned here in this slide, world over, ranging from CDC study, which is the first study in US, from Netherlands, to Finnish study that we discussed, and a very important Quebec study, which was done neck to neck for both the PCV10 and PCV13. If you see there were, you know, the trials were different. There were some of them were indirect cohorts, some were matched case control, other was unmatched case control, and we also had lab-based studies as well. So it has been studied not just one way, not in just one part of the world, but world over. If we look at the results, the PCV13 effectiveness against 19A has ranged from 83 to 94. And if you see, the confidence intervals are rather large. Same thing when we go ahead and study in PCV10, which does not contain 19A per se, and the efficacy that is produced by cross protection ranges from 82 to 62 to 82. And if we have a closer look here, the confidence intervals are more or less overlapping. So we can say that the protection of PCV13 against 19A is good, and PCV10 is definitely somewhat comparable through cross protection. Now, apart from the effectiveness, there are two other things that we can see. Why the PCV7 did not have 19F? So why PCV7 did not give a cross protection against 19A even when it had a 19F? Why did that happen? It happened because the structure of 19A and 19F are pretty similar. However, the chemical process that was done in PCV7 was different. The process that was used in 10 was cyanylation, which preserved the structure of 19F to remain as similar to 19A. Hence, cross-reacting antibodies were produced. The third way, the one was the direct antibodies, the second was effectiveness, the chemical structure, and the very important way to assess the effectiveness of a vaccine against a particular strain is to figure out the functional antibodies against that particular subtype. Now, the functional antibodies are diagnosed are titrated by OPA titer, opsonophagocytic activity of that antibody. How much of that antibody is killing the bug? So PCV 13, of course, would have 100% since it has the bug, and 10 has 88%, which is significantly comparable. And based on this data, PCV 10 can write it on the label that they have protection against the 19A subtype as well.
Thank you. Thank you very much, Dr. Tyagi. I think you made a beautiful point that cross protection and direct protection are two ways in which nature protects all life forms. You know, in vaccination, we use it extensively. Your BCG protects against leprosy, cowpox against smallpox, human rota vaccine has a wild heterotypic protection. Men-B can protect against gonococci, for example. There's plenty. Even rabies vaccine can protect against a lot of Lissa viruses. One additional point I would like to add, the antibody produced by 19F in PCV13, because the conjugation makes a slight difference in the structure, definitely protects against 19F. But the antibody is slightly different. In fact, I would like to quote Dr. Jan Pullman's study, where it's a beautiful study where he studied the antibodies produced against 19F by polysaccharide vaccine, PCV13, PCV10, and amazingly enough, he collected naturally produced antibodies in the elderly. They might have gone through a natural disease once upon a time in their childhood, and he compared all four of them by their conjugation to serum albumin, and surprise or perhaps no surprise, PPV, the polysaccharide vaccine, PCV10, and the natural antibodies were identical. But the one produced by 19F in PCV13, while definitely effective against 19F, was slightly different, which is one of the reasons why this occurs. So going back to Dr. Ganesh Kulkarni, the ever-spoken AOM, acute otitis media, is it a disease we need to really worry about and really worry whether we need a vaccine for it? And is there any evidence that this PCV10 will give protection beyond pneumococci and probably affect AOM incidence as well?
Yeah. So as far as PCV is concerned, we always have been talking about invasive pneumococcal disease. And we know that, yes, that's a dreaded disease. It has a much more mortality, and our concern is always about invasive pneumococcal disease. But having said that, we have been ignoring something which in fact has 1,000 times more incidence of a disease which comes to our OPD in and out. Now, on first count, when we were comparing these two vaccines on effectiveness, they are almost comparable. Now, here I have a reason to smile. Why? Because now this PCV10, which has a carrier protein, NTHI. Now, we all know AOM in pediatric, our age group, is the bacterial etiology is basically Streptococcus pneumoniae. Second is non-typeable Haemophilus influenza and Moraxella catarrhalis. Now, similarly, the way serotype replacement disease is happening, as and when we have increased our coverage against pneumococcal disease, there is something which is called as replacement of organism is also occurring. Streptococcus pneumoniae is being taken care of, but now the same AOM is being much more caused by non-typeable Haemophilus influenza. And to our surprise, here the carrier protein which is used for conjugation in PCV10 has given us a smile, a reason to smile. And this NTHI B protein conjugation is being phenomenal in taking coverage against AOM. Now here, look at this particular pyramid where invasive pneumococcal, for one case of invasive pneumococcal case, we have almost 1,000 cases of AOM, which are coming into our practice every day. Now, what really is being happening here is AOAM, for that matter, when it comes to your OPD, either it is a viral or a bacterial, but because of our clinical settings and scenarios in our country, a lot of antibiotics have been prescribed against it. And that is where AMR is being encountered, or we are facing a problem of AMR, antimicrobial resistance. And that is why we need to take this AOM also so seriously. Now, on the similar study, Swedish study that we have seen here, another factor which was compared between these two. Now, these two different counties, which one were using PCV 10 and other was using PCV 13, the overall incidence of AOM almost had gone down by 25% in those counties where PCV 10 has been introduced. So this itself tells us, yes, it has an advantage against AOM when we compare PCV 10 over PCV 13. And that's the reason PCV 10 offers dual protection against AOM caused by Streptococcus pneumoniae and NTHI. So that's where, when we want to select a vaccine, I would rather prefer PCV 10 over PCV 13 to counter against AOM.
Thank you, Dr. Ganesh. You made an excellent point. PCV 10 has a unique conjugation protein, which is the D protein of non-typable Hib, which is why it is able to extend its protection beyond pneumonia into non-typable Hib. And a lot of pediatricians believe it's really not a major issue in India. AOMs and CSOMs are not really that common, but there are a lot of papers, especially from CMC Vellore, from where I am, close to Chennai. Dr. Rupa, Dr. Sophia, Dr. Rita Isaac, they have all published extensive studies of school-going children. Almost 6 to 7% of nearly 1,000 children actually had chronic CSOM, meaning they had gone through an AOM or ASOM and was not recognized, was not treated. Many of the AOMs, ASOMs, I think we are missing. And even non-typable, I've heard many senior pediatricians ask me, does it exist at all in India? I'm sure it does. Now that Hib has become extensively covered by Hib vaccination, it's being slowly replaced. In fact, about 10 years ago, Dr. Shekhar from Chandigarh, he published a paper on nasal carriage below 2 years. 11% were Hib. Of the 11% Hib, 1/3 were non-typable. So non-typables do exist here. And the other factor, which in PCV 13, they do not talk much about AOM protection, because even the pneumococcal protection they find is not really complete. In fact, from Rochester, Michelle Fishy shared a study where after PCV 13 has been given, many children developed AOM. He collected the fluid, he cultured the fluid, and was quite surprised to see almost 20% pneumococcal still present. Of course, non-typable Hib was untouched. So going to Dr. Tyagi again, what is your opinion on available PCVs? It's a relatively long question. And what is your opinion based on IPD protection? What is your opinion based on pneumococcal protection? What is your opinion based on AOM protection? And finally, I'm sorry, I'm giving you so many things to answer. What is your opinion based on cost effectiveness? You can start with each of them. IPD protection.
Dr. Raju, at the offset, I would say that it is very important to give a protection against pneumococcal disease per se, whether it is 10 or 13. At this point, all the children in the country should be given the vaccination, because we know not only it's an economic burden, it causes disease, morbidity, mortality, and the number of antimicrobial use increases, the antimicrobial resistance increases. So it is imperative that we start giving pneumococcal vaccine to almost each and every child. Now, coming to comparison, Dr. Raju, it's the most difficult question to answer. But if we look at the scientific data, as regards the septicemia, the invasive pneumococcal and the invasive pneumonias are concerned, in my previous slide also, wherein the studies were there, we figured out the efficacy against not only 19A but other bugs as well. The protection was comparable. Based on all these studies, even the world bodies, global health authorities like WHO and PAHO-TAG have stated the same. I would like to read the WHO statement. There is currently insufficient evidence that two vaccines differ in the impact on overall pneumococcal burden. And PAHO-TAG says that neither vaccine is superior to another. with similar safety, effectiveness, and impact profiles. So a child should take a pneumococcal vaccine, whether it is 10 or 13. Coming to AOM, Dr. Ganesh has just elaborated in detail that PCV10 has a dual advantage apart from pneumococcal coverage. And you also mentioned anti-HI is a big problem which needs to be handled, is been taken care of by PCV10 better. So in this aspect, PCV10 will have a bit of an edge over PCV13. And we've seen the various studies in the previous last 5 minutes of discussions as well. The last is the cost effectiveness. That is what you asked me, no? Now, I would say that, everybody on the forum, I am one of the vaccine believers, that vaccine is the most cost effective thing that, as regards as infectious diseases are concerned. It not only reduces the cost of healthcare, it reduces the diseases, the mortality contents, and the most important point, which I'm going to highlight once again, is I'm worried about the antimicrobial resistance, which is the biggest menace it's going to be in the next, coming years in front of us. So there is no doubt about the cost effectiveness of pneumococcus vaccine. To debate between the two vaccine, 10 and 13, there are certain points. In India, we have a big, huge economic variability in people's buying capacity, and Indian people have to pay from the pocket for the vaccination. So wherein, if I use a lesser cost vaccine, it will be more acceptable. More number of children are going to avail it. So apart from direct cross, there'll be an additional advantage of indirect immunity. So overall pneumococcus protection is going to be better. However, as we all know that the cost of PCV10 and 13 are at par in the world. They are more or less the same. So if we look at the economic viability of these two vaccines, there is a very beautiful study which was done in Italy, wherein they considered overall effectiveness of pneumococcal conjugate vaccine, and economic analysis was done, and wherein it was a neck-to-neck trial between the two vaccines, and the health cost was figured out at various health centers, and it was pooled. So they figured out that the PCV10 had an added advantage over PCV13 because of its additional benefit in protection against AOM. So even if the cost is not considered, if we consider that both the costs are same, PCV10 will have an advantage because it has an additional benefit in AOM protection, as this was the only study which compared them economically.
Excuse me, request. Can you please speed up the discussion, ma'am? We have.
Yeah, we are done. We are in the last few minutes.
Last slide.
Please,
So there's one randomized control trial for PCV10 in our country. This is a very important, beautiful slide which actually sums it up all. For every 1,000 babies who received PCV10, we could prevent 1 IPD, 5 pneumonias, 22 AOMs, and 200 antimicrobial prescriptions. So I think that sums it up, that it's a highly cost-effective vaccine.
Thank you, my panelists, for an excellent discussion we have had today. There are 2 pneumococcal vaccines that are available. Both of them are equally effective as far as pneumococcal is concerned. There is really nothing much to choose between the two, but one has an additional benefit by covering AOM as well. The choice of PCV should not be based on serotype coverage, but should be actually based on ground level responses which you are seeing and the efficacy. Additional serotype doesn't really translate to higher protection. And even WHO 5 years ago said, use PCV13 wherever 19A exists. They have significantly diluted it in the recent one which has come in 2019. They have not emphasized on that, but they have said there is really nothing much to choose between the two. So with this, I conclude the sessions. I thank the organizers. I thank the panelists for the excellent discussion we have had. Thank you very much.
Thank you, Dr. Raju. Thank you, Dr. Tyagi. Thank you, Dr. Kulkarni. I think the question answer can be taken in the chat box. And Prashant, you have the next list if you have.
Yes. So we carry on with our series of panel discussions on vaccinology. And next we have is the panel discussion on primary to booster vaccination. And for this, Dr. Ishika Das is going to moderate the session. She is, Rohit, please put the slide of Dr. Irshika Das. Yeah. She is Senior Medical Science Liaison Officer at Sanofi Pasteur. And as panelists, we have Dr. Tushar Shah. He is Dr. Tushar Shah's slide, if it is possible with Rohit. Yeah. He is Director, Department of Clinical Research at KGP Children's Hospital, Vadodara. And he is a member of Executive Board of Gujarat 2020. And next is Dr. Samdani. He is a very respectable retired professor of pediatrics at Grant Medical College, JJ Hospital, Mumbai, and emeritus consultant senior pediatricians at various hospitals in Mumbai. So I hand it over to moderator and panelists for further discussion.
Thank you very much. And we thank PCNI 2020 and NIPID for giving us the opportunity for being a part of this prestigious program today. And I'll hence share the slide. And
I have a request to made if you can, I think, speed up the session and.
We assure you not more minute more than
We
20
are
minutes.
getting very late. We
And,
are 1 hour late.
We are 1 hour late, and our cultural program is also due. We have so many singers waiting to sing, to perform their talent. So we want that everybody.
Sure,
Dr. Lalit, we are waiting to see Dr. Lalit's performance as well today.
Sure, so we'll ensure that we stick to the time and
Thank you very
no
much.
deviation to that. Thank you so much. I'll just quickly flash the slide for Dr. Samdani. This is the updated slide for him. We are extremely obliged to have Dr. Samdani and Dr. Tushar Shah today for a discussion on primary and booster vaccinations with the perspective of diphtheria and pertussis and polio. And this would be a panel discussion. It will be Q&A based discussion. So I hope I can keep everybody highly interested during the session. So in the current situation, we see that there is a continuous rise in the number of diphtheria cases, as well as cases for pertussis continue to persist in spite of high coverage in the world, and not just only in India. And even the epidemiological situation when it comes to polio, OPV has played its role, but we continue to see certain outbreaks in China, Philippines, and our neighboring countries continue to report active cases. So in such a situation, what should be our approach? And that is what we are going to be concentrating on today. So to begin the session, my first question to you, Dr. Shah, is that why should we choose the 6 diseases that are part of the hexavalent vaccine? So we would want your opinion on that, sir. Why the chosen 6? Yes.
Thank you, Dr. Ishika. And I think all would agree that when we talk of hexavalent vaccine, there are a lot of advantages of using an hexavalent vaccine whereby we prevent 6 very, very important these chosen diseases. And it's very important to prevent against the disease because they have very short incubation period as compared to many other diseases. And therefore, you require regular vaccines as primaries and boosters. So very important. If we talk of pertussis, we know that it's a very, very important cause. We contribute to the largest number of pertussis cases in the world. And we know that the immunity is always waning. And so we need to keep up with the primaries and secondaries. As far as polio is concerned, we know it's a very paralyzing disease. And we see plenty of cases of CVDPV now outbreaks in and around our country. So we need to be watchful and we need to ensure IPV, in fact, rather than OPV, and I think we'll be discussing about that in later slides. Talking about diphtheria, we know that it's a life-threatening disease, again, contributing to a large number. At times, we are not able to define and classify, but it's very, very important to protect diphtheria, and nothing can be reinforced more than this. Hepatitis B, if we talk about, we know it's a potentially infectious disease which can present as acute chronic state. It can also present as chronic hepatitis 2, cirrhosis to malignancy of liver, and therefore it's very, very important to protect hepatitis B. And we know that there are plenty of ways and means of doing it. As far as Haemophilus influenza B is concerned, along with other like strep pneumoniae and meningoveno, HIV is one of the important cause of invasive pneumonias and meningitis, and therefore we need to prevent against HEB. Tetanus, we know it's one of the non-infectious disease with no natural immunity, and therefore we need to have ready level of high antibody titers for tetanus, and therefore many doses of tetanus that we keep giving in primary series and boosters, even in adolescents. So we'll talk about that.
Right, sir. Thank you so much for giving us an elaborate answer to why we have chosen the first primary 6 diseases as the primary schedule vaccination. So my next question to you, Dr. Samdani, would be around the line that we do have our vaccines, and we know that certain indicators for vaccine performance include immunogenicity, efficacy, as well as effectiveness. But in the current scenario, in the Indian scenario, we do not have any head-to-head effectiveness data of the various hexavalent vaccines which are available in the market. So, sir, I would request your take on that, sir. How do we identify or how do we make our right choice there, sir?
Hello, can you hear me?
Dr. Samdani, yes, we can hear you, sir.
See, the most important point is to look at the efficacy and safety of the vaccine. Safety has all been done, and that's how the license have been given. Efficacy is most important in two aspects, looking at the seroprotective titers and looking at the GMT titers. Seroprotective is to prevent a disease, and GMT is long-lasting effect of the prevention of the disease. And therefore, any GMT which is higher will last for a longer time, and therefore protection will remain for a longer time, which will give us an advantage that even if the second dose is delayed, you are still protected to a reasonably good level. And that's an advantage. Third thing, when there is no head-to-head comparison, you must select a vaccine which is least reactogenic. Why? Because it will give us an impetus for the family to come back for the second dose and the third dose. If the reactogenicity prevents vaccination by the elders in the house, by the mother and by the child, and therefore the vaccination is not completed. If you don't complete the whole schedule of the vaccination, the effectiveness of the vaccine goes down and the control of the disease does not happen. The vaccine should also not interfere with each other as a component of the whole vaccine, as a combination vaccine. This vaccine should also not interfere with co-associated vaccine. For example, you use pneumococcal vaccine. Now, in certain preparations, when you use the combination of pneumococcal with all these 6 combination vaccines, the polio antibodies go down a little. And therefore, you should look at all the aspects that it should give rise to the same effect as it is used singly or in combination. Other thing is that the consistency of the results should remain intact. And the compliance would increase with ease of administration and less reactogenicity. And these are the factors which we'll look into, and the flexibility of the whole schedule of vaccination, which will give us the answer which one to select and which one not to select.
Right. Thank you so much, sir. I totally understand the importance of GMT, especially when we do not have any effectiveness data. It is the long-term protection that our concentration is there. And of course, when it comes to reactogenicity, we're giving it to healthy patients. We don't want minimum amount of any adverse events or any reactogenicity taking place. So, sir, moving on, the next question to Dr. Shah, and this is the most controversial question, but I'll still forward to you. So what is the difference of consistency and immunogenic response and duration of protection when we are choosing between an AP and a WP vaccine? So it has been a very point of discussion whether it's WP or AP, so on opinions on that.
So yeah, I agree that it's a controversial question, but we must understand that both acellular pertussis and wholesale pertussis vaccines have been effectively used to control pertussis in infants and toddlers in many countries for a prolonged period. So it's like nothing new, and both of the vaccines have done their job beautifully well in various countries. We also know that outbreaks have been reported from countries using either AP or WP vaccines containing vaccines in their schedules. And so it is possible with either of the two. So that basic debate of whether WP gives more immunogenicity or AP gives less immunogenicity is definitely out of question. As you can see here in this slide, that in WP there are more than 3,000 antigens, and these are quite heterogenic antigens. And what happens is that because of this, there is a lot of difference from country to country, from batch to batch also. And therefore, you can see in various studies that there is variable WP protection that is acquired, which is ranging from 31 to 96%. And more important thing, other than there's efficacy and effectiveness, is the reactogenicity, as Dr. Samdani was stating. And there is a huge chance of high reactogenicity, which includes not only the local symptoms, but even excessive crying, seizures, and encephalopathy-like symptoms, which can occasionally happen and has been reported from various studies and plenty of data that we know. So more important issue is the coverage, and we have to understand that when we use a AP-based vaccine, there is more of standard result that is expected, because we know that it's almost 70 to 93% efficacy that we see, which is more standardized as compared to WP, because it is variable because of the heterogeneity of the antigens. So when we have this comparison of these two vaccines, we have to understand that more important is that we should be able to offer this vaccine to more number of children. So overall coverage of the vaccine is more important than talking about what will happen individually. That one must consider.
Right. I think that gives us a quite a understood answer and an important way we can go for a conclusion that both of them have, of course, played their roles, but we have to choose that going forward is with the acellular pertussis vaccine. So, now the next question to you, Dr. Samdani, is that we understand that OPV has done a very good job. Most of the world is now polio free, barring certain places. And so but we're still continuing to see some cases of VDPV and outbreaks happening in many countries. So there is an epidemiological situation that we have in our place. So does the current epidemiological situation warrant for a preventive and protective approach for polio? Your comments on that, sir. Dr. Samdani.
See, the whole idea of giving a polio vaccine is to prevent a wild disease, which we have achieved by and large by giving oral polio. But now the stage has come where the incidence of vaccine-associated polio is more than the wild disease. And therefore, it's time to switch on to an intramuscular variety of polio vaccine. But unfortunately, what is happening, 60 to 70% of the children in this country still go to government and municipal centers for their vaccinations. And they do not have enough stocks of IPV. And therefore, they either get fractionated doses, which is only 2 doses, which is not sufficient, which can achieve you only 90% of the protection. And therefore, they don't give a booster dose again. Therefore, the suboptimum level of protection is offered to the child when they reach to these municipal places. But unfortunately, everybody cannot afford to come to private. And therefore, IPV is the choice. It should be given by the government and by all the practitioners as a routine. Now the stage has come that we should switch over to IPV rather than continue to OPV. We continued in the transit time on OPV and gave a bivalent vaccine because we didn't want the type 2 variety of polio to come into as an probably fear of an epidemic again. And therefore, the bivalent vaccine has been introduced. But the bivalent vaccine was introduced because we wanted to replace this in time to come with IPV. But unfortunately, that is not happening. And therefore, it is time that use trivalent vaccine as far as possible, which is injectable, which will not give you any chance of vaccine-associated disease, which will give you a chance of eradication of the disease. And OPV cannot give you eradication of the disease. And therefore, these are the disadvantages. And oral polio cannot be given if somebody in the house is suffering from some immunocompromised condition. Therefore, and even if the child is in an immunocompromised state, you cannot give oral polio. And therefore, there are certain restrictions of oral polio where IPV scores over it. And total 5 doses of IPV are to be given. And therefore, to prevent these, the first choice still remains as IPV, and we should try and use IPV as often as possible and feasible.
Right, sir. Thank you so much, sir. Even as per the Global Polio Eradication Program,
Dr.
the OPV...
Ishika, you have last 2 or 3 minutes to wind up the discussion.
Yes, sir. So, given the Global Polio Eradication Initiative, OPV is anyway going to phase out and it's going to be replaced with IPV. So, taking forward a discussion from primary to boosters. So, Dr. Tushar, the next question to is regarding the immunogenicity of a full dose DTaP versus a Tdap vaccine, especially when we're looking at boosters in preschool and the adolescent age groups. Sir.
Yeah, so we understand that there is definitely a huge difference between immunogenicity of full DTaP versus Tdap, and there was a time gap in between when so many people were using Tdap as a second booster, a preschool booster, which is definitely not right. And fortunately, ACVIP has now definitely given a recommendation that we should be using full DTaP IPV combination as a preschool booster, and that's a good welcome from ACVIP of IAP. And we know why, because there is a huge hazard and the Tdap vaccine effectiveness is definitely going to fall. We also know that Tdap vaccination will not prevent against pertussis outbreak, and it offers less protection, and the protection remains for a very short period of time. So Tdap should be used as adolescent booster only, and we should be using DTaP IPV as combination. IPV is also very, very essential, and fortunately IAP has registered this and has now put it officially for all of us to use as DTaP IPV combination at school entry booster.
So in continuation to that, sir, and a very quick remark from Dr. Shah, is there any importance of having a ready-to-use vaccine at the current situation of COVID times when we are looking into reducing any kinds of contamination or reducing the time that is required in the OPDs?
Yeah. So when we're talking of using an hexavalent vaccine, we have options like ready-to-use and one where we have to reconstitute. And we must understand that as per this Indian time and motion study, which was published by Dr. S.G. Kashe and others, and so many other things, as we know from our own experience, that there is, if we are using a ready-to-use vaccine, there are a lot of advantages. Almost the time that we use in reconstitution is saved, and therefore our exposure time with the patient is half as compared to where we have to reconstitute. There are plenty of mishandling errors, and that can be reduced by almost 5 times, and therefore there is less. If we are not using such vaccine, then there is going to be some spillage, or there can be some infection because of touching. So there is some unsterility that we are going to face, or some discomfort because of the needles that are going to be reused. So there are a lot of mishandling errors and reconstitution errors and spillage errors that can be avoided when we are using a ready-to-use liquid preparation of hexavalent vaccine. Definitely, there are a lot of advantages, and over and above this, it's a vaccine where IPV is there, so it is a big advantage where you want to prevent against this disease. It's a AP-based hexavalent vaccine, so you have an advantage where you are having less reactogenicity, and you know that there is a hepatitis B which is superior to other hepatitis B because of the manufacturing process, and therefore even if you have missed a birth dose of hepatitis B, this hexavalent vaccine has an advantage in the 6, 10 and 14-week schedule where you don't have to use a booster. We also know that it can be used in different schedules. So in this COVID situation where people have missed their vaccines because of delayed coming to your vaccination, or in between there was a lockdown and they had not come to your office, so it can be used in various schedules, and there are data to support this from various countries. So it can be used as 6, 10 and 14. It can be used as 2, 3 and 4 months. It can be used as 2, 4 and 6 months. It can be used as 2-dose schedule of 3 and 5 months. And there is significant good antibodies that we see even with all the schedules, which has been proven. It has also data for preterm use, so excellent data, and therefore it is proven for that also. And this hexavalent vaccine is also WHO pre-qualified, which speaks of its quality and procedures that it follows. So excellent all in all a vaccine where it has edge in this COVID situation.
Thank you so much, Dr. Shah. Just some few words of closing remarks from Dr. Samdani, and we will wrap up the session.
I think most important part is that all parents, gift of a child is given by the God. Gift to the child by the parents is to immunize the child and prevent a disease. This should happen as a routine. Therefore, education at the level of the pregnancy to childbearing and marriage, it should happen that all parents should learn more about nutrition, vaccine, and so many things about the child. You must do a better coverage of vaccination. And the coverage should, why these episodes of in between diseases happen? Because the vaccine is not completed as a booster dose. In India, less than 50% of the people complete the whole schedule of the vaccination. In UK, they didn't use 2-year vaccine, and therefore there was a recurrence of whooping cough. In Australia, they didn't use 5-year booster, there was a recurrence. In USA, the adolescent didn't use the vaccine, and therefore they had military people with suffering from whooping cough. Therefore, we should not miss on the complete schedule of the vaccinations. We must use pregnancy as an opportunity to prevent whooping cough in the child, to vaccinate the mother with DTaP. And cocooning theory is a grandfather gift to the child, because when they get vaccinated, the child doesn't suffer. Like pneumococcal vaccine gives a gift to the child, gives a gift to the parents that they don't suffer from pneumonia so often. Therefore, this gift should be offered. These, I think my major emphasis is on education and completion of schedule. And the school must have a vaccine card compulsory every year to be checked so that the compliance of completion of the course of vaccination should happen.
Right. Thank you so much, sir. And thank you again for the organizing committee to give us this opportunity. Thank you, Dr. Shah, Dr. Samdani. Thank you so much. Please stand.
Thank you so much, moderators and panelists. And as Dr. Samdani was talking, IPV shortage, and we need IPV 5 doses full. Luckily, IPV with change of origin and technology, it is going to be produced in India. And by the end of next year, we are expecting changed IPV and shortage will be over. So, with these comments, I hand it over further to Dr. Lalit for a very interesting talk by Dr. Manas Kalra on hematology.
Thank you, Dr. Prashant. And my request to the next session panelist is please do it in a time, because we are losing time. Although the time allotted is 20 minutes. So my request is if you can make it in 15 minutes. And I would like to invite Dr. Rajiv Jain for the next session on hematology. And Dr. Rajiv Jain is the Chief Consultant Pediatric in Indian Railways. And Dr. Amita Mahajan. And she's well-known hematology in charge at Indraprastha Apollo Hospital. And Dr. Manas Kalra will take up as a moderator. And we know how bright the Manas Kalra is. As always, he has done a fellowship in pediatric oncology and bone marrow transplantation from Australia. And he's always there for any hematological discussion. And Dr. Manas, it's up to you now. So I hand it over to you. Thank you.
Thank you, sir. If you can allow me to share my screen.
Sure, always. No problem. I request is just 15 minutes, Manas.
Sure, sir. So, good evening, everyone. Thank you, Delhi IAP, for giving me this opportunity. We are going to rush through all the slides. Dr. Amita, Dr. Rajiv, Delhi IAP has promised us 5,000 rupees voucher each if we finish this within 15 minutes. So let's just get cracking and finish it very soon. Also, for the participants, whenever we ask some questions, if you type the answer in the chat box, the question that is directed to the audience, if you give the correct answer, I will announce which question is for the audience. The one who gives the first correct answer will get a 500 rupees prize from Delhi IAP. So Dr. Smita, Dr. Nab, if you can just have a look at the chat box, and if you can decide the winner, that will be really, really helpful. Okay, so we'll get tracking quickly. So the first question is for Dr. Rajiv Jain. Sir, this is the slide that has been given to you. This is the peripheral smear of a patient, and this is the image of this peripheral smear. The question is, what does this slide show, and what are the DDs? Very quickly, sir.
Dr. Manas, sorry for interfering. Actually, yes, in this platform, we have three platforms. Like we have here all our attendees and faculties, which are smaller than the nucleus of normal lymphocytes. All the delegates are on third source platform. There the event organizers will see the answers and they will put it here. So the attendees here are not delegates, or our faculties here.
Okay, sir.
Okay, so this is for the delegates, and we will decide on winners later, because as if now it will not be difficult. So tomorrow we can
see all the responses there, and then Dr. Nab and Dr. Smita will decide and tell us.
Yeah. Sure. Thank you, ma'am. Thank you, sir. So Dr. Rajiv, if you can comment on this, please, quickly. Dr. Rajiv? Dr. Rajiv? I think till the time Dr. Rajiv...
Dr. Amita can take it.
Dr. Amita can take the question. Ma'am, what does this slide show? What are the DDs?
Manas, this is perhaps the commonest slide of the Indian child, which is microcytic hypochromic anemia. And as we can appreciate, there is a central pallor in the red cells. And just as a comparator, you can see that the red cell is actually smaller than the nucleus of the lymphocyte that you have put very nicely on the slide. So if it is smaller, then it is microcytic, just as a ballpark rule. If it is larger than the lymphocyte of the nucleus of the lymphocyte, it is a macrocyte. So this is microcytic hypochromic anemia. Commonest etiology will be iron deficiency in our country, but we have a number of hemoglobinopathies and anemia of chronic illness. These would be the three common DDs of this condition. Apart from that, we have chronic lead poisoning, sideroblastic anemia, and some congenital hemolytic anemias with unstable hemoglobins.
That's right, ma'am. So thank you. This was microcytic hypochromic anemia, and this was the image, and these are the DDs. Next question, Dr. Rajiv, if you are there and if you can answer this. This is a child whose hemoglobin is 4.2, white cell count is 4,200, platelet count is 50,000, MCV is 123, RBC count is 0.9. So this is the basic CBC sitting in front of you, and RDW is 22. If you have this CBC that I've shown with the MCV and everything, and this is the peripheral smear report, I think I have been, yeah. Okay.
Hello. Yeah.
Yes, Dr. Rajiv, can you comment on what you can see in the peripheral smear?
Yes. Yeah. The most of the RBCs are larger than the nucleus of lymphocytes, and there's increased MCV. And folate and vitamin B12 deficiencies could be the cause, or alcoholism or liver disease could be the cause.
Very, very true, sir. We can see large RBCs, and this is the hypersegmented neutrophil. If you see something like a hypersegmented neutrophil, it is very typical of a macrocytic anemia, either due to B12 or folic acid deficiency. And we can do a B12 folic acid level and confirm by doing a bone marrow, which is not essential in most of the cases. I think the voice is echoing. I'm not sure if that can be corrected from the organizer then.
He is connected with two devices.
There is a lot of echo.
Now it is not there.
Now it is not there. Thank you. So yeah, so this is typical of a macrocytic anemia with hypersegmented neutrophils. Other abnormalities that you can see in these patients are basophilic stippling, Howell-Jolly bodies, and Cabot rings, which can also be seen in macrocytic anemias. This is the typical knuckle hyperpigmentation associated with nutritional anemia leading to this. So how do you manage this condition? Dr. Jan, very quickly, if you can answer this, how do you manage this condition? Sir, please unmute yourself.
It's unmuted.
Okay, I think there is a problem at his end. So how do you manage this condition? We give B12 or folic acid supplements. The supplements can be given orally also. Initially, we used to think that it is only IV or IM B12, but now we know that even oral B12 works quite well. Next question. This is for you, ma'am. Identify the abnormal cell depicted in this picture. Name two conditions where you can see this.
So this is a classical target cell, which can actually be seen in a number of hematological conditions. But for us, for practical purposes, this is seen very commonly in thalassemia, all types of thalassemia. And the other condition would be liver disease, that also very frequently we see. And again, hemoglobin C, hemoglobin E. So the whole range of hemoglobinopathies, target cells can be seen very frequently.
Thank you, ma'am. So that is the correct answer. These are target cells, and very clearly you can see the image, which projects the target cell in this picture. So the next one is this image. Dr. Amita, if you can look at this image, this is the peripheral smear of a picture, and kindly tell the audience what you think this is. So what is the abnormal cell? And please mention the name of two conditions where you can find this in a peripheral smear.
As we can all appreciate, we can see these broken cells. They are called as helmet cells because they have this typical shape of a half broken red cell and like a helmet sitting on the head, or a schistocyte. We must be though careful that a badly prepared peripheral smear, this may be like an artifact as well. So here we can see that the rest of the red cells are actually very well preserved, and we see these broken RBCs. And in pediatrics, this would usually be seen in something like hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, or any other microangiopathic hemolytic anemia that we may see in burns and sometimes in G6PD deficiency.
That's right. So these are, typical of HUS. You need to look at the creatinine value. You need to look at the platelet count of this patient, and then you'll be able to make the correct diagnosis. So you need your hematologist's help to diagnose this condition. So now this question is for the audience. If Dr. Nab, Dr. Smita can later look at, who is answering this question first. So I'll show the image. So this is a 12-year-old boy who has fever for 7-day duration. His pediatrician noticed cervical lymph nodes, and there is a spleen which is palpable 1 centimeter below the left costal margin. This is the peripheral smear of this patient. What do you think is the abnormality? So this is for the audience. If you can see this image and answer the question. So what is the diagnosis? What is the investigation that you will do to confirm it? And what is the management? I'll again show the picture. What is the diagnosis? What are the investigations? And how would you like to manage? So I hope the ones who know the answer have given it.
Manas, is it atypical lymphocytes?
So that's right. So these are infectious mononucleosis cells.
Right.
These are atypical lymphocytes associated with infectious mononucleosis. That is the characteristic ballerina skirt appearance. These lymphocytes stick to the RBCs and form this kind of a pattern. And these are large lymphocytes, and they can be confused with blasts at times. The investigation is a viral capsid antigen or a EBV viral PCR, and the treatment is essentially symptomatic. So we'll move on to the next question. The next question
remains in the competition or not?
It remains, ma'am. If somebody has answered it and the first person who answered it, I think you can give him a 500 rupees prize. Thank you. Okay, so this is the image of a patient who has presented to a hematologist. The image depicts a child who is being evaluated for anemia for the last 2 years. She has failure to thrive. Dr. Rajiv, can you take this question? And if you can unmute yourself.
Yeah.
CBC of this child reveals a hemoglobin of 7, a white cell count of 4,000, a platelet count of 1.1 lakh, and the DLC shows neutropenia. Bone marrow is hypocellular. Now again, there is a similar patient. This male child has a similar disease as similar to the previous patient that we saw. And there is hyperpigmentation of the skin and flattening of the hands. So this is the child that comes to you, and these are the investigations. Sir, what do you think is the diagnosis of this patient?
Well, the most likely diagnosis would be Fanconi's anemia, and chromosomal breakage study could be used for specifically diagnosing it, and bone marrow transplantation would be the treatment of choice.
Very right, sir. Very true. So the high MCV, often people think that this may be megaloblastic or macrocytic anemia. Actually, Fanconi anemia is associated with high MCV. So this is a Fanconi's patient, and what you need is a bone marrow transplant, and a chromosomal breakage study helps to diagnose this condition. Dr. Amita, if you can take the next question. Ma'am, this is the HPLC of a patient where you can see the HbF value of 92%. Now, this is a 4-year-old child who has come to you for the first time, ma'am, and the child has pallor and splenomegaly. The hemoglobin is 7, the MCV is 59, and the RDW is 32.4. Ma'am, can you tell our audience as to what do you think this child has and what are the DDs?
So Manas, a 4-year-old boy with moderate anemia, which is microcytic hypochromic, with a high RDW and with a HbF of 92%. This is the picture of homozygous beta thalassemia. Now, when we see this HPLC, we would have expected this child to be actually transfusion dependent from early infancy. But according to history that you give, this child has never received a transfusion and for the first time sought hematology opinion. So by, HPLC, which is like that of a thalassemia major, but not requiring transfusion, till the first 2 years of life, the technical label that we will give him is thalassemia intermedia. So that this would be the picture that we see in thalassemia intermedia. So the HPLC report should not actually report this as major. It should just report as homozygous beta thalassemia. If this child is on regular transfusion, then he has major. If he has, like this child, never received a transfusion till the age of 4, then he has thalassemia intermedia. Now, how we choose to manage him beyond this point will depend on a number of factors.
That's absolutely correct, ma'am. If this child walks into your OPD, ma'am, what are you going to do for the management of this child?
So for our first choice would be to put him on a drug which may further increase his fetal hemoglobin and may help us in getting a better hemoglobin, and which would be hydroxyurea in our usual clinical practice, though there are a number of other such drugs currently under evaluation. But as of now, it will be hydroxyurea. And if the child can maintain a hemoglobin above 7, adequate growth and development, and not develop dysmorphic features, we can continue to manage him without transfusion.
That's right, ma'am. Thank you so much. So the next question, we will keep this for the audience. If they can just write the answers. I don't know how successful is that going to be, but I think, we can still make an attempt. A 6-year-old girl presents with a history of jaundice for few years. So the parents say that, the child is chronically jaundiced. Jaundice keeps fluctuating. She is pale, she has icterus, and she has a spleen which is palpable. This is the peripheral smear of this child who comes with jaundice, anemia, and also splenomegaly. This is the peripheral smear. The question is, identify the abnormality and what is the characteristic finding in RBC indices. So what is the abnormality? Just quickly, if you can write it down, what is the abnormality and what is the characteristic finding in the RBC indices? So I won't waste much time. I'll go to the answer straight away. The abnormality that we see here is spherocytes. So these are spherocytes, characteristic all round spherocytes, usually similar in shape and similar size. And the characteristic abnormality is high MCHC. The MCHC is high usually in these patients, more than 35, 36, and that helps us to make the diagnosis. The next question is for Dr. Rajiv. This is a 5-year-old girl who presents with joint pains. There is joint pain, there is lethargy, there is malaise, there is poor appetite. Movement is restricted, there is pain, there is pallor, there are small cervical nodes. The child has been treated as a juvenile rheumatoid arthritis. The child has been treated for rheumatic fever, and somebody thought it may be a septic arthritis. The child comes to you, the child is not responding, and the CBC shows a hemoglobin of 7.2, a white cell which is high, and a platelet which is low. The neutrophils are 15%, which are low, and this is the peripheral smear of this picture. Sir, the question to you is, what is the diagnosis and what is the cure rate of this condition?
Well, most likely diagnosis, of course, could be acute lymphocytic leukemia, and cure rates of ALL at present are close to 80%.
That's right, sir. So this is acute lymphoblastic leukemia. So any such patient who presents where you have any doubt, please do a bone marrow, get a good peripheral smear examination. Even if the peripheral smear is normal, make sure that a bone marrow is done so that we don't miss a leukemia. This is the 10th case, and if we are crossing the time, we can just make this as the last case. The organizers can guide us. Ma'am, this is for you. This is a 2-year-old child with fever for 7 days, mild cough, splenomegaly, SGOT is 4,000, SGPT is 5,200. So the liver enzymes are very high. There is anemia, there is leukopenia, and there is neutropenia. The LDH is high, and the workup so far has been negative. So a child who's been highly pyrexic with all these abnormalities. This is what you see in the bone marrow examination of this child. Ma'am, can you comment on what you can see, the image, simple test to pick the diagnosis, and what will be the treatment of this condition?
So Manas, this large cell right in the center of the slide is a macrophage which shows hemophagocytosis. Like you can see the ingested red cells and platelets within this large cell. So there is hemophagocytosis, and though it can be seen in a number of other conditions, along with the other features that you have described, fever, transaminitis, splenomegaly, cytopenia, high LDH, this would be consistent with a diagnosis of HLH or hemophagocytic lymphohistiocytosis. Now that could be primary or secondary. This is a 2-year-old child. Usually the primary HLH, which is due to a heritable mutation, usually presents in infancy, but can present later also. But secondary HLH is the far commoner variety that we see in clinical practice, which is usually secondary to an infectious trigger, usually a virus, but virtually any infection, malaria, typhoid, Kala-Azar can trigger HLH. The commonest marker or the most easily available marker is serum ferritin, and the specificity of serum ferritin as a marker of HLH increases with the value. So above 10,000, when ferritin is above 10,000, other than fulminant viral hepatitis, there is virtually no other, or iron overload, there is no other condition that will cause such high serum ferritin. So serum ferritin is a very good biochemical marker. But the diagnosis is based on the constellation of at least 5 of 8 possible factors, mostly clinical or lab. So these are the 8.
Please mute yourself. Please request everybody to mute yourself. There is a lot of disturbance coming. Please mute yourself so that the panelists can give the answer, please.
If we have
Dr. Amita, you will have to unmute yourself.
So in the presence of persistent fever, if 5 of these 8 clinical criteria are positive, then we can label the child as having HLH. There is no one hallmark test as such. It is a constellation of clinical and lab parameters. The management will again depend on whether it is primary or secondary. The commoner variety is secondary HLH, and treatment of the trigger is the fundamental treatment. But if that does not adequately control the constellation of symptoms, then a course of steroids can be considered. And for those who fail steroids or recur once we withdraw steroids, the full HLH treatment with the steroid, cyclosporin, and etoposide is considered. For primary HLH, we again begin the treatment similarly, but once the disease is a little more, the child is stable, allogenic bone marrow transplant is the only curative treatment for primary HLH. But fortunately, that is much rarer.
So that's right. So most important investigation is ferritin, and most of these patients will have very high ferritin values, more than 3,000-4,000 on an average, and you'll be able to suspect and pick this diagnosis. The other things would be hypertriglyceridemia, low fibrinogen, and cytopenias. The next question is this 3-year-old child.
Manas, we can stop it here. We are already late by 1 hour.
Manas, I think 10 cases have been taken. And
yes, sir. So thank you so much, all the panelists, for the wonderful participation. And if there are any questions, we can solve them later. Thank you so much.
Thank you very much, Manas, for the taking this quiz section, and it was really wonderful. And I'm sorry that we are just cutting it short, but definitely it was one of the best sessions. Thank you.
One of the best things is we can call Dr. Manas anytime. He's always available. Very nice. But thank
you so much.
It is always interesting.
Thank you, Dr. Nab and Dr. Smitha and Dr.
Thank you, Dr. Amitaji. Thank you very much.
Thank you so much.
Thank you, Dr. Raju. Thank you, Dr. Amita.
Thank you, ma'am.
Next session, please. Thank you, Amita. Very nice to see you.
Thank you.
Next session, I would like to invite Dr. Next session is on what is new in Kawasaki disease. And for that, I will request the panelist, Dr. Nomita Gupta.
Good evening to all of you.
And Dr. Swati Bhardwaj. I think we'll straight go to Dr. Sujata If you don't mind, Chairperson, because introduction will take time. They all are well-known pediatrician in South Delhi, and Dr. Sujata Sani is the consultant pediatric rheumatologist. And I will request Chairperson to please request Dr. Sujata Sani to start the session.
Am I audible? Can you see the slides?
Yes, yes, ma'am.
Yes, can I start?
Yes, please.
Okay, good evening, everybody, and welcome so much to this rather late session. And I would like to thank the Delhi IIP to give me an opportunity to talk to you today. So I'll just be briefly talking about Kawasaki disease and what's new about it. And this is just going to be a run through because it is rather late. I'm going to consider for you this evening a few important new developments for diagnosis of incomplete Kawasaki. How do you define an abnormal echo when you see one? What are the new things that are coming about in the acute management? What about anti-thrombotic in the long-term care? So really the go-to paper, if you listen to nothing else but just this, is the go-to paper for management of Kawasaki disease must be the American Heart Association 2017 position paper, and a lot of what I'm going to talk is coming from here. So incomplete Kawasaki disease, you're aware about this consensus algorithm, which was given by the AHA in 2005. This has currently been superseded by this new algorithm, which has been published in 2017. It's very important for us to understand that if a child has less than 3 criteria of Kawasaki disease that you're very familiar with, note that it is an inflammatory condition. And when you look at these patients, always remember to look at the SGPT and the serum albumin in addition to the complete blood count. Also remember to look at the urine. And if the child is fitting more than 3 laboratory criteria and has high inflammatory markers, don't forget to do the echo. This is extremely important. The other very important thing which the AHA paper has pointed out is which are the clinical scenarios where you must consider incomplete Kawasaki. Those are young infants under 6 months of age with prolonged fever, a child with prolonged fever and aseptic meningitis, a so-called culture negative shock that you may be treating as a bacterial sepsis, a child who has a cervical adenopathy that is currently unresponsive to therapy, and a child who's got a parapharyngeal phlegmon that is non-responsive. So remember, these are conditions where you must think of incomplete Kawasaki. Why is it important? Because children with incomplete Kawasaki have a 30% of risk of developing a coronary artery lesion, and therefore you must be very vigilant for these children. Let's now come on to the second important issue I'd like to cover. How do you define an abnormal 2D echo? The American Heart Association has given very clearly what are the sizes of a small, moderate, and large coronary artery aneurysm. And these are all defined, as you're aware, by a Z-score. So what's a Z-score? A Z-score is defined as abnormal if it is more than 2 standard deviations and a 2.5 standard deviation. And that is a coronary artery dimension which is more than 2.5 standard deviation above the mean for the particular body surface area of that child's age. And note that if you have one arterial segment which is abnormal of more than 2 SD, it is likely only in 0.6% of the normal population. And when you go to a Z-score of more than 3, then the percentage positivity in the normal population is only 0.1%. Note that the LMCA should be interpreted with caution because it has got a variable cause, and therefore you must interpret isolated LMCA dilatation with caution. So that said about the definition of the Z-scores, and also currently the definition in the 2017 has again been modified. And if the child does not have a Z-score of more than 2.5, then you look at certain other features in combination when you do the echo and think of abnormality. And these include a decreased left ventricular function, mitral regurgitation, pericardial effusion, or a Z-score between 2 and 2.5 and 2 of the arteries mentioned there. Of note, what was earlier mentioned in 2005 of increased perivascular coronary artery brightness, the lack of tapering or utilizing the Japanese criteria have been excluded. So these are very important as you interpret the findings of the echo that you get done. Let's now go on to management. I think the most important thing you should understand about the management today is that you need to stratify the patient. So for example, if you see a child with enteric fever, you're not going to treat every child of enteric fever with the same drug. You may want to give someone oral, someone IV, some a touch of steroid, someone inotrope, someone who's got a perforation may require to be opened up, and so on and so forth. So what are you doing? In your mind, you are stratifying the patient with enteric fever. In the same way, when you have a child with Kawasaki disease, please remember that one size does not fit all. All patients are not the same, and you need to stratify the child. So let's look at the clinical considerations. A very young infant under 6 months is likely to run into trouble. A child who's got cytopenias is specifically if the child has got a sky-high ferritin and has got a lowish platelet count, may require steroid. A child who's presenting with shock is obviously going to require steroid and vasopressors both. And a child who's got a concurrent infection is going to require the appropriate antimicrobial, antiviral, or antibiotic as the case may be. And what is very important is a child who presents to you in the clinic with coronary artery lesions. Why is this important? We are sitting in the center of the country in Delhi, and in our own data, we see that 45% of patients who are referred to us are already coming to us with coronary artery lesions. And clearly, those patients need increased therapy. The second important thing is if a child presents to you with coronary artery lesion, we'll come to what anti-inflammatory medication you want to use. But remember, in patients with Kawasaki disease, if they have got significant coronary artery dilatation, what are you trying to prevent? You're trying to prevent an acute coronary artery thrombosis. So in addition to the anti-inflammatory, you're going to use an anti-thrombotic drug. Which drug are you going to use for which patient? Again, the key word for you is stratify. This is an excellent table, which is from the AHA 2017 paper that gives you very clear guidance as to which drug you're going to use for which patient. We don't have the time to go through all this, but let's pick up, for example, 5.2. A patient has a large or a giant coronary artery aneurysm, which has now become small as you followed up the patient. How are you going to treat the patient? What are you going to use? You're going to use low-dose aspirin. You are going to use warfarin. You may want to now switch the child to a combination of clopidogrel and aspirin. You may consider beta blocker for the child and perhaps use a statin as well. So it's very clearly delineated as to which drug you need to use depending upon the current size of the coronary artery lesion. Somebody is writing on the slide. Can I request you not to do that, please? And finally, the third concept that I'd like you to understand is that there are 3 ways of treating a patient. The first thing is that you use just IVIG and aspirin, which is standard of care. The second is that you have identified by some clinical method or some score, for example, a Kobayashi score, that just IVIG is not going to be adequate for the child, and therefore you add a second layer to this patient's treatment. For example, you may want to add steroids. And when you're adding a second agent upfront, that model of management is called primary intensification. And then maybe your child did not do very, very well with the first dose of IVIG, persisted to have fever, and you then are going to rescue the child by adding a second agent. So there are 3 methods of therapy: standard, primary intensification, and rescue. So what are the change agents we can use for these patients who are unwell, who come to us with KD? So really the anti-inflammatories are 4: aspirin, IVIG, steroids, and anti-TNF agents. Let's briefly run through them. Aspirin. Excellent meta-analysis, more than 8,000 patients, mostly patients from the Korean peninsula. And what did they show? This paper showed that the coronary artery aneurysm, based on the Z score, was higher when a higher dose of aspirin was used, suggesting very clearly that high-dose aspirin is not good for your patient. And then came about another excellent paper which compared in a large number of patients, I think the number of patients were 260, what was the outcome change about the fever and the coronary artery lesion in 2 groups of patients, one who were given less than 10 milligram per kg of aspirin, one who were given high dose. There was no change in the fever, in the coronary artery lesion, or the length of stay. Thus again telling us that high dose aspirin is not a very good idea. And here's the Cochrane database review that said that there's insufficient evidence to give high-dose aspirin to all patients. So question you have to ask yourself, you're using 80 to 100 milligram per kg for your child. Are you harming that patient? Coming to IVIG, this was the landmark paper of 1984. Again, the study came from Japan, which showed very clearly that if you had two groups of patients, one given aspirin and the other IVIG and aspirin, the risk of coronary artery lesion in the group given IVIG was remarkably less. And following this, it became the standard of care. So there's no discussion on IVIG. It's the standard of care for all children with Kawasaki disease. And what is the 2017 paper talking about the primary management of these patients? They talk about of a moderate or a high dose of aspirin. So they've left the decision to you, and they talk about intravenous immunoglobulin. All right. So this is where the 2017 paper leaves us. What about now coming to the next management protocol, which is primary intensification of therapy? You know that for the last 50 years, using steroids was an absolute no-no. And this was based on a very small, rather flawed study by Cato that was published in 1979, following which steroids were not used across the world. And then came many years later, in 2007, the Neuberger paper that looked at a pulse of high-dose steroid in an unselected population of Kawasaki disease, and they as well showed that there was no difference in the coronary artery lesions. And you can look at these bars. The risk of coronary artery abnormality at baseline, week 1, week 5 was not any different whether the patient was given intravenous pulsed methylprednisolone or not. And pulse here was 30 milligram per kg. And following this paper publication, steroids were absolutely not used for the next decade. And then along came in 2012, a very interesting study from Japan, which showed us that in a selected group of Kawasaki patients, where you anticipated they were not going to respond, and in this set of patients, it was using the Kobayashi score. If you used upfront primary intensification with low-dose steroids, the patients did remarkably well. So well that the trial had to be terminated, telling us that in selected patients, steroids are very good, and this was confirmed on further meta-analysis. And therefore, it was understood that steroids are very good in a small subset of patients with Kawasaki disease. The Cochrane database that came out in January 2017 suggested you should use steroids in all children with Kawasaki disease. What does the AHA paper state? The AHA paper is again ambiguous. It's left the decision to you. Because of the Neuberger paper, they say don't use high dose. But if you can identify the child who's unlikely to respond, go ahead and use the dose that the Japanese use, which is 2 milligram per kg per day. And this is the features which are taken to calculate a Kobayashi score. And outside of the Japanese subcontinent, the score has been shown to be specific but not very sensitive. That is to say, if a patient in India meets the Kobayashi score of more than 4, they are unlikely to respond, but you don't have to rely only on that, because with that you miss a lot. And along comes a fantastic review just a couple of months ago. Again, this is from Japan. What is this study about? 1,593 historical controls were taken of Kawasaki disease, and those patients had got only IVIG. They were compared to the new group of children who were given IVIG and steroids as primary intensification, and look and see the risk of developing coronary lesions if you were given steroids was remarkably lower than the historical cohort, such that the internationally recognized figure, Professor Jane Burns, has written an editorial suggesting we really do need to revisit patients to be given steroids. We won't spend much time, but just talking about anti-TNF, using infliximab upfront primary intensification, no effect. Using etanercept upfront, no effect. Using cyclosporin, no effect. What does the AHA primary intensification say about anti-TNF? It does not talk a lot about it at all. Another drug, cyclosporin, not much effect at all. What about the child who has presented to your clinic with Kawasaki disease and already has aneurysms when you first see the patient? This is a retrospective review just published about a year ago. If in case you are given only IVIG, you continue to have an increase in the coronary artery Z score. But if you are given primary intensification with steroid or infliximab, you tend to do better. Once your patient has not responded, let's now come on to the rescue therapy. Giving only IVIG, is that sensible? Not very sensible, because half those patients don't respond. What has the AHA paper said? They have left it open, and said if your patient didn't respond first time around, you have a menu choice, and they've left it really quite complicated. Yes.
Dr. Sujata, request to, if you can speed up the discussion, please.
Yes, I'll be finishing in exactly half a minute. What about still being awaited? This is the use of anti-TNF versus IVIG in a failed patient. And I think the European consensus, which has come out more recently, tells us very clearly which are the patients who need to be given steroids. Those are the children who didn't respond to the first IVIG. If they have a high Kobayashi score, if they present with HLH shock, they are infants or they already have aneurysms. So steroids are not so bad after all, and one size does not fit all. And remember that we know that you can get Kawasaki disease with infections. And here's a patient with a psoas abscess, and of course now you know that you have seen MISC or PIMS TS patients with COVID-19 infections as well. So the AHA 2017 paper needs to be looked at very carefully. You need to interpret it very carefully, and don't be confused. Think rationally as to how you want to understand this literature which has been published. We have changed our practice in our unit. If a patient has any coronary artery lesion, they are given upfront steroid with IVIG. If they don't have a lesion, they are given 30 milligram of aspirin along with IVIG. And the role of the antiplatelet agent or the anticoagulation depends upon the size of the coronary artery lesion. There's also excellent data on how to systematically follow up the patients if they have a coronary artery lesion, and that we will leave for another day. But just to leave you with the concluding slide, so the management of Kawasaki disease is dynamic. It has changed remarkably in the last couple of years. Life has certainly come a full circle. We are not scared of steroids any longer. You need to stratify your patient both clinically and as for the coronary artery lesion. And this is both acutely and for the follow-up. And now that we know that Kawasaki is occurring in children with COVID-19, should we really state that it's not a single disease, but a syndrome which may have many, many triggering agents? And thank you so much.
Thank you very much. We welcome our esteemed guests from CIAP, Dr. Bakuljan Parekh, Dr. Piyush Gupta ji, and Dr. Anna Vasudev. Thank you. Please carry on.
Any comments from the chairperson? Just brief comment, Dr. Namita, Dr. Seema Kapoor, and Dr. Bhardwaj. Any comments?
As usual, Dr. Sujata Sani made it very clear and it sounded so clear and easy that KD is so easy. But if any problem, Dr. Sujata is always there for us.
Yes,
thanks
please,
for an
always.
excellent presentation.
Thank you so much. Thank you.
Now we come to the next this thing. Please introduce the next chairperson, Dr. Sunita Bijania. We will have the session on genetic evaluation in pediatric diagnosis. And she is the senior consultant at Gangaram Hospital in Department of Medical Genetics. And I will request her to please start this presentation. Dr. Sunita, please start.
Yes. Good evening, everyone. Thank you, sir, for your kind words. And thank you, the organizers, for allowing me this presentation.
I would request, ma'am, if you can have the session in 15 minutes, because we have the validity functions and our dignitaries are also waiting.
I will try to do it, sir.
Thank you, ma'am.
Yeah. Okay. So I'll just get started with the genetic evaluation. Well, we all know that it's all about the DNA in us, and there are a whole lot of tests that can be done to diagnose a child who has a genetic disorder. So what we need to create similes.
Rohit, we don't want this disturbance.
So let's look at the DNA very much like a rail track. So they are double-stranded, they are connected with each other with the hydrogen bonds, but probably it is too simplistic. The DNA in us is more like this, multiple tracks of railway lines, and perhaps more realistically, within the cell, it is like this. So it's really complicated. So the idea is not to show you this, but to say that within on these tracks are a lot of trains, which we call genes, and each gene has its own, components. So there is a starting point. You can say promoter or the first exon. Then these parts called exons. And then within these exons, we have these sequences of nucleotides, or very much like the windows of the train carriage. So when we have to study the genetics, we can actually zoom into from the grossly speaking the chromosome into going down to the level of a single base pair. So it is really vast and very, very extensive. And that's why there are so many tests. Now, I have been given the responsibility of telling you about the exome and the genome. So basically, this is a genome. The entire DNA within us in each cell is a genome. But there are various types, ways to study this. So this is a very simplistic karyotype where we look at just the chromosomes. So it's a very basic test. When another basic test is a test of a single gene. So for example, we have to have a clinical diagnosis first. We talked about thalassemia earlier. So it is a single gene disorder. And to make a disorder, we don't necessarily need to study the gene. The diagnosis is made by hematology. But even if we have to study the gene, it is only about 3 exons long. So it's not very difficult. So, but what happens when we need to study many genes together? So that's when the next generation sequencing platform comes in. So here, very simplistically stating that let's say all the trains are now studied together. And these are all the genes or the fragments of every gene, multiple. You can create panels of 10 genes, 1,000 genes, or even the whole 22,000 genes or so. So simultaneously sequencing each and every letter of the coding regions of the gene is what entails whole exome. So this is what we are into, the era of next generation sequencing. So to put it another way, it's a massive parallel sequencing that we offer. So it enables multiple segment sequencing in one go. And any number of genes can be tested. So here I've given an example of muscular dystrophy, where there could be anywhere between one gene in DMD that we can suspect easily to about 150 genes. So one really needs to resort to the NGS technology to get to a diagnosis. So within the next generation sequencing also, there are two major tests. The one is a whole exome sequencing. The other is a whole genome sequencing. So here, when I said whole exome, let's go back to our rail track theory and the trains. You're only studying the sequences of all the trains, all the genes. So all the coding regions of all the genes in our body are studied, and not the entire genome. The entire genome actually includes all the rail tracks. So there are certain areas where there is no train, there is only a rail track. That's the genome. So exome essentially comprises only about 1 to 1.5% of the entire genome. And majority of the changes, where the functional regions and the changes which will give us the diagnosis lies there. So about 85% of the diagnosis lies in the exome. This is again another way to say that we have 3 billion base pairs in a single genome in our body. 1% of the genome is what we call is an exome, and we have 20,000 genes that we know of now. Not all the genes have been deciphered, like the function is not yet known. Not more than 5,000 genes are there where we really know the function. Then exome, but this 1% or the exome is expected to cover 85% of the disease-causing variants, and because they are present in the functional part that we understand. Now, what is the implication of all this? So let's come to our clinical practice. So here is a child in the clinic, about 18 months old girl who presents with motor developmental delay, and parents have noted that she has had frequent upper respiratory tract infections. She does have a protruding abdomen and a gibbus in the spine. So there has been in the family a similar affection of an elder boy who died at 2.5 years of age. So when we look at the little girl, she has a very recognizable phenotype. And she has coarse facies. She has like this corneal clouding. She has open mouth with a large tongue. She had an umbilical hernia. She had hepatosplenomegaly. She had a kyphus. And when we looked at the X-rays, there were dysostosis multiplex. So it was very easy to make a diagnosis of what we call a mucopolysaccharidosis. Now, with the 2 children in the family, both males and females, and with the corneal clouding, and with the age of presentation, particularly with the gibbous and all, one could reasonably establish a clinical diagnosis of MPS type 1. So for MPS type 1, we don't really need to go for an exome. All we need to do is do a urine MPS as a screening test to know whether the gags are present, and then we are on the right track. We can order an enzyme assay. So here in this case, the enzyme assay was done to diagnose MPS 1, which is alpha iduronidase, and it was noted to be really deficient. So that clinched the diagnosis. Of course, genetic studies are needed, and they have their another purpose. One is to confirm the diagnosis. The second is to be able to offer prenatal diagnosis in the same family. Now, coming to child 2. The first child was fairly simple, clinically recognizable, no need for the high-end tests. This boy, 9-month-old little boy, very delightful, presented at this age with a history of frequent episodes of respiratory distress since the age of 3 months. On examination, he had come with an X-ray, and it showed a cardiomegaly. He also came with an echocardiogram because he was referred by a pediatric, our pediatric cardiologist, and the diagnosis was dilated cardiomyopathy. So our role was basically to establish the diagnosis in this child, or once the diagnosis, then it would the logical question would come whether we could treat the disease in the child. Even if not treat, we could at least aid in prognosticating the family about the disease and the child, and of course, for planning a future pregnancy in this family. Now, going about investigating the child, so after a thorough clinical evaluation, where we noted hypotonia, failure to thrive, motor developmental delay, and also with the echocardiographic diagnosis of cardiomyopathy, we made an impression, and we thought of some treatable causes first. So within the treatable causes are simple disorders such as primary carnitine deficiency, which is very easily treatable with just carnitine therapy, and also Pompe disease. But alas, the child did not have any of these, and we did note an elevation of lactate. So here we are with the child with cardiomyopathy, and in order to make a genetic diagnosis, we really did not have any particular gene in mind. So this was an ideal candidate where we would think of doing the next generation sequencing. And here it was all about the genes. So we asked for a whole exome sequencing in this child, and we did get a diagnosis of a combined oxidative phosphorylation deficiency, which is kind of an autosomal recessive nuclear encoded mitochondrial disorder. So of course, this child deteriorated very quickly, and the parents lost the child, but we did have this diagnosis, and now we can think about doing a prenatal diagnosis in their next pregnancy. Now, coming to genomic testing, basically when we say genomic testing, it's not very specific. It is entailing the entire genome, and that's why there are basic 2 types or 3 types. One is a chromosomal test, and that's not including the genes. It is just a chromosomal test because it is studying all the chromosomes, and the best way to do is by a microarray. And the microarray is basically a very, very magnified view of the chromosomes, and it is testing for all the regions on the chromosome, which may include as little as 1 gene or 10 genes or 100 genes. Then we come to the next generation sequencing, I've already said, which could be just a panel of say 10 genes. It could be what we popularly know as clinical exome sequencing, or it could entail the entire exome, which is called whole exome sequencing. Now, the whole exome sequencing can be done as a solo, just on the patient, or it could be combined with the trio, that means with including both the parents. Now, there's something else that we call a whole exome CNV. CNV is a copy number variation. Basically, this means combining the two, because when we do a next whole exome sequencing, we do miss out the copy number variants. The test cannot identify a heterozygous from two copies of the same gene. Now, the whole genome is slightly more vast, and it is, of course, it is because it has 100% of all the DNA, and it is coming very rapidly into our clinics, although it's used mainly for research purposes. Now, what other tests are there for genetic testing? This is basically guided by our phenotype. So, for example, if it's a very clearly identifiable syndrome like this one, we only order for a karyotype and we get our diagnosis of trisomy 21. Or if we identify a child who by facial gestalt or by some other very typical features we can identify, we can use what is called a FISH test or a fluorescent in situ hybridization. In this particular child who has clinical identification of Williams syndrome, we went for FISH, which is on chromosome 7. So here there is a deletion of this part of chromosome 7, and these are the controls showing 2 copies. Now there are various biochemical genetic methods to identify metabolic disorders such as galactosemia, tyrosinemia, NPS group. I alluded to all the lysosomal storage disorders which we identify by enzyme assays, etc. So this is not part of my talk. So basically we'll be moving forward. In molecular genetic testing, again, when we think of a single gene disorder, we don't really go for the high-end next gen. We really have to identify what test is to be done, and that is guided by the mechanism of the genetic defect. So for example, in this child who has spinal muscular atrophy, we know that the genetic defect is basically a deletion of the gene and not any sequence variant. So what we will do is just an ordinary PCR, which will identify a deletion of one exon of SMN1 gene. So it's a very simple targeted test, not very expensive. Then if we come to this child who has clinically identification of a Fragile X syndrome, we will not again go ahead with the bigger test, but an ordinary PCR, because the mechanism of this is basically expansion of a certain 3 base pair repeat sequence. So there's another method to identify that. Similarly, in a child whom we have clinically diagnosed as Prader-Willi syndrome, we know it is not a sequence variant. So another test will identify its imprinting defect. We know that it's the father's copy, which is very essential to avoid this disorder on chromosome 15q11. So the methylation test is able to bring about any of these options, which will give a diagnosis of Prader-Willi. Either it's a deletion of the paternal copy, or if it is a uniparental disomy, which means mother's copy is duplicated with absence of father's copy, or a mutation on the father's allele, or it's an imprinting defect. So these are the few examples where you don't really need to resort to exome sequencing, but sometimes we do. So in this particular child who has dysmorphism, she also had a cardiac defect. So our clinical diagnosis was Noonan syndrome, which only has about 13 genes. So we did have the choice of doing just the panel of those 13 genes, or a clinical exome, which will cover 5,000 genes, or a whole exome, which will cover 20,000. So basically, we need to know as pediatricians when and what test to order. You really have to individualize your patient and not just blankly ask for NGS. So NGS is not an answer for all genetic disorders. But of course, it's very easy to order this test, but it's a big responsibility to decipher, to provide a diagnosis based on that test. And then we are faced with this
Mute yourself, Dr. Lalit, mute yourself.
variants of uncertain significance or VUSs. So basically, whenever the laboratory identifies a variant in a gene, it has to classify it into one of these 5 types, which is according to the ACMG criteria. So while the first 2 are quite good because they give us a diagnosis, they are basically disease-causing variants. Some of them are clearly, say, premature stop codon.
Dr. Sunita will have to hurry up, please. Last 2
This
minutes.
is one of the last slides, sir.
Thank
so
you.
What I just want to tell is that by doing NGS is not the end of the story. Sometimes we do have to do some post-NGS workup in order to bring clarity to the diagnosis and to give a correct answer to the patient. And of course, there are very many reasons when the NGS will not give us a diagnosis. And then, of course, various reasons for that. Just to conclude, we know that NGS or next generation sequencing is here to stay. It is the next era of diagnostics, but adequate clinical workup and understanding of the case is required before one orders the NGS test. One could approach the evaluation in 2 ways. One is the forward way, where you identify the phenotype and then make some diagnosis and then go ahead looking for your confirmation. The other is to do the genotype first and then follow it up with functional studies, which is called reverse phenotyping. So although it is quick, inexpensive, and reasonably accurate, clinical assessment in combination with consistent biochemical phenotype is indispensable tool for at least the inborn errors of metabolism. With that, I conclude and thank the organizers very much.
Thank you so much, madam. Thank you so much.
And any
Thank you. Yeah,
we can chairperson, otherwise we must.
I'm sorry, I rushed through.
Thank you, ma'am, for a very lucid and very presentation. And as the technology, as you rightly said, it is very important to know which tests should be ordered when, and it's just the beginning. It is not the end of your investigation. Thank you so much.
Okay. So we can move on for the next session.
Right. So
Dr.
next
Lalit.
session is the last session of this conference, and that is a very important topic, common poisoning in office practice. And for that, I will invite our chairperson, Dr. R.K. Advadi, who is the consultant at BLK Hospital, Dr. Yogesh Parashar. And Dr. Yogesh Parashar is at Holy Family Hospital, consultant pediatrics, followed by Dr. Manish Gupta. He is our dynamic secretary, IAP Delhi. He will be taking the baton from Dr. Smita on 1st of January and myself. And I can just welcome Dr. Suresh Gupta due to paucity of time. And Dr. Suresh Gupta, we all know, is the consultant pediatrician at Gangaram Hospital. And he has got a special interest in toxicology, and he's dealing with poisoning cases, and he's going to soon deliver a book on this. So I welcome Dr. Suresh Gupta. Please start. And it is a panel discussion. And again, in view of the shortage of time, we have requested to make it in just as small time as possible. So welcome, Dr. Suresh Gupta.
Thank you, Dr. Lalit. Without wasting time, we'll go on to directly this panel discussion. And all of you know the panelists who are there, they are very learned. Dr. Lalit is with us, Dr. Manish Gupta, Dr. Yogesh Parashar, Dr. R.K. Advadi, and myself, Dr. Suresh Gupta. So let us go on to this case directly. This is a 3.5-year-old child who is brought with a history of ingestion of unknown substance while he was found playing outside the house. And child has come to your emergency room or your office. At present, the child is asymptomatic. So I'll ask this question to our panelist, Dr. Lalit Mehta. What should be the general approach in managing such children?
Sir, the first is the general approach is in the case of a poisoning is usually always the important is the history taking. I think history is very, very important. And if the child is very sick, again, the ABC protocol, stabilization of the airways and breathing and circulation. Once you have stabilized, and then you immediately get a blood glucose done if the child is unconscious. And of course, there are if circumstances suggest that naloxone administration can be given. And the important point from the history point of view is the accurate history, who is bringing the child to the hospital or the clinic, the circumstances in which the medicine or drug was taken, and just find out whether it was unintentional or intentional. Intentional is usually in adolescents, whereas unintentional is usually in the young age group below 6 years, in which the poisoning are common. Find out the drug, batch, number, pills, because most of the time these are the parents taking medication at home. And important thing is the child environment. What are the circumstances in which the child is living? Are there environmental stresses at home? Who is looking after the child? Who is the caregiver? And finally, if we don't know where the exposure, this substance, then of course, in the circumstances where the child was found, in the kitchen, garage, room, or in laundry, so that can help us to point out the substance taken. And of course, timing is very important if we are able to find the quantity. An important thing in history in adolescent is that complete history of drug, drug taken also should be taken. And of course, pregnancy has to be ruled out. So urine test is important in this case. And in doubt, always call poisoning cell center. The helpline we will be telling.
So that was next question also directed toward Dr. Levitt. Any baseline investigation should be done in all the cases?
The baseline investigation, right? Baseline investigations usually, basically after the complete initially stabilization of the airways ABC, try to find out, immediately do a quick basic physical examination of vital signs, especially the states, examination and order. So these are the important signs. And then please unmute yourself. And in the laboratory, as such, there is no lab test which will be helpful in poisoning case. And there are only very few medications in which the lab studies are important. You get the drug levels done like salicylates, paracetamol, anticonvulsants, iron digoxin, or in case of ethylene glycol. And urine drug screens are available for adolescents, in which we can find in case of substance abuse. And of course, pregnancy test has to be done in any female child. Pregnancy has to be ruled out. Apart from this lab investigation, apart from the few baseline levels we get in few specific medication, ECG is done if there is a suggestion of tricyclic antidepressant. And of course, the ECG and can detect the Widen KORS intervals in case of TCA, diphenhydramines, these drugs. Sometimes few medications can cause prolongation of KOTC interval if there is suggestion of antipsychotic drugs. And X-ray is done usually when you suspect a hydrocarbon, aliphatic hydrocarbon, kerosene oil or oil ingestion. And plain X-ray abdomen can be done in case of metals, usually pellets have been taken by the child. And of course, in case of caustics, we can always get the upper GI endoscopy done. So these are so as such, lab studies are depending on the type of poison, and the levels are only specific in few cases.
Okay, thank you, Dr. Lilith. Very well said. The only thing which I will add is that when managing poisoning, remember one thing, that most of the children, particularly younger children, their poisoning is trivial. Adolescents may have serious poisoning. So there is always chance of underdoing or overdoing. So selecting a child actually which really needs a treatment is very important. Number two, treat the patient, not the poison. Some of the poison may be very toxic, but the amount ingested may be very small. So always focus on the child rather than on poison. If we follow these two principles, in addition to what Dr. Lalit has said, we'll be able to manage most of it. Now, I'll move on to Dr. Manish Gupta. Dr. I think somebody is...
Please mute.
I think somebody is managing a child with poisoning and doing a GI decontamination. Putting in nasogastric tube, that's why the child is crying.
I think some noise is coming. Okay. Dr. Suresh, should I answer this?
Yeah. We'll move on to you.
Okay, so as Dr. Suresh asked, what are the various methods to decontaminate? We must understand what is decontamination. See, there are basically two approaches when a patient has poisoning. One is you give antidote and treat already the poison which is there in the body. But here you have to decontaminate, and you have to prevent the ongoing exposure of the poison in the GIT, and you have to prevent further absorption of the drug. So basically decontamination is of three types. First is you can do eye decontamination, second is you do skin decontamination, and third is you do GIT decontamination. Eye and skin are clear. You just irrigate eye with saline, and if required, instill local anesthetic drops. In skin, obviously, you remove the clothes and do copious rinsing with soap and water. Now comes the question of GI decontamination. And our DMC President Dr. Arun Gupta also has asked in the chat box that what is the role of stomach wash. So I might answer it very correctly, and it cannot be legally wrong there. So various points of decontamination of GIT types are: you can do induced emesis, you can use activated charcoal, or you can do stomach wash or gastric level. Now, emesis has got very limited role, and that too at a center if it is too away from a medical setup. So hardly it has got any role in the medical setup. Then comes the activated charcoal. Now, activated charcoal is
I will
something.
request Rohit, Manish, just 1 minute. I will request Rohit, please mute. There's so many voices coming.
Rohit, can you mute?
Yes, Manish, continue.
Thank you. So activated charcoal, when it was not there 5-10 years back in India, there was a lot of enthusiasm that it will help a lot. But when it came, and lately few years, the studies have shown that it has got a very limited role in treatment and should not be used without proper indication. Like, unless patient presents within 1 hour of ingesting toxic compound, you should not use it. Plus, there are certain contraindications, like patients with altered conscious state. If a patient has taken ethanol, alkalis, corrosives, metals, cyanide, hydrocarbons, mineral acids, boric acid, in those patients, actually it is contraindicated. Gastric lavage again has a very limited role in treatment, and whole body irrigation also for certain slow absorbing preparations. So that is what you do.
Dr. Manish, I totally agree with you. As far as GI decontamination is concerned in children, the decision regarding GI decontamination is something like a decision regarding using antibiotic in a child with fever. Right? Like, you don't use antibiotic in each and every child of fever. Same way, we don't use GI decontamination in each and every child with poisoning. I will say that 90% of the children who come with poisoning in emergency room do not need any kind of GI decontamination. If you decide which method has to use, then you decide which one is to be used. And the most effective of all, human is relatively less effective, activated charcoal. And as far as gastric lavage is concerned, it's rarely needed. And next question is with Dr. Yogesh Prashar. What are the common household product poisoning in children in India? Dr.
Am I
Yogesh
audible?
Yeah.
So what the poison the child swallows depend upon where he lives. In Western countries, medicines, the pharmaceuticals or the products on the dressing table, the cosmetics and toilet products are more important. But in third world countries, pesticides, kerosene, cleaning agents are the commonest ones. Large studies from the Delhi area indicate pesticides, including organophosphates, organochlorines, pyrethroids, cleaners, which include the acid and the alkali corrosive materials, phenyl, thermometer mercury, naphthalene balls, kerosene, paint thinners, camphor, silica gel, hair dye are the common things. Amongst the drugs in our setting in India, anticonvulsants, including phenytoin, thyroid medicines, anti-leprosy drugs, anti-tubercular drugs, benzodiazepines, analgesics, oral contraceptives are the important drugs which are commonly ingested.
India is a
Talking
very
about talking about the National Poison Information Center, this center is run at AIIMS New Delhi. It is managed by the Department of Pharmacology. It provides 24 by 7 telephonic consultation to doctors who dial there. And it is useful because they maintain a very big central registry of all the poisonings that they calls that they get. So they are a good source of information. They can correlate the signs and symptoms that the patient is having with the probable poisons or tell us what is likely to happen to this child. They can give good guidance on the products which are available in India because the chemicals inside the various compounds can be listed. Their concentrations which are commonly present in our country can be told. If any antidote is required or what are the other management things that are useful in such a child can be told to us.
everyone can note down this number. This is 1800 This is a very useful number, and they work 24/7, and they provide reasonably good information which can be used while managing. India being a very diverse country, the type of poisoning which we see varies from one part of country to another part of country. North and south is different, east and west is different. Not only that, even in Delhi, West Delhi and East Delhi, South Delhi and North Delhi, you will find a different kind of poison. It all depends on social milieu in which the children are. Dr. Lavadi is there with us. Dr. Lavadi, what should the initial management of children who is suspected to have ingested or inhaled some unknown poison? Though many of the points are already covered by Dr. Lalit, but you can just
Yeah.
put them again.
Thank you, Dr. Suresh. Dr. Lalit has already said about few things, but I will just summarize them. So, initial assessment and triage, which means the first thing is to see whether it is symptomatic or asymptomatic. In asymptomatic, we need to go for a detailed history and try to find out the poison. In symptomatic, we look at emergency stabilization and looking at airway, breathing, circulation that has been highlighted. And once we have looked at that, once we have stabilized the airway, breathing, circulation, we are looking at two main things. One is the oxygen level, and second is the sugar level. So we look at hypoxia and we look at hypoglycemia. We try to correct it, and then once we have corrected these basic things, we are looking at the toxidrome. So I'll just briefly say that in this we look at toxidromes based on the mental status, vital signs, pupillary reactivity, skin color and moisture, and vowel sounds, and breath order in some cases. And broadly, there are 5 toxidromes we look at: anticholinergic, cholinergic, opioid, sedative hypnotic, and sympathomimetic. In this specifically, if there is any thing like opioid overdose, that means a triad of decreased level of consciousness, meiosis, and respiratory depression, then there is a role of using IV naloxone in the initial management.
Thank you, Dr. Alwale. Jim, remember that most of the time when I get a call regarding management of a poison, actually they ask me what is the antidote. But I will say we have only 20 antidotes, and no new antidotes are coming in. And there are so many kinds of poisoning. But luckily, most of the poisoning can be managed just with their simple sporty treatment, and most of the children can be saved even without antidote. So let us take few cases. This is a 2-year-old boy brought with the suspicion of ingestion of 3 to 4 camphor tablets while preparing for puja on a Diwali festival. And the child ingested around 30 minutes back. At present, the child is stable, except that he is complaining of little bit pain abdomen. Dr. Lalit would like to tell what is the time frame for developing symptoms after ingestion of a camphor tablet?
Sir, this child has taken 3 to 4 camphor tablets. It's quite significant because the toxic dose is 0.5 to 1 gram. So the time frame usually of developing the symptom in this child maybe just after 5 to 15 minutes, the neurotoxicity may develop. It is characterized by nausea, vomiting, and GIC symptom, and then it involves the CNS symptoms in headache, confusion, and of course the convulsion is very, very common. And ultimately, because it is excreted to liver and kidney, then it can damage that also. And usually, if it is the drug is excreted normally, this toxicity usually normally resolves in 24 hours. But we have to admit this child and follow up this child and watch for the symptoms. This child needs to be admitted, and then we have to deal with, because we don't have a specific antidote for camphor. So we will be again stabilizing the airways, breathing, and circulation, and we'll treating the child symptomatically. And usually the deaths usually in this occurs because of respiratory failure. It is very, very toxic, and commonly that puja preparation and these types of poisoning are very, very common. And normally their toxic dose is 0.5 to 1 gram. Usually per kg, if you say, it is usually 30 milligram per kg, and above that, it is very, very toxic. And also it is present in this Vicks VapoRub and other substances also.
Thank you, Dr. Lalit. So remember that camphor is toxic, but the metabolites of camphor are not toxic. So whatever the symptom has to occur, they will happen within 1 or 2 hours, maximum within 6 hours. And if the child is asymptomatic for first 6 hours, you don't have to keep this child for next 24 hours. This child can go safely home. Only if the child has symptoms within 6 hours, then you have to observe him for 24 hours. A asymptomatic child without any symptom can be discharged from emergency room after 6 hours. I think these 2 points have been covered by Dr. Lalit very well. Let us take another case. It's a 8-year-old boy brought to ER with vomiting and reduced consciousness by his mother. He had been in good health until he was found 30 minutes prior to admission unresponsive in bathroom. His younger sister, told that he was spraying fluid from a bottle while playing in the bathroom. And later on, the mother admitted that she has filled the bottle with some pesticide. So what are the various kinds of toxic compounds in the pesticide? Dr. Manish would like to tell us.
Yes, Dr. Suresh. There are various ways how do you classify pesticides, but a simple way would be like where the agent is actually acting. So you see, it may be a herbicide, it may be an insecticide, it may be a rodenticide, or it may be a nematicide, or it may be molluscicide. And if you see, for examples, like for herbicide, you have borax, nitrophane. For insecticide, you have DDT, BHC. Then for rodenticide, you have warfarin, zinc phosphide, nematicide, you have phorate and all. So basically, mainly insecticides are commonly what we have seen. In there, again, you have organocargamates, organochlorides, organophosphorus, pyrethrin, and those common things are there. And we all have in our medical work seen OP poisoning cases. So these are the main pesticides what you come across. And if you see in India, almost 10,000 yearly deaths are there due to pesticides in India. Then that is non-suicidal accidental exposure, 10,000 yearly deaths in India due to pesticides.
Thank you, Dr. Manish, for highlighting that pesticide is a very, very broad term. And many times a child is brought to emergency room with some pesticide injection. Most of us may think, okay, it's an organophosphorus poisoning. So be careful. Not all pesticides are organophosphorus. Only some of them are organophosphorus. So when a child comes with pesticide poisoning, just look which pesticide the child has ingested, because the management depends on that. Okay, pesticide doesn't mean giving atropine and pyrrolidoxime to each and every child, right? It may be some other pesticide, it may not be organophosphorus. Let us come to the case again. Vital sign of this child: temperature looks normal. He has a slight tachycardia. BP is also okay. There is tachypnea. Saturation on room air 96%. CRT is maintained. But further examination shows that child has pinpoint pupil, right? And there is hypersalivation, lacrimation, and you can see some muscle fasciculation happening. And child is drowsy but responsive to pain with slurred speech. And GCS was 9. On the chest, there are bilateral Bs. Dr. Manish, do you think there's some toxidrome over here?
Yeah, definitely, Dr. Suresh. And toxidrome, as already you indicated before, Dr. Alwadi also indicated, it is a big help for a clinician in dealing in emergency where you just have a certain set of symptoms. So let us see first what is actually toxidrome. A toxidrome is a syndrome caused by a dangerous level of toxins in the body, and the term was coined in 1970 by Moffenson and Grinser. And what it does is certain set of symptoms. If you see pupillary reaction, if you see temperature, if you see bowel activity, if you see secretions in the body, on that basis there are almost 6 toxidromes. You may have cholinergic symptoms, you may have opioid symptoms, you may have sympathomimetic symptoms, you may have anticholinergic symptoms, hallucinogenic or sedative hypnotic. And if you see in this patient, see the pupil size is small. If the pupil size is small, then you see what is the secretions and bowel movements and other muscle. In that basis, you come to conclusion these are hyperactive, so this is a cholinergic. So this is likely to be OP poisoning. Had it been hypoactive, then it would have been opioid poisoning. So this way it helps it. Other way around, if you see if the pupils are normal or dilated, then you see temperature. If the temperature is raised and again bowel sounds are hyperactive, then it is likely to be sympathomimetic group of this thing. And if bowel sounds are hyperactive, this is likely to be anticholinergic. Again, if the temperature is normal or low and bowel sounds are hyperactive, then this is likely to be hallucinogenic group of drugs. And if bowel sounds are hypoactive, these are likely to be sedative and hypnotic. So this is a flow chart I think we must place in our emergency rooms and in our casualties, so that immediately a resident can come across and follow this flow chart. This would be very helpful.
Thank you, Dr. Manish. So the purpose of toxidrome is to identify a toxin when the toxin is not known. If the toxin is known, then all the symptoms you attribute to that toxin, unless it's totally different actually. Okay. Right? So continuing the same case, Dr. Alwadi, do we need to do lab investigation like cholinesterase? In this case, we know this looks like a organophosphorus poisoning or cholinesterase, cholinergic kind of poisoning.
Right, sir. So
and
if
mother
the
is also
history
giving the similar kind of history.
Right. So if there's a clear history of pesticide being there, insecticide is there, and it clearly looks like a cholinergic toxidrome, then cholinesterase level is not required. So in a clear case, cholinesterase level is not required. Anyway, it does not help in management. If the case is doubtful, that there is no clear history and you are suspecting it, then you start the treatment, draw the levels and start the treatment. So what is available is a plasma cholinesterase level. And later on, once you have the levels, you can corroborate or confirm your diagnosis. But for initial management, it has to be a clinical diagnosis only. And in a clear-cut case, it is not required.
And what about atropine? How do you really use atropine in case of a organophosphorus poisoning?
Right. So in this case, the primary treatment would be a supportive care, oxygen, IV fluids. And then regarding atropine, once we know that this is an organophosphorus poisoning and we have to have for the anti-muscarinic action, we start atropine. It is given in a dose of 0.05 to 0.1 mg per kg. And it is to be injected every 5 to 15 minutes. And you titrate it to the secretions. So in the chest, you auscultate in the axillary region. And once the chest is cleared of the secretions, you don't hear creps, then probably the child is atropinized. And then you have to manage the case subsequently.
Yeah. So Dr. Alwadi very clearly pointed out that the problem which this cholinergic toxin is causing and killing the child are the secretions in the lung. It's not the constricted people which is going to kill the child. What is going to kill the child is wet lungs and hypoxia. So managing your airway, breathing, circulation is very, very important, right? So don't just rely on atropine. Manage your airway, breathing, circulation, and then give atropine. And keep on looking at the lungs. When the lungs are dry, it means you have reversed the cholinergic effects of the organophosphorus. And once you have reached that atropinization level, you can even continue a continuous drip. And how we do the continuous drip is whatever total dose which you have used for tokenization, 10% of that dose each hour you can give as a continuous infusion to maintain that tokenization. Right? Many people use intermittent dosing also, both works very well. Dr. Alwadi, are there any late effects of organophosphorus poisoning?
Right. So organophosphorus poisoning has acute muscarinic effects, and then in case it's a severe poisoning, then you have the nicotinic effects, which produce what is known as an intermediate syndrome. And in this intermediate syndrome, you have the muscle weakness because of the nicotinic effects. You have the proximal muscle weakness, you have the cranial nerve involvement, and you have the respiratory distress. And then in a severe case, and this intermediate syndrome lasts for somewhere from 24 hours to 2 weeks. And then in a severe case, beyond 2 weeks, you have a delayed polyneuropathy, which is the late effect. And this polyneuropathy is a distal muscle weakness, which will spare the neck muscles. And this is because of the inhibition of target esterase, and the effects can last up to 12 months. And there have been reports of lasting up to 5 years. So there is a definite late effect along with neuropsychiatric manifestations, confusion, Parkinsonian-like features. All that has been described in severe poisoning.
Thank you, Dr. So even if the child has reversed this cholinergic crisis, remember that by end of the first week or beginning of the second week, they may dip down again when the hypoxia starts happening because of respiratory muscle weakness or child not able to move the limb or neck weakness. I think because of lack of time, we'll just go on to some of the rapid fire questions. I know my panelists may excuse me because of lack of this time.
That's better.
Okay. Ingestion of oral hypoglycemic agent. Is the clinical presentation different from different classes of oral hypoglycemic agents like sulfonylurea or metformin or Lalit?
This sulfonylureas usually cause hypoglycemia, so symptoms will have hypoglycemia, whereas metformin is usually associated with the injury and which causes lactic acidosis. So that is how it causes. This is the difference.
Metformin is
hypoglycemia.
Metformin is a relatively safe drug as an oral hypoglycemic. It doesn't usually cause hypoglycemia, but in large doses it can cause lactic acidosis, not in normal doses.
Right.
Dr. Manish, which of these is most toxic? Deodorant, lipsticks, pencil, toothbrush, watercolor, nail polish remover, artificial nail remover?
So if you start from top to bottom, you can see the most risky is the bottom one. So deodorants, lipstick, pencil, these are risky but quite less. Mainly it is artificial nail remover. Actually what it contains, we have to understand, it contains straight acetone, that is acetone nitride. And what this chemical can do is it can cause nausea, vomiting, fatigue, and mainly respiratory problems it can occur. So that is what we have to deal with, sir. So most risky is artificial nail removal.
So nail polish remover and artificial nail remover, both these are totally two different kind of compounds. Nail polish remover will not cause much problem because it's like acetone kind of thing, will cause little drunk child actually, and the child will recover in 2 or 3 hours automatically. And lead which is there in the pencil is not a lead actually, it's a carbon. So no toxicity with that. What is the antidote, Dr. Yogesh, for beta blocker, calcium channel blocker, sulfonyl-induced hypoglycemia?
So all these are very toxic drugs and they can be fatal. Sulfonylureas, which is last on this list, causes very severe hypoglycemia, and the antidote is octreotide, which prevents insulin release from the pancreas and helps. For beta blockers, glucagon is the antidote. It improves the myocardial contractility and the heart rate. Besides, you may have to give saline, inotropes, and benzodiazepines if there are seizures. Calcium channel blockers are also very toxic. The treatment is a hyperinsulinemic euglycemia where you give high dose of insulin. You will also need again volume expanders, vasopressors, maybe calcium gluconate or chloride along with.
The reason why I brought this slide is like most of us may get an impression, okay, beta blocker, it means we give beta agonist to counter the effect. But remember, beta blocker have already blocked the beta receptor. So no beta agonist is going to work in that case. You have to go indirectly. That is, glucagon is the one which can activate the cyclic AMP. Same way, calcium channel blocker, high doses of calcium will not reverse this calcium channel blocking effect. It is this hyperinsulinemic hypoglycemia. Same way, sulfonylurea induced hypoglycemia, giving glucose infusion alone may not correct hypoglycemia. In fact, it may sometimes aggravate hypoglycemia because it induces further release of insulin. Octreotide is the answer for this. What is the most important investigation for this poisoning, Dr. Lalit?
Hydrocarbon, as usually the chest X-ray, we can get it. The findings are available after 6 hours. And salicylate, I told earlier also, you can get the blood levels done. Of course, ABG depending on the level of acidosis, the clinical manifestation. Caustic ingestion 12 to 24 hours if the child is stable, and also for the follow-up. And TCA, I just mentioned that KORS, the prolongation of KORS complexes.
So these are the most important investigation which help you in management actually. The reason I written this investigation because they help you in taking a decision. Hydrocarbon management all depends whether X-ray has got the finding or not. Salicylate, there are 3 stages. First is of alkalosis because there is CNS stimulation. If there is alkalosis, respiratory alkalosis on the ABG, it means a significant ingestion has occurred and this child is going to land up into problem. And second stage will be acidosis, and third will be mixing of the both the things. Tricyclic antidepressant, all management depends whether the ECG has got the finding or not. One pill can kill an infant. Which one of these can kill an infant? Dr. Alwadi?
Yeah, so already stated, sulfonylurea is very toxic and even a single pill can kill the infant. Paracetamol, we know doses up to 150 to 200 mg per kg would be required. Thyroxine up to 1 milligram is safely tolerated in children usually. And metformin, we have just stated only in very high doses, they cause lactic acidosis. So sulfonylurea.
So a 1-year-old infant, if he ingests one of these toxins, it may be quite a fatal thing. So you have to remember it is common mnemonic. A one pill can kill, and these are some of the drugs which can be very toxic to a 1-year-old child. It's not for the older child. So I'd like to convey all the my panelists for such a good discussion. Dr. Lalit, Dr. Manish, Dr. Yogesh, Dr. Wadi, for wonderful input regarding management of the poison. Thank you so much.
Thank you, and I thank all the panelists. And before I hand over to Dr. Nap and Dr. Smita, thank you very much, Dr. Gupta. Just want to add one thing. During the COVID epidemic now, the sanitizer toxicity is also coming. And the basic thing is it is not ethanol or methanol, it is the isopropyl alcohol, and it is very, very toxic. It can cause cardiac toxicity, and it is also a very important now household item, and it is really very toxic. Just I wanted to add.
Very well said, Dr. Lalit. Very well said.
So thank you very much, everyone, panelists. It was wonderful discussion. And Dr. Nab, just Rohit informed us that 5 to 10 minutes they would like to have before we go for our valedictory function. So that time we have to wait for. Rohit?
No, madam, Zoom, I had discussed with Rohit. Only issue is our Zoom and our third source, the platform, the login platform would continue. Only the YouTube link would be off for 5 to 10 minutes. So I think YouTube link, there are very limited people. We can do our validatory function. He will make a new YouTube link for the cultural program.
Okay, so Nikita informed me that we have
I had a talk with
I'm very
Rohit.
happy
I
if
think
we are going ahead.
Let us continue, madam. Let us continue.
That's a wonderful news, Dr. Manish. Thank you very much. So, Dr. Nab, I just start the proceeding for the valedictory function.
We are thankful to the Lalit Mehnirata and Dr. Manish. They did the scientific coordination part very well today. And I'm extremely thankful to Dr. Suresh for a wonderful, panel discussion on common poisoning. Our delegates must have been enriched with the knowledge. Yeah. Now I'll request Dr. Smita Mishra to carry on with the program.
So I'm really congratulating all of IAP Delhi team to perform so well in this PCNI and NIPID conference, and it was unique in its own sense.